Hello. Hello.
Check 1 2 3. Mic testing. One. Check 1 2 3. Check. Check 1 2 3. Check. Check. Check 1 2 3. Mic testing. 1 2 3. Check.
The session will start in 5 minutes at 9:30. I request all participants to please take the places.
A very good morning to respected dignitaries and all the delegates. The program will begin shortly. Thank you. In 5 minutes. I would also like to inform all the dignitaries and delegates that this program will be streamed live on YouTube and the link will be shared on your group, on your WhatsApp group. Thank you. Yeah, you can share it with your colleagues also. Thank you.
Good morning, distinguished guests, esteemed colleagues, and dear friends. I, Dr. Vivian Agdev,
I, Dr. Mayuri Saro,
welcome you all to this continuing medical education program on recent advances in cataract surgery. Today, we gather to explore the latest innovations, techniques, and technologies that are transforming the field of cataract surgery and enhancing visual outcomes. We wish to replicate this with a practical session of wet lab workshop. Your presence here is a testament to our collective commitment to this advancing medical knowledge and improving patient care.
cataract surgery has evolved significantly over the years, and recent advances have brought about remarkable improvements in precision, safety, and patient satisfaction. From the use of femtosecond lasers to advanced intraocular lenses, our field is witnessing groundbreaking changes. Today, we will delve into the developments with insights from leading experts who are at the forefront of these innovations.
Before we begin with our sessions, I request everyone to keep their phones on silent. Wet lab workshop is being conducted simultaneously. Notifications for the same will be sent on the group. We now begin with the first session of the day. We are going to dive into the significance of counseling in cataract surgery, exploring its impact on patient satisfaction and insights into perfecting phacoemulsification. I request Dr. Narsapur Sir, Senior Ophthalmic Consultant at Bina Eye Hospital, Vijayapura, and Dr. M.H. Patil Sir, former Professor, Head of Department of Ophthalmology, Shri B.M. Patil Medical College, Vijayapura, to come to the dais for moderating this session.
Good morning, everybody. I request Dr. R. Dr. Dr. R. Krishna Prasad to give his talk.
So good morning, and I'm really thankful to the entire BLDE team, Dr. Rekha, Dr. Sunil, and all my friends in the department and all the postgraduates for putting up such a great show. a great place and a nice ambience for a lot of interactions. And I'm really, glad that I'm here. So I'm starting the day with not with some video of a complication or some exotic, OPL video. It's a commonplace topic like communication and counseling in cataract surgery. Well, this is not a video on complication, but probably when you have a complication, this communication can help. Okay. So probably uh, we always see the complications in so many conferences uh, and how they are managed, but that is on the table. But obviously, the result is not always very optimum. So what you actually have to face after the complication is over or being managed, to the patient, to the relatives, and also in case of where things go wrong. So that is where this talk comes in. This is not for the senior ophthalmologists. They have evolved their own ways of salvaging this problem, and they have developed their own communication. It is for the youngsters. So majority of you are actually here postgraduates who are stepping into your field of domain of cataract surgery. This art of communication, art of counseling is a very important soft skill. Very unfortunately that for a long time, it's only recently it is the changes we have seen. There is no curriculum for communication. You never had a class, you never had exam for communication. You are never actually taught in kind of a wet lab. You are taught the cataract surgery in a wet lab, but there's no wet lab for communication, right? So you basically have to, build on your own trait, your own stick. If you're a good communicator, you have a good vocabulary. If you've got a good so-called the art of medicine, if you have the right kind of what you call as the emotional quotient, probably you can solve the problem of the day. And normally the good communicators get into less trouble. Okay, we always, create problems. We do not really exceed expectations. We always fall short of expectations of the patient. That is where we chip in. So this is a very light-hearted talk. Okay, it's a very interactive one also. We can actually have, so basically whatever you do, see, we put up so many hours and years and decades to learn a cataract surgery or any surgical technique. Okay, but if you can embellish that with a good communication, you can actually sell yourself better. Right. So many a times patient may not know all the good work that you have done. Okay. So, and also in case where there is some kind of a trouble. Okay. So what you need to do. So this is like a kind of a workshop for you all youngsters. Like I'll just give you some clinical tips. See, when the patient comes for surgery, okay, this is our standard, our experience. Even Dr. Arup will actually agree with me. When the patient comes, we do a topical phaco. Patient is extremely happy. Okay. Patient can see very well, no pain, absolutely fine. And he compares his vision to the previous vision and is able to do everything. And he thinks you're God. He says, I want the second eye. Okay. He comes for the second eye. But after the second eye is done, the patient is not happy at all. Patient says, sir, this was very fine. You took very short time. Absolutely, there was no pain. And I could see very well immediately. But this left eye, you operated second time. You took a long time. And I had a lot of pain. And I'm not able to see at all anything. See, why does this happen? See, this happens because there are two evils in your life. If you can avoid, you'll always be happy. That is, one is comparing, one is expecting. If you don't compare yourself with anybody else, you'll be very happy in life, right? Just think. Okay. Don't expect and don't compare yourself and don't expect anything. Don't expect anything from you, anybody. Like from your maybe your parents, maybe your spouse, maybe teacher. If you don't expect anything from anybody, you'll always be happy. Here, both the evils are working. How? See, when you come for the first time, you only have fear. You heard stories. So you don't know whether you'll cooperate. It may be very painful. Eyes a very delicate structure. You have your own doubts about the surgeon and yourself. So when you are having that much of fear, surgery happens very quickly, that too topical, and patient is extremely happy because you overcoming all the fear that he's actually able to, like you have delivered some result which he had never imagined because he never gone to an OT earlier. And also, this eye vision, whatever good or bad, it may be 612, it may be 618, it may be subnormal even, but he compares that eye with the other eye which has a cataract. So relatively, the right eye looks better because there's a comparison here. And now for the second eye, the whole thing will go topsy-turvy. See, now he is coming with an expectation. The second eye surgery, he comes with an expectation that it will be done very quickly, it will be painless, and he's going to see the moon, he's going to see everything. Now, when he come with expectation, you are getting into trouble. Okay. So, and also he compares the left eye vision, not with the third eye which has a cataract, but the first eye which is already operated and equipped and already seeing well. Okay. So the comparison is very unfair. So this is actually a problem. And believe me, this leads to actually heartburn, dissatisfaction, and patient keeps on telling, ಮೊದಲನೇ ಕಣ್ ಚೆನ್ನಾಗಾಯ್ತು, ಎರಡನೇ ಕಣ್ ಅಷ್ಟು ಚೆನ್ನಾಗಾಗಿಲ್ಲ. And that too, it happens when you have a monovision principle. Right eye of focus for distance and the left eye of focus for near. He doesn't care that. He's actually able to see the newspaper because of the left eye. He doesn't. He'll just check for the distance and he says, right eye I can see, left eye I can't see. So monovision is another set of problems. So when this is there, you please have to actually see through this. You will have to actually tell the patient. I tell the patient, the second eye all over the world will take more time, will be a little more painful than the first eye, and you will take more time to recover. Okay, whatever. See, you basically forewarn the patient that the patient is not able to see. See, I'll tell you as simple communication as, see, whenever I finish my surgery, at the end of the surgery, I always tell this. I will tell, you will not see well till tomorrow. By evening, you will feel a little better. By tomorrow, you will see. Why is this? Because a lot of patients, once the surgery is done, they get up from the table and they start looking for vision. Okay, they want instant. When you have actually under the microscope, the whole macula is bleached. They won't see anything immediately. The vision, even after a topical surgery, is not great. It will take some time to recover. The pupil is dilated, there's an inflammation. So patients have a tendency to check vision. So they will just say, I'm not able to see anything. They go back to the house and the daughter will call from Australia and say, what happened, surgery? Because she says, they got it done. Okay, but I'm not able to see. Next day, she may say 6-6, but the word has already spread that the surgery is not successful. So you tell the patient just a simple thing that you want to take time. So that itself is enough. Okay. And this is the worst part of the thing. Things go wrong. Okay. We do have complications. But the postgraduates are not trained to break the bad news. So many a times there's what called foot in the mouth syndrome. No, you will blurt out something that you will completely devastate the whole thing. Already the people are very suspicious of us. There's a media trials. People always want to, put the doctors at the gunpoint, and we're always under scrutiny for our, outcomes. So in such a situation, if something goes wrong, and we are selling a commodity, we are just a service provider. I'll give you this much money, you have to get me the vision. So when it comes to that, obviously you have to give good results. If things don't go wrong, then how will you break the bad news? Okay. For example, our patients and the relatives, they see a lot of movies. Okay. So typically, what is a operation theater scene in a movie? There's a closed door, there's a red light, people are moving here and there, are waiting. Suddenly, that door opens. The surgeon comes out, sometimes not wearing a mask or a cap, sometimes with a stethoscope, some funny thing. And he will deliver a judgment. He will say, बच्चे को बचा सकते नहीं तो माँ को बचा सकते, 24 घंटे में होश ना आए तो बस गई बात, whatever. Like some life-shattering, life-changing judgment comes after the door opens. So that image of a OT is always kind of linked with a bad news can emerge out of that. That is their point of vulnerability. That is where the patients or the relatives are prepared mentally to hear the bad news. Okay, I have 20 cases. My second case, there's a nucleus drop. Okay, or I'm not able to put the IOL, whatever. Okay, what I'll think, Aril, please send them to the room. I'll finish my list. I'll go sit and talk to them. And I'll discuss in great detail and explain and do the counseling for the future treatment. Never do that. Call the patient to the probably where the semi-sterile, sterile zone is there. Like you're wearing your cap, mask and gown. See, that is your area. You are your, area of your dominance. And that patient on the other side, so he's little submissive. No, that is not his place. And he's now mentally ready. You say like, we started doing the cataract surgery, the back support is not good, or something, whatever. Like you can do some white lies, whatever. And you basically say that you need another surgery. We need to fix up something at the back. We need to wait. I need to probably wait for another 3 months to 3 weeks to put another lens, or we need to customize the procedure. So whatever you're going to tell, you tell it there immediately, not later, because this will be held against you in the court of law. Tomorrow, even though you went after 1 hour, took 3 hours to explain what went wrong, he will say the doctor is, okay, he's such a brute that he didn't even bother to tell me something got botched up. He botched up my eye and he kept on operating others. He didn't have the courtesy to come and tell me something has gone wrong. For the patient, it's 100% fault. For you, it may be one case out of 20, but for him, it is 100%. So that will be held against you. So please use this and also know how to actually articulate. See, this is very important. Never try to use a language in which you're not proficient. You may be from, somewhere else. It may not be a local language. You try to explain the complication in Kannada or your Hindi, which language you can't really have words enough. So you may be miscommunicating. Always use a person who can actually fluently communicate and also use the right kind of words. So that's very important. And see, now the thing is like we want spectacle independence in cataract surgery. We are scaled the heights of cataract surgery technology, which we will probably learn in the rest of the day. So multifocals and trifocals have become the order of the day. We want spectacle independence for everyone. The literacy is not the criteria now. Everybody has gadgets, even illiterate people, they need to see clearly. And bifocals is not the way to go for old people. Okay. And a lot of people come with the confusion. They've heard stories or read in the media or internet, plus and minus of multifocals. And so it is very difficult. Whenever I ask a postgraduate, like for your father, what eyeball you're going to put? This is a very interesting question. I meet a lot of postgraduates, not mine. I mean, people from outside, they come for short-term trainees or just like that. I ask a question for your dad. Okay, which eyeball you're going to put? I get very funny answers. Their answers are so illogical. Okay, they know their father, but even then, they know the profile. But still, they say, multifocal. No, sir. Rings and halos. That's what they know, only rings and halos. They don't know the advantages of a spectacle independence and I know how much important it is, like how less important it is in a particular patient. So they don't know the present day world or how these actually have to be really understood. So if your patient is there, he will come and ask you, sir, what lens I want to, you should be inserting, monofocal or multifocal. So how will you explain? How will you explain to a patient? And whatever is the result, you need to actually stand by it. So for that, I give a simple idea for all of you, the postgraduates. Use the two extremes, clarity and convenience. So for a patient who can understand, give this option. Boss, you have two things. You have clarity and you have convenience. Okay. If you are using monofocals, you have very good clarity. See, monofocals give absolutely crisp vision because all the light is going to one particular distance. So absolutely crisp vision. You have absolute clarity. But there is a small inconvenience of wearing spectacles at some point of time at least, even if you're using monovision. So you need to actually be dependent on glasses at least some time of the day. So you forego convenience for your clarity. But if you, make your, convenience as your important thing, if you probably give value to, convenience of not wearing glasses, then there's a small loss of clarity. Don't make this big, okay? The small percentage. There's a very small percentage of clarity. You may have problem with night vision or sometimes, but most times you're okay, but there's a small. So probably when this is there, the patient actually thinks what is important for him. Don't overdo anything because he will definitely push to the other side. Because even if he comes as I'm seeing arrows, okay, not of them will actually disappear with time. But you can say, so you chose convenience, right? Now you are spectacle free. So there's a small, loss of clarity, which will again get all right with time. Or the patient comes there, why are you prescribing me glasses? You say you chose clarity. So there's a small inconvenience. So these two things will probably make you understand like how to actually choose a particular patient. And also you involve the patient in the decision making. And this is something I'm very, okay. See, all postgraduates before starting their practice should have an idea about counseling. You should actually meet patients, talk to them, try to, sell yourself. We always undersell. In India, we sell the, lens brand rather than the surgical skill, unlike other specialities. Okay. Our packages are mostly dependent upon the brands rather than the surgical skill. Okay. So here it is very important that you actually make the patient understand that surgery is very important, not the brand. At the same time, you also should know what the lens will do to you. For example, there are a lot of patients, if you really see in our practice, around 30 to 35% of patients actually need toric intraocular lenses. Toric intraocular lenses are basically for, okay, the astigmatism correction. And if you do not really correct them, the uncorrected vision, you are actually doing an injustice. Okay. But we don't see 40% of patients getting torics because toric is a different package, is an extra money, and most patients say, I don't want. So how I counsel a toric patient? See, normally I get my biometry done. I know the astigmatism before anything else. So when the patient comes, I say, boss, you have two problems. One problem is you have cataract, which you know. The second is you have a very crooked cornea from childhood. Okay. Teda hai, par aapka hai. So cornea is teda. So you have around 1.5 or 2 diopters of a teda cornea, by which that's why you are wearing that much of astigmatic, correction that you are wearing, cylindrical number. If I do a cataract surgery, however good, this tedapan will continue and you will have to wear 2 diopters of lenses to see things clearly for even for distance. So now we have an opportunity to correct this old problem also. By just changing and customizing the lens, I can solve this astigmatism, which is an age-old problem, along with cataract. So now what happens? See, the table turns. Now this astigmatism is patient's problem, not yours. You are not actually. So if your patient says, I don't want at all, if he's so foolhardy, then you can't convince him. Like if a patient said, I can't see for distance, they say, you said you had 2 diopters, I told you. We can correct this. Now wear glasses. See, it also doesn't make financial sense, right? The patient spending money for the rest of his life wearing cylindrical number doesn't make financial sense for an small extra amount that he's paying for toric. So toric lenses are not premium IOLs, which is a misnomer which is peddled by the industry. It is a basic necessity. If I have astigmatism, you are correcting it, you are not doing a great favor on me. It is my right. It's my right that you convince me about this. If you don't convince me, okay, you are putting me into a disadvantage of not seeing things clearly with that astigmatism. So it is on us to convince the patient that both the problem, that is the technology, you need to take care of that. No, money is not everything. And lastly, this is my last thing, end of. See, this is the worst thing that can happen to a cataract surgeon. Very disastrous, very demoralizing, especially for a beginner. It can be really, really bad. Okay. But please understand, it's not end of the world, right? So very importantly, it is not science. You know all about EVS study, you know all about endophthalmitis protocols, but you are very bad at the art of managing endophthalmitis. No postgraduate is actually in the scene. Normally they mess it up. So please understand how things turn out. So please accept it. It is not TAS. For me, any reaction more than what it should be is endophthalmitis unless proved otherwise. Not just to say in reality. I always take it as endophthalmitis. There is no TAS. You're always asked a question, difference between TAS and endof. TAS is not that common. In a good quality practice, you don't have TAS. Okay. Endofs can happen. Okay. Please fall in line. And be very, very, expeditious in what you do. Don't sit on the patient. Every hour matters. So what does the patient think? Patient has come to you with a lot of hope, has paid you a lot of money, with a lot of expectation, but he sees nothing now. He is a breach of promise. You have basically botched up the surgery. That is what they write. And he also has pain, discomfort. So basically he thinks that you are not a good surgeon. He actually judges you on the basis of endophthalmitis on which you have probably no role, right? So this is something very bad. The surgeon can't stomach this. So you have done everything in good faith, but patient says you are a criminal, you are useless, and you have really botched up my eye. Give me the money, I'll go to the court. So how to handle? When you have a busy OPD, please tell all your OPD assistants, reception, anybody says I got operated 5 days ago, I'm not able to see from today morning, quickly ferry them in. Don't say there's no appointment today, no doctor is going for lunch. No such thing. It will all be held against you in the court of law. Patient says, from morning 6 o'clock, I've been waiting in his clinic with pus and pain and all that problem and loss of vision. He didn't care. He just went over me, stepped over me and went out. Okay. So please take care of them and make it private. Don't discuss in front of other patient. If you have another patient, don't discuss that and let him not keep on telling sitting in the OPD room that he got operated, he's not able to see at all. You should show compassion. At the same time, don't panic. Don't bend backwards. You're not committed a great crime. You're not, there's no criminal intention in this endophthalmitis, as the patient thinks. You wanted to do good. Okay. So don't be so panicky. Ask the patient, when did the blurring start? Like we do topical phacos. Patient actually sees pretty well the days, evening or next day and even subsequent day. For all the PGs to understand, even if you introduce bacteria into the eye intentionally during cataract surgery, patient will still see well for few hours and days. Because this bacteria, the anterior chamber is very hostile to bacteria. They won't thrive in the anterior chamber with aqueous. They will have to gain access to vitreous cavity. That is a culture medium. That is a safe haven for microbes to proliferate and the inflammation to start. So the vision drop happens when the vitreous gets involved, not they don't proliferate in the anterior chamber. So this transition from the anterior chamber to the vitreous cavity can take 1 to 2 days, maybe even more. If you have created a PCR and zonal dialysis, it will be very quick. You open the highway. Otherwise, it will take 2-3 days for depending upon the virulence of the organism, depending upon the inoculum, the amount of inoculum, and the patient's innate immunity. Right? So patient sees for day 1, day 2, and day 3. So ask the patient, did you see on day 1? Patient says, yes. Next day, yes. Third day, yes, sir. Third day also I saw. In the night it started. What did you do actually then? Did you rub the eye? Did you cough? Did you sneeze? Did you not put the drops? What happened? Patient will always think, I think I skipped the medicine. I put this instead of that. Or I sneezed. So he will connect something. No, his imagination very fertile. He'll imagine. Because if you have botched up the surgery, you will not see anything post-surgery. But you saw for 3 days. That means your surgery must have gone well. Something must have happened later, no? So this small kida in his head is enough to kind of shift the hostility and start thinking there is some contributory negligence from my side. Or there may be some external factor, not the surgeon. Dr. Sunil did a good surgery because I saw for 3 days. Right? वो 3 दिन की बाद कुछ हो गया गड़बड़. So patient start, see, you're basically, this is the actual reality. You're only asking him to look into that dimension, which actually changes the whole perspective of the patient. And as I told you, never use the word infection. It is not in your vocabulary anymore. So what happened? My PG is unsuspectingly seeing a patient and he will say, kya ho gaya? Say, infection ho gaya. See, infection, pus, septic, all mean that you have not washed your hands properly. You have done a very unhygienic surgery. You have created infection. Means infection is on us. There's an operation where there's an infection. That means it is a surgeon's responsibility. You don't use word of infection. You say, what happened? It's a reaction. Endophthalmitis is also a reaction, right? So reaction is different. It doesn't really, it's not very specific. And don't get agitated. Don't panic. Wait and take the hostility. Most patients are hostile. No, they deny, then they're hostile, their aggression. And slowly they actually fall in line and things do happen properly. Natural course is, I told you, patients accept. If you are really judicious, if you are expeditious, if you are doing things, and if you are not using the wrong words, then things, hold on to your nerves, everything will be. And India, we don't really have so many litigation problems. We don't have so many unemployed lawyers waiting for these patients. So it doesn't really happen that way. And lastly, can we win in case of endophthalmitis in the court of law? Yes, we can. Most of the patients, most of the lawsuits have gone in favor of the doctor. I'll tell you why. But even then, it is important to prevent a medico-legal case, because we are a foreign thing in that. I mean, those people can actually afford to go every day to the court. We can't go. And it's a waste of effort, resource, and it's actually in bad light you will be put. And anticipate that and be prepared. Very good advocate is important. Just like a good cataract surgeon, don't go to an advocate who's your friend. Go for a best advocate and documentation. See, whatever is not documented, you're an NABH institution, you will understand, it is not done. You would have done the best cleaning, best disinfection, best sterilization. If it is not documented, it is not done. So law is the slave of evidence. Unless you show it, it is not done. So even if you have not taken a consent, patient will say they forcibly took me to the OT and operated. So it will be held against you. So please do that. So finally, endophthalmitis, as I told you, it is a very serious problem. There are a lot of signs of endophthalmitis. Even prevention of endophthalmitis is a big chapter by itself. And how do you manage an endophthalmitis? But not using the words like infection, not, trying to show too much of agitation, that you're showing the guilt that you have actually messed it up. At the same time, doing the right thing immediately. Now, don't wait. Like if you give an intravitreal injection, examine the case after 6 hours. Don't call him after 48 hours. Okay, and early vitrectomy. Today's 25 gauge vitrectomy, 27 gauge vitrectomy is a miracle. We have never lost a patient, in the vision as the eye, if the patient has reported early. Okay, if there's a excessive necrosis of retina, or if there's a corneal involvement, and a bad case, late patient is different. But any early patient. So I have one, submission to all the postgraduates. One thing that you tell to the patient when they go home. See, you see a lot of patients, you operate a lot of patients, but post-op advice, one important advice to avoid a patient coming late with endophthalmitis that you can't salvage the eye or the vision is ask the patient to evaluate their vision every day. Not with a Snellen's chart. The patient normally will have some clear cornea by 2 days. No, he can close the other eye, see whatever he's seeing. Like he's seeing that calendar. Every day morning, he is to check that. He should at least see the same thing, if not better. The day he stops seeing that, he has to rush. The drop in the vision is the event which marks the involvement of vitreous cavity. That is your endophthalmitis. So drop in the vision, not redness, not pain. With the steroids on, all they may not be there. Very, very soft signs. But the most important, unmistakable sign is drop in the pre-existing vision, which actually heralds the onset of endophthalmitis. If the patient can rush immediately, you can save the eye and prevent all the problems. This is a very important communication, probably the most important communication that you can avoid all the heartburns. Thank you very much.
Thank you, KP. Session is open for questions, discussions.
Everybody has a thing to add. I think all the cataract surgeons here will have an anecdote, will have a piece of advice. I've just compiled a few, which in my judgment would be the ideal thing. So I think, yes, sir. Yes, madam.
Sir, do we need to explain all the complications which happens after the surgery?
No.
When
See,
we
it's
take
not
a
like
consent,
you.
then they will go to the other
See,
side.
this is a very balanced thing. See, it's very important that, see, in the US, you go to Australia, there is so much that you need to sit and see. When things go wrong, all these are raked up. When things are happening fine, whatever you are doing will go away. Okay, will not be considered. We normally ask the patient to sign under the dotted line. Whatever you have written, patient will never read. Okay, but patient can say that they never made me explain all this. They never explained all this. They made me sign on the thing, which will be held against you. So the actual consent which stands in your favor is a video documentation of your consent. I am talking to the patient in the patient's language. Patient is saying, yes, I can understand. Are you understanding? Yes, he says. It is documented on a video. You show it in the court. I told him, no, see, there's a video document. Okay. Now all crimes, only CCTV things are shown in the TV, right? So it's all CCTV. I have a CCTV. And there are doctors who actually record their entire proceedings of their OPD, OT on CCTV for archives. You'll never know when this will be on you. But in India, it is not that great. But at the same time, you also have to, just like you can see some patients, no? Some of them come in good faith, but some profiles are little litigant. Somebody is an advocate, somebody is advocate's brother or father. So you know that this patient, because he goes to court every day. That is his profession. We can't go to court every day, right? So you try to be clear. At the same time, whenever there is a straightforward case, you don't have to explain too much. But if there is some kind of a problem or you're expecting subnormal vision, you should be very clear. Like, for example, you have an advanced cataract. You have an advanced cataract. The pupil is not, I mean, it may not be very great, or the pupil may not be very brisk. Okay. And patient thinks that you're going to get him all the vision. You may do a B scan, it may show anechoic vitreous, but it doesn't say anything about the status of retina or the optic nerve. You may have a disc pallor, you may have a macular scar. B scan only show there's any vitreous is clear or not, right? Or an optic nerve cupping. So you need to explain, even though B scan is clear, you may not get any vision because we have not seen. So unless you make them understand this, in case in such a patient, you can write down on the paper, okay, since I have an advanced cataract and the posterior segment cannot be evaluated, there is a possibility of subnormal vision, and I duly understand this. I've been explained in my language. Get a signature. So you know specifically where you can go wrong. So in India, right now, we are not having that kind of a problem, but very soon we have to be probably 360 degrees ready. So consent, see, if you don't have this consent, anything can go against you. Okay, your subnormal, your suboptimum outcome in cataract surgery. Okay, all these things. So communication, see, but if you explain the patient clearly in India, normally things, because I told you, no, see, patient is not that criminal minded. Since you have not told there is a problem, 99% of patients, if you have clearly communicated, they don't go to court. I told you, no, sir, say. So that's why I say, when you have a mature cataract, we have protocol. I see the post on the, before I sending the patient, I do an indirect consent. Who knows, patient may have a disc pallor, may have, CRVO. Okay. So immediately I can say, not after 1 week. Otherwise, if there's a CRVO in a mature cataract, I've not seen and sent the patient seeing only anterior segment. Patient will come after 1 week and say, I can't see. In 1 week, he has tarnished my reputation. He has told 1,000 relatives that I saw, I did the surgery, nothing has happened. And also, if he comes late, he may come up with an NVG also. With the CRVO at the back, with the cataract surgery, will trigger an NVG. Right? So you see and say, see, you had a mature cataract, you have a problem. So that's why I said around peri-operative period is the most vulnerable period. Not later. After 1 week, when the patient comes, he's already armed with all the kind of support system and the kind of vengeance, arrogance, and also the audacity. And also he's very sorry that he has come to you. So he also comes with a lot of, anger. So better tackle him then and there.
Sir, if endothelitis is
even if you put 1 lakh lens also, after 10 years,
I think
vision is
these two
going
should be
to-
dissociated. The cost of the lens is
Because in our place, depending on the cost, they think vision is going to come.
yes.
Because it different in a different place. So where we are practicing, and diabetic patients, it's better to say, even if 1 year duration, in future at least you have to have a posterior segment surgeon. With
See, I
lot of
train my
patients.
counselors. I
Beginning
teach
like
them
that.
very simple thing. For all of you, it probably is very helpful. Patient will always ask one question after all the counseling. They'll say, sir, yav lens hakskobeku. So which lens I should get it? And you only tell me, because I don't know, you told all this. What will you say? If the counselor is confronted with the question, you tell me which lens I should undergo. Some counselors are not, they're dumb. They will say costlier one, or they will ask for a bigger package or whatever. That is not right. I say very clearly. Okay. For example, Dr. Sanjeev Kulkarni is operating. This patient, I am the counselor. I will say, don't worry, get any package done. Dr. Sanjeev is operating. You will see very well. I am promoting Dr. Sanjeev, not the lens. See, he is an excellent cataract surgeon. Whichever patient he operates, whichever lens he put, the patient always sees well. But, I'm not done it. But This surgery happens once in a lifetime. Okay? Tomorrow you can't come and say, I wanted that. So think, don't hurry your counseling. It's a lifetime thing. It's like a marriage. Okay? So think, take your time, and you say, we go with your budget. I use this. It's an open-ended question. Go with your budget means, because I can't really understand what is his budget looking at his clothes. He may be having, he's a multi-billionaire, who knows? He may be wearing a dirty dhoti, but doesn't mean that he doesn't have money. Okay, so you say you go with your budget. It's a once in a lifetime. So take your time. Jitna paisa aapke paas hai, you're spending only once, that too for you. And I have one more talk where most of the old people who come for cataract surgery actually have money. They don't spend for cataract surgery. In Indian poor people die rich. All the money is in the bank. Somebody who says, please, 10,000 operation maabidri, 5,000 maabidri, leaves 50 lakhs in his bank account and dies. So they have austerity mindset. They have never spent for themselves, not even for their healthcare. And we, being in ophthalmology, have always created a charitable poster for our ophthalmology, where patients don't want to loosen the strings of their wallet. So here you say, see, you have done so much in your lifetime for your kids. Okay. Now, at least this is the time you spend for yourself. Vision is everything. So one or two such, emotional blackmail can actually make them go back and think that I have money. Okay. So because I'm saying it's not a business sense. I'm saying you're also doing disservice to them when they have money and they get a substandard surgery, a substandard eyeball, or they wear glasses post-surgery, or wear, get a non-toric eyeball. It is a disservice to them, and it's an injustice done to them, even though they have money. If they don't have money, it's okay. They have money, getting a substandard service for a lesser package actually is their loss, and you are responsible.
Sir, if endophthalmitis occurs, whom to refer, when to refer, who will bear the cost?
Okay, this is a very interesting, important question also. Okay, see, ideally, you should have a good vitreoretinal friend. Okay, and there has to be some understanding. This is very important. See, when you have a problem, immediately send. See, when you have an endophthalmitis, a proven endophthalmitis, give an intravitreal. This is period. No question, no second question. Before sending the patient, even in the same city, you give an intravitreal, because your treatment has to start right now. That intravitreal will hold the things in control. It will not cure it. But if you see the vitreous exudates and don't put an intravitreal injection, then you are going to, your results will not be very good, even in an excellent setup also. Give intravitreal, refer the patient. And always make that referral very smooth. Call the doctor, he should be received, they should be ready, and always nudge for an early vitrectomy. And vitrectomy, obviously, vitreoretinal surgeons, it is a very cost-intensive procedure, but ideally, patient should not be charged. Ideally. Okay. So there is some other way of, and not that even our colleague has to bear it, but at least some understanding has to be there. But if you charge the patient, actually it is not really bad also. You can actually, that's why what you say, all other cataracts you charge 2,000 more. The extra money you collect, you spend it on this patient. Crowdfunding.
In a vault. Suppose lesser package and more packages. Post-op, both will have the same vision. And they go on discussing, ki, I am also seeing better, you are also seeing. Okay, I spent more, I would have rather spent less on. So what is the solution for that?
See,
do we
patient
segregate?
mixing and matching in the OPD pre or post intraop is actually a very bad thing, because there are some very happy patients. They're happy always. Even with an upper lens, they're very happy. And there is here a pantoric patient, panoptic toric, who is unhappy. See, this is important. A happy patient is a very wrong concept. I cannot make my patients happy with my cataract surgery. Patients are happy, they're happy. They're happy as such. So unhappy patient, whatever surgery you do, the best vision you get, they'll be unhappy. So patient comes and says that I'm not happy, is not your problem. Understand that. Don't take it to your heart. Patient's happiness is not your problem. They're happy anyway, or they're unhappy anyway. That small thing, say, there's what's called a happiness set point. Each person is happy or unhappy at a particular level. If something good happens, they go up, again come back to that level. If something bad happens, they go down, again come back to that level. If the patient has a very high happiness set point, he's a good patient. Even with endophthalmitis, he will still come back to your second eye. He will still send his spouse to your surgery. Okay. If somebody you will get a best result for him, an unhappy patient will go up for a short time, again he'll come and start creeping. There'll be always 100 things to complain. So when a happy patient and unhappy patient meet in the OPD, you have had it. Okay.
Thank you, everybody. We'll continue discussion later on. I invite Dr. Arup Chakraborty to give his talk.
Yes, till my slides get ready. So regarding the second eye syndrome, what KP had just mentioned, I mean, I had just about a week or 2 weeks earlier, I had operated on an Ayurveda doctor. It was actually, surgery was happening in Varkala, which is about 50 kilometers from Trivandrum. He had a very hard eye. He was an Ayurveda doctor. And after I finished surgery in one eye, he says, my brother is an ophthalmologist, so and so. He's a very well-known ophthalmologist in Kerala. End of the story. Second eye, he came next week. And then after the surgery, immediately after the surgery, there was a havoc and everyone told me, please go and meet him. Then he said, you're not Dr. Arup Chakraborty. I said, I'm the same person who operated on the... No, you're not. First, I took such a short time and, I did not experience any pain and all that. Then I said, okay, I'll put my mask back. Because usually we are all the time masked on, still he could not recognize me. He went back with the belief that it was a different surgeon who had operated on his eye. But anyway, his vision improved and he came to Trivandrum. Just, we had a good chit-chat session. All right. So second eye, you have to be really, very careful about how the surgery goes. Now, good morning to all of you. And thank you, Dr. Rekha, and for the Vijayapura Ophthalmic Society for giving me an opportunity to be present here today. And see, in life's journey, we make many transitions. Some are major transitions, some are small, minor transitions. In my journey as a cataract surgeon for about last 37 years, and as a phaco surgeon for last 32 years, I have made 3 major transitions. One was intracapsular cataract surgery to extracapsular surgery. Second was extracapsular surgery to SICS. And third one was SICS to phaco. And I think the third transition, it is like Renaissance. I mean, it has changed cataract surgery like anything. And there have been few minor transitions. For example, when I was in a big institute, so when I started private practice, so that time it was the era of rigid lens. So I started using foldable lenses. So rigid to foldable lenses, scleral tunnel to a clear corneal incision, and peribulbar block or retrobulbar block to topical anesthesia. These I would say very minor transitions. And as regards transition, in life, so yesterday when having dinner, that 90% of the postgraduates were females. That is the trend all over the country. So if you have not already undergone the very major transition in your life, or you'll be undergoing it soon, I would say that these kind of transitions are very, very simple to negotiate. I can talk about my mother. So like in the late 50s, she made a transition from Banerjee to Chakrabarti. She shifted from Bihar, Darbhanga district to Kolkata. It's a major transition, but the transition that I'm going to talk to you about are relatively easy to effect. So topical anesthesia, when I was thinking of, when I set up my practice in Trivandrum, that I have to start doing it and the patient should not be affected. So it was easy for me because as a consultant, I was operating a lot of patients who had no akinesia or no anesthesia. The eyes, they had been blocked, but effect hadn't taken, and we could finish off the surgery. Likewise, if there's any difficulty being encountered by any of the trainee surgeons or junior surgeons, and I used to go and used to complete the surgery without any additional anesthesia. So I think this experience, helped me a lot when I really shifted to doing topical anesthesia surgery. So let me tell you my thoughts on this. See, why should you convert from a surgeon who is using needle anesthesia to topical anesthesia? So I would classify patient-related factors and surgeon-related factors. See, from the patient's point of view, if you have done under topical anesthesia and if everything has gone off well, your patient selection was good and everything has fallen in place, patient has immediate visual rehabilitation. So there is very small latent period. Eye is usually quieter because you have not given a block, and these eyes generally are not white and quiet postoperatively. And this is one of the results for a better postoperative cosmesis. Problems like postoperative ptosis or sometimes chemosis or subconjugal hemorrhage. Subconjugal hemorrhage can also be seen under topical anesthesia, but it's not to that extent where we have a retrobulbar hemorrhage which comes forward and gives the patient a red eye. Then, of course, you eliminate the chances of, or the ocular or periocular trauma, retrobulbar injection, some of the life-threatening and sight-threatening complications, so on and so forth. And some patients are scared of needle prick. They say, we do at all costs, doctor, I don't want to have a needle prick. So these are some of the factors which patients expect from us. And we should help them by doing surgery under topical anesthesia. Now, for the surgeon also, it is beneficial in many ways. For example, when I'm doing the capsulorhexis, I ask the patient to fix it on the light. So my rhexis become more centralized. If I want to make a rhexis which is centralized, which is centered on the corneal reflex. Then again, in a very deep set eyes, when I don't have proper access to the eyes, so if I tell the patient that please look nasally now for my temporal incision, please look inferiorly for my superior paracentesis, and gaze superiorly for my inferior paracentesis. So it becomes much easier for us. And then, you are always operating on a normal intraocular pressure. For a certain period of time, of course, when you're doing, phacoemulsification, the IOP goes up. But today we have machines which are supposed to keep the IOP under relatively, good control within the physiological range. Then you have the ability to comply with the patient request. Some patients would like the surgeon to take a pause, they want to cough and all that, so that is always possible. Then other factors are peer pressure. When you find that all your friends have started doing topical anesthesia surgery, you don't want to be left behind. And it should not be considered as a status symbol. Like I see in the social media that I am a 100% topical surgeon, and I'm 90% topical anesthesia surgeon. It is never like that. If there are certain days when I'm 100% injection anesthesia surgeon, there are certain days I'm 100% topical. It all depends upon the type of patient you're getting. Supposing if you're getting a very uncooperative patient, very difficult eye, with your experience as a phaco surgeon, you can do a good job. But then the patient will definitely remember you as a surgeon who gave him a lot of pain. The intraoperative period became memorable because of the pain and because of the discomfort that the patient had to encounter. And that is not a very good way to remember a cataract surgery. You may not have the even opportunity for the second day surgery. Then, of course, it is a career milestone, like the way I'm telling you now, that there's a point in time when I did not use peribulbar, when I didn't use topical, and then it's a milestone. It was a transition in my life. So that is it. So now, what is the trend like? In India, we don't have that much of statistics, which you can rely upon. So basically, this was a JCRS article published in March 2021, and Europe, for example, EuroQ. So from 10-year study, 2008, only 28.1% of the cataract surgeons were using topical anesthesia. 2017, it became 71.7%. Now, this was another article which was published about 6 months back, same journal. Again, if you see the blue line here, so it increased from the percentage of surgeon doing topical anesthesia surgery increased from 30% to 76%. However, there are certain things that have to be kept in the mind. The patients who had surgery under topical anesthesia had higher incidence of, which is statistically significant, higher incidence of PC dent with or without dropped nucleus. So that is to be kept in the mind. And then there was also a higher incidence of endophthalmitis in patients where surgery was done under topical anesthesia than under regional anesthesia. You can clearly see the p-value here. So these are debatable why it happens, but these are just measured retrospective studies. So we cannot really interpret and in the way that in individual surgeon's hands what is happening. But it is important to be kept in the back of your mind. Now, topical anesthesia is not for every case. Every case of cataract surgery, that cataract patient that you come across is not fit for cataract surgery, not fit for topical anesthesia. So as I mentioned just now, 100% topical surgery is just a myth. And sometimes, you can elicit more cooperation from the patient if you do surgery under the monitored anesthetic care. So whenever I say topical anesthesia, I always have an anesthetic standby. Patient is being monitored. And in certain situations, I also supplement topical anesthesia by intracameral anesthesia. So usually it is a combination of topical and intracameral anesthesia. Now, how do I select the patient? I said that, not all patients are fit for cataracts for topical anesthesia surgery. So basically, it starts in the preoperative period. When you do all those investigations on the patient, like Goldman impression tonometry, gonioscopy, indirect 90D. Earlier on, we used to do eyelash trimming. We don't do it now. Syringing. So at that time itself, you realize that patient doesn't open the eyes. Patient has a lot of blepharospasm, photophobia, and they may not be hence a good candidate for surgery under topical anesthesia. Then certain patients, of course, as I mentioned, they have fear of the block, so they ask for topical anesthesia. So in those cases, though I have to go extra way, but I still would take them under topical anesthesia. Usually, patient with significant comorbidities, like COPD, coronary artery disease. Anytime the patient can lie down for a long period of time, has to get up. So I would not do under topical anesthesia. I do a injection anesthesia for them. Communication barrier is classically, if a patient is a deaf patient or speaks some other language, so it is definitely a barrier because all the time we are supposed to be talking to the patient. But here, another thing I have noticed that many patients where patients doesn't hear, a patient has dementia, a patient speaks some other language, but still, even operating, I don't feel as if the eye has not been blocked. It is absolutely still eye. It is not moving. So it is a patient-to-patient decision. So I just cannot say that this person I cannot take up under topical anesthesia. Surgeon factors like you cannot. I mean, there has been a myth that you need to be a very experienced and senior surgeon, giving consistently good surgical outcomes, confidence in your surgical skills. You take about 10-15 minutes to complete your cataract surgery. And usually it is a case of mental block. Somehow you don't have the confidence to abandon the injection and start surgery under topical anesthesia. So these are some realities which you really have to overcome. But finally, a final decision is taken on the surgical table. When I put the patient on the table, sometimes the nurses do the decision on my behalf. Patient doesn't have any blepharospasm. There's no significant Bell's phenomena. All patients will have Bell's phenomena, but it should not be a very bad situation where the whole eye disappears under the upper lid. Patient should be able to fix it on the microscope light, and patient should ideally be able to follow verbal commands. So if these criteria are satisfied, even if the patient has a very challenging case, for example, small pupil or a black cataract or a white cataract, I'd still take them up under topical anesthesia. And there have been instances also have a very easy case, well-dilated pupil, soft cataract, but patient has been so uncooperative that I had to resort to a needle anesthesia. So how do I go about it? So today, as the patient comes into the operation theater, 1 drop of Oroken goes into the eye, and then patient lies down on the table, betadine drops go. Patient is assessed for your suitability for topical anesthesia surgery, and then betadine goes into the eye. Please do not put betadine into the patient's eye before ocular surface has been anesthetized, because betadine is quite an irritant, And then another drop of Paraken drop is instilled in the patient's eye, and then I go and scrub. Before Paraken came into the picture in the Indian scenario, we were using 4% xylocard, then 2% xylocard. These were epitheliotoxic. Paraken is also epitheliotoxic. So don't abuse these surface anesthetic topical agents, particularly in diabetic patients and some of those patients with ocular surface disease. If you apply these drops more than 3 or 4 times and these patients keep their eyes open, when you start the surgery, if you feel that there is a lot of haze, you cannot see through the epithelium. And then of course, there is certain situations I mentioned of intracameral anesthesia, lignocaine. Then now we have a combination cocktails available with us, T Ultra and Phenocan Plus. These I'll be talking about when I talk to you about IFIS. So these also are kept in the standby. So as I start the surgery, so I start off with the dimmest illumination, 0.1. And I only step up to 0.2, and then during nucleus removal, go up to 0.3. I don't use any higher illumination, because higher the illumination, more will be the patient's photophobia. How do I fixate the eye? I have seen surgeons using the gloved finger to, apply counter pressure on the opposite limbus to fixate the eye. But, I just use a closed tooth forceps. One could also use the Johnson's bud. But if a patient has a conjunctiva which is loose, sometimes you may have bleeding, subretinal hemorrhage may come up. Make sure that the blades that you use are quite sharp. Use dispersive OVD, 2% HPMC on the cornea to keep the cornea wet. There are certain situations when the patients will appreciate pain. For example, when you tend to enter into the patient's eye, if there is a very tight fit between the phaco handpiece and the incision. And certain situations, for example, myopic eye or post-vitrectomy eyes, when the AC becomes absolutely deep when irrigation comes on. When you rotate the nucleus during IL insertion. So these are the steps where I have a dialogue with the patient. I tell them that, there may be some stretch sensation. So please don't panic, don't move, keep still. Another situation where patient has to be informed before we perform that step is when you inject intracameral anesthesia, because that stings. Xylocard, when it is injected, the patient's eye, it gives us a burning sensation, and the patient is not aware that such a thing can happen. He'll immediately close his eyes. And then, of course, then it settles down. But it's better that the patient is pre-informed. So intraoperatively, the problems that I have encountered, like subcorneal hemorrhages, many of these patients will have very fragile blood vessels. So wherever you touch, they start bleeding. So postoperatively, the eye will look red, though you have used topical anesthesia. And sometimes, the patient will suddenly move. It doesn't happen to me, and I have not encountered any major complication, because whenever the patient has started moving, I have paused doing whatever I was doing. If I'm making a section, I immediately come out of the eye. If I'm making a rhexis, my needle or the forceps will immediately release the capsular flap. And when you start phacoemulsification, because it is a bimanual technique, then it doesn't really matter, because the eye is held together by both the hands, left hand instrument and your phaco handpiece. And usually same thing about IOL insertion. So there is a possibility for a uncontrolled wound extension, which may mean that you have to suture that incision and make a fresh incision to have a tight fit and proper wound, anterior chamber stability. Rhexis runoff if suddenly the patient moves and you have not been able to disengage the cystitome or the forceps from the capsular flap. Sometimes everything goes on well, but patients become increasingly uncooperative. Then I call the anesthetist. We usually give midazolam to these patients, so another dose of midazolam will be given. So patient usually quietens down. And there may be a need for intracameral anesthesia. So that has to be kept in the mind. If patient is becoming a little more uncooperative, surgery is taking a little longer time, I'd use intracameral anesthesia for this patient. And very rarely, I had to close cases where patient was moving excessively, patient was very uncooperative, otherwise fit, was able to lie down. So I gave an injection anesthesia and then took up the patient for surgery immediately soon after. So now, for some time, I used Xylocaine jelly. It was supposed to be more very friendly to the corneal surface. So before you apply the Xylocaine jelly, you have to apply Paracaine, and then you apply the betadine eye drops, because once you put the jelly, it forms a layer on the conjunctival surface. So the betadine which you're going to use on the conjunctival sac will not be able to reach the crypts and crevices of the conjunctival fornix and the conjunctival surface. So you have to make sure that jelly is applied only towards the end, as you see here. But then I found out that it was also giving us a lot of epithelial haze, and I stopped using it for my cataract surgery. This is about 15 or 20-year-old video. So this is, I saw somewhere in the ACRS meeting. So used two MVR blades, and this inferior paracentesis, superior paracentesis is small size. So it is a bimanual wound creation. And then you inject either BSS to inflate the anterior chamber or topical anesthetic agent. By that time, the patient has become accustomed to the surgery. So you see, I'm applying counter pressure using my tooth forceps, closed tooth forceps. You could also use a bud to do that. So here, for example, you see this, I injected Xylocard into the patient's eye, And then, patient had sudden Bell's phenomena because patient was also told that, you will be having a burning sensation, but sometimes, they misjudge the intensity of the sensation they may have, they may feel. So this is something, my last few slides. Now, what about a junior resident? When you're learning a cataract surgery, SICS or phacoemulsification, should you do it under injection anesthesia or should it be done under topical anesthesia? This was an article came about 20 years back, 2 decades earlier, from one hospital, where they showed that so initially the residents, most of the surgeries, first 25 cases were under peribulbar block, and then 25 to 50, the numbers were gradually increased to from retrobulbar to topical anesthesia, and the last 200 cases, most of the cases were done in topical anesthesia. So the intraoperative complication rate are comparable. So just because the the resident started using topical anesthesia did not increase the incidence of complications for that patient, for those patients. Likewise, the post-op complications and best corrected visual acuity, there is no difference. So this paper felt that junior resident can be given surgery under topical anesthesia with the proper supervision, and the results are not much different from peribulbar anesthesia. So friends, what I would like to conclude by saying is today cataract surgery, the standard of care is, temporal clear corneal phacoemulsification under topical anesthesia. But if you feel that by doing topical anesthesia surgery, you're going to jeopardize the eventual outcome, visual outcome of the patient, or you're more prone to give the patient complications, you can still do it under peribulbar. But, best standard of care today is to do these surgeries under topical anesthesia. So thank you very much for your attention.
First, Arup, to continue to second oration, second topic, so that we can take up the questions later on. Sir, is it all right for you?
Yeah, yeah.
Thank you.
Yeah. Yeah. Some water. Huh? There are certain views which stay on in your mind for your life. Yesterday, when I was traveling from Hubli to Vijayapura, there are certain areas where, the view from the car window was lush green fields with bodies of water and waves of hill. Last month, I was in Darjeeling, a place called Ghum. So there, from the property where I was staying, there was a view of the Kanchenjunga, mountain. It looks beautiful. I mean, I think Arka Prabha might have gone to. Anybody gone to Darjeeling? Yeah. So this stays in your mind. You never forget, and it sort of makes your day. So for a cataract surgeon, a view like this, when you have a sparkling, crystal clear cornea on day one, makes your day. There's nothing like it. Everything is the right track, and you start your day on the right note. So the journey to the crystal clear cornea on the first postoperative day begins in the preoperative period, where you do the proper patient workup, plan out to his surgery, and all those are incorporated during your surgical steps. So let me go through these one by one. So all patients undergoing cataract surgery should have a thorough pre-op evaluation. Of course, I'll not be able to talk about everything, but pertaining to the cornea. So a slit lamp biomicroscopy is done, and you use the zone of specular reflection. And this is, can the postgraduates tell me what do you see here? This is a cornea guttata. So, all right. So this was many of the situations, corneal health, it can be assessed by just looking by doing a slit lamp biomicroscopy. And at this point itself, I can predict that some patients, if only cataract surgery will soon go in for a need for endothelial keratoplasty. So there are certain predictive factors. There are more folds in the posterior stroma, subepithelial fibrosis, peripheral guttae, epithelial edema, and then some other higher risk factors like elderly patients, patients with complaints of morning blur, low best corrected vision acuity, or failure of endothelial density measurement. Many of these cases you cannot measure, the cell density. So these are the situations where, before I take them up for cataract surgery, I tell them that there may be a need for an endothelial keratoplasty because your eye may decompensate. So patient selection has to be done very carefully. All my patients also undergo a specular microscopy because it gives me a printout which stays with me, which may be useful for medical legal purposes. And this is also stored in the computer. Then pachymetry is routinely done for all these patients. Now, what is the cutoff value? Like, a value above a certain level should not be taken up only for cataract surgery. So there is no such consensus as such. The different studies still different figures. But what has been seen that many of these cutoff figures, cutoff values fall within the normal population. So you may be having a thicker cornea, but for all you know, the patient is within the normal range, on the higher zone of the normal range. So best would be to follow up those patients, and if there is increasing thickness of the cornea of the pachymetry, in that case, that cornea is decompensating, and before the epithelial edema and other things show up, patient should be appropriately warned or maybe taken up for cataract surgery before further damage happens. And again, the schedule the patient for late morning and when you measure the central corneal thickness. So the same things, sequence, you do under topical anesthesia. And now regarding betadine, there's something that I would like to tell you that, so this video was done long time back when I was still trimming the eyelashes. So irrigate the congenital sac, that is normally done for all the patients, but ensure that all the betadine is washed off the eye, irrigated off the eye with BSS. Because even if a little bit of BSS, if the betadine enters the eye, and you have, even if it is normal corneal endothelium, post-operatively, you will not be happy with what you see in the post. So it has to be thoroughly washed out with the BSS. Now, I would make a temporal clear corneal incision, but if I'm dealing with a cornea where the specular count is very low, or if the corneal thickness is high, then I would take maybe a little posterior incision, scleral tunnel incision. You need to have an appropriate OVD strategy. So rheology of the OVDs, OVD I think is a long question, so you must understand what are the various OVDs, which is a dispersive, which is cohesive, which is viscoadaptive OVD. So I use both Hilon 1%, 1.4%, Viscoat, and then the Trypan Blue and, some other, Oculan, etc. that goes into the eye. And I don't use ringer lactate. Always, it is always better to use BSS, particularly when the cornea is not too healthy. And recommendation is to use BSS plus, but due to availability issues, I really don't use BSS plus in many of these patients where I would have definitely loved to use it. And so the fluidics, the viscoelastics and fluidics have to be properly chosen. Always use a soft shell technique. Now, the soft shell technique is, now I've already stained the anterior chamber, anterior capsule with Trypan blue dye. I'm injecting a Viscoat into the anterior chamber. Then I'll go with Hilon, just in front of the anterior capsule. Then inject Hilon. So what happens is, as the Hilon mushrooms out, the Viscoat is layered against the corneal endothelium. Okay, so it protects the corneal endothelium pretty well as you do subsequent steps of cataract surgery. Now, sometimes when you have Hilon in front of the anterior chamber, rexis making may be a little difficult because, you require, there are certain, if you're using a needle, I have a longer needle and you can feel the traction that you have to use a bigger, more forceful traction on the cornea, on the capsular flap to get a good rexis. So with that in mind, I think Arshinov came up with the soft shell technique where this is Viscoat, this is Hilon 5, and here is BSS. So the third step that is done is injection of BSS just in front of the anterior capsule. So there you can perform the rexis quite easily. And a word about the anterior chamber maintenance. A lot of people talk about AC anterior chamber maintenance, and not only in SICs, but for phacoemulsification. And they say that you can avoid OVDs by using anterior chamber maintenance. But this study, published in May 21, JCRS clearly showed that anterior chamber maintenance should not be used during phaco in patients with limited corneal endothelial reserve. So that is something I think was a very useful information that came to us. Capsulorhexis is paramount. confine all your surgical activities within the capsular bag. There is all the nucleus emulsification that happens, all the energy that is generated, all the fluidics that is created, everything should be within the capsular bag, away from the corneal endothelium. So when you make the hydrodissection, make sure that the nucleus doesn't prolapse out, because sometimes if the nucleus prolapses out, it may be a little difficult for you to because the rexis, I said, is a little smaller, and if the nucleus prolapses out, it may be difficult for you to deposit it back, and you may have a tendency to perform anterior chamber phacoemulsification at a little anterior plane. So that is something that has to be resisted. So perform a slow, gentle hydrodissection. Make sure that the nucleus is always within the capsular bag. Am I within the time limits, or I'm in time, isn't it? Okay. So here, for example, this is a brittle cataract. Rexis is quite small. So I wanted it that way. And all the manipulations will be performed within the capsular bag, which means all the phaco energy that is liberated, all the free radicals that is liberated during phacoemulsification, fluidics that take place, everything is happening within the capsular bag. So fortunately for me, this particular situation, the nucleus is pretty brittle. I'm using the Chang chopper. So you have to divide this nucleus into multiple small pieces, because now if you just get it down to 4 pieces, and then you try to bring it to the center to perform emulsification, rexis is small, too much of anterior capsule, so the nucleus is going to rub and apply traction against the anterior capsule. So there may be zonular dialysis. So here I'll be breaking up the nucleus into at least 6 or 8 pieces. And let me fast forward this. This is just to highlight the role of breaking the nucleus into multiple pieces, so that you can perform all your activities, phaco activities, within the capsular bag. All the energy liberation is happening within the capsular bag. All the fluidics that is going on, very turbulent fluidics, everything is happening. Most of this is happening within the capsular bag. Choice of phaco technique. So now, for example, it becomes important if you are dealing with the harder cataracts. Do you do a divide and conquer technique, and do you do a stop and chop technique, or do you use a direct phaco chop technique? So it all depends upon the surgeon. Whatever technique you feel works best in your hands to give you a safe phacoemulsification is good for you. So here, for example, this is a very old. This video is more than 15 years old. This old generation phaco machine. So it is possible to tackle hard cataracts with all generation of machines. But only thing is, the new generation high-end machines makes your job and life much easier. So here I made a deep groove at the center of the nucleus, and then chopped into multiple pieces, and so it went up pretty well. So now this is another such cataract. So here, whenever I have a hard cataract in a poor corneal endothelium situation, I always prefer to use this particular phaco machine. This machine has got what they call as a phaco a mega tip. So mega tip has an enormous cutting power. It cuts through hard cataracts like butter, and it also gives you a very good hold, on the nucleus. So chopping goes very efficiently, and the mega tip has 3 internal slopes. So whenever you're using chopping, you would have heard that the wound burn can happen because the lumen of the phaco needle can be blocked by the chopped nuclear pieces. So the likelihood of this happening is much less, because there are 3 slopes within the mouth of the megatip. So as a big chunk comes into the megatip, inside the megatip, it gets further emulsified, reduced in size. So it happens at three levels. Ultimately, when it travels, the nucleus particles travels through the lumen, which is 0.5 millimeter in size. By that time, the nucleus has been, downsized into a much smaller size. So the chances of wound burn happening are much less. And this was again a cataract nigra, Anglo-Indian lady, bilateral black cataract. So this is, I won't show you the surgery. Here I did a stop and chop technique of cataract surgery. So soft shell technique was used. I used copious amounts of viscoat to protect the corneal endothelium. And so she did pretty well. So here I didn't go in for a direct chop, because direct chop would have been very traumatic, by holding the nucleus and trying to at a very deep plane and trying to chop it. There's a possibility that the hole could break and the nucleus could get, as it gets disengaged from the tip of the phaco needle, there may be a torque, it may be tilted, and it may damage the the capsular journal apparatus. So this was ultimately done. So the key word in these situations is patient. Patience. You know that it can be done. Only thing you'll be requiring maybe a little higher energy. You'll be requiring a little more time. So use be very careful. Use a lot of OVDs. Protect the corneal endothelium. Keep your activities confined within the capsular bag at the posterior plane. So with patience and with your perseverance, you can take out the last piece as you see here. Last piece comes out. By that time, when you come to the last piece again, you step down on the phaco parameters because you don't want the surge to damage the posterior capsule. So this is the picture, first post-op day. It is really first post-op day. It is not some other day later on in the post-op period. Patient had a vision of 6/6. Patient actually was the wife of a rubber estate manager in Kerala, that they have migrated to Chennai. She again came back for the second eye. Second eye also done extremely well. Now, this is another technique which I use again when I'm encountering difficulties with the nucleus management, and maybe sometimes it is a little softish or very hard nucleus. So there I stop using the phaco handpiece, phaco needle. I go with two Sinskey hooks, and as you see here, I develop a chop line starting from the periphery, come to the center, very calculated move, very slow, very gradual movement, and then the chop line comes into the subincisional area. So here in this situation, of course, you have to rotate the nucleus. And again, you have to use a lot of OVDs to make sure the anterior chamber depth is well maintained, the bag is well inflated, and that is it. Finally, once you have got the nucleus divided into two pieces, subsequently, whatever technique of phaco that you employ, it goes on pretty well. So this is the same technique being shown. The newer machines, they have made surgery much easier while dealing with the harder cataract because of better fluidics, because of better chamber maintenance, because of reduced post-occlusion surge, etc. But in spite of all this, when you have small machine malfunction, for example, what you saw here was a surge. So for a brief period, the cornea comes into contact with the phaco handpiece, and that is very, very injured. That jeopardizes the corneal endothelium. Post-operatively, are going to come up with central corneal striate keratopathy. This is another thing which we should not ignore. Like when you come towards the end of phacoemulsification, the small particles, they ricochet from the phaco handpiece and they hit the corneal endothelium, and then it happens repeatedly. So that way, the corneal endothelium has a chance to get traumatized. So you have to be very careful. So you have to increase maybe the followability, reduce the phaco power, you reduce the chatter that is happening. And this can also happen towards the end of phacoemulsification when you're doing irrigation aspiration. When a little chunk of nucleus is visible, it flows out from the anterior chamber angle or maybe from the posterior chamber. So that again has to be tackled carefully, ensuring that it doesn't move around much in the anterior chamber. So what is the choice? After doing a successful cataract phacoemulsification, what is your ideal choice? Don't use a hydrophilic acrylic intraocular lens. Because post-operatively, if this patient goes in for endothelial keratoplasty, where air bubble is kept into the anterior chamber for some time, there's always a subsurface calcification in these lenses. So these lenses will have to be explanted with a different lens. So always use a hydrophobic acrylic lens for these situations. And always aim for a -1 to -1.5 diopter myopia. Because if post-operative, the patient again requires a corneal surgery, there is a post-op hyperoptic shift. So patient's target refraction will be better achieved with this arrangement. Never use a multifocal lens in a patient with Fuchs dystrophy or a patient with the cornea guttata, because there's always a forward light scatter because arising from the guttae, and the optical quality of the light that is transmitted is not very good. On top of that, if you have a multifocal lens which further degrades the optics of the light that passes through the system, a patient is definitely not going to get the advantages of a multifocal lens. So basically, when it is safe to perform cataract surgery in these compromised eye situations, where the PACI reading is less than 640, you take up these patients before the nucleus becomes too hard. We always have a tendency to temporize these surgeries. Ask the patient, like, you're seeing well, let the cataract get advanced a little bit more. But what you don't realize that as you allow the cataract to become more and more advanced, you're going to require more energy to take out these cataracts, and that is not good for the corneal endothelium. These cases should again be done by experienced surgeon. Always use a soft shell technique for these cases. So I have operated by now more than 20 such cases in the last 15 years, and I have not lost a single case where the cornea has ended up with the decompensation. There's only one case, a doctor actually, so my wife's classmate, she had iridocorneal endothelial system along with corneal dystrophy. So there I did a cataract surgery. Her count was around 1,000. But then I later on realized that a combined surgery would have given a better prognosis in that case, in this particular combination. So basically, please remember that your preoperative workup has to be meticulous. Use BSS, if not BSS plus. Use soft shell technique for all cases. Endocapsular phaco techniques are always more desirable. Phaco power modulation and fluidics, you must employ them very ergonomically. Avoid factors which are known to be detrimental to the endothelium, and know when to plan for the stage surgery or when to do a combined surgery. So that that information, though you may not be doing corneal surgery, but then that information should be available with you. So thank you for your attention. But before I finish, I'll just show you one slide. So the AACRS meetings, that they have an on-demand. People who have attended those meetings can view the contents of the meeting online, like AIOS. We have the same thing on demand, which was when I was the editor proceedings, I started the system. So there is a slide which this was actually in 2023, not a very old study. So it concluded, the question is flax preferred in eyes with Fuchs endothelial dystrophy? The conclusion was the overall existing evidence supporting flax in individuals with Fuchs endothelial corneal dystrophy undergoing cataract surgery remains scant at worst and inconclusive at best. So there is a feeling that, if you do flax for these cases, you save on corneal, the total phaco time, maybe the endothelial count, and do they really give better results? So I think it is still an ongoing debate, and we don't know the final answer. But even if you're not doing flags for these cases, if you follow proper guidelines, which I've discussed in my presentation, I think you'll be on a good road for the patient's recovery. Thank you very much.
Thank you, Dr. Arup. May I invite questions from the audience?
If the cornea is compromised, is SICS better than phaco, or which one?
I think it's a very valid question. Yeah. So if the cornea is really compromised, elderly patient, and it is a hard cataract, some people doesn't dilate well, SICS I think would definitely give us a better outcome if we are good in doing SICS.
So I'd like to just add a point. See, basically, it all depends on the surgeon and also the actual case. So it's a very difficult statement to make, which is better. Okay, but thinking that the surgeon can do both effortlessly, what I keep telling my postgraduates, the basic thing in SICS is that the cataract has to, the nucleus has to come out of the bag and come out of from the anterior chamber to the exterior. So there is a transit period in which there is a period in which you have no really control on the nucleus. Whatever you do, whatever technique you do, there's a possibility that the nucleus can touch the endothelium. There are certain moments where you have less control. Whereas in phaco, as he showed, it was such a, great surgery where you can have a great control on the things. The anterior chamber can be always maintained with the fluidics. You can always use the viscoelastics cover. You can always do an endocapsular phaco, a cornea conscious technique where you make small pieces and emulsify it within the bag. So that there's always, you have things under your control. Here the nucleus is broken into pieces and eaten within the bag. Here the entire nucleus comes into the AC and comes out. So you need to put an instrument above, below sometimes to pick it up. So if you lose that one or two attempts, then probably if you're doing multiple attempts to get the nucleus out, you are stuck with the scleral tunnel, you will create definitely more damage to the endothelium. So I think you will agree that phaco has more control on us.
No, in this specific case, I think I did not answer your question completely. So I do SICS for these cases, and what I do is my incision size is not restricted to 6 millimeters. Normally, all my SICS will be restricted to 6 millimeters, and you can cut the nucleus, or you can use phaco sandwich technique and all that, and get the nucleus out. In these cases, as KP mentioned, that cornea is of such importance here. So I'll make an incision which is maybe 8 millimeters. Okay. I'll be using viscoat. It is not HPMC based surgery. So patient can afford any type of lens. I'm talking about that is not a hindrance, but he wants the best. I want to give him the best result. So my incision will be 7 to 8 millimeters. Okay. I'll be using viscoat for these patients. Make a rexis which is slightly larger, so that prolapsing the nucleus into the anterior chamber, you don't have to do a bimanual technique, or you don't have to tilt the nucleus. Sometimes you do a small rexis, big nucleus, you have to tilt the nucleus, AC becomes shallow. So just with hydrodissection itself, you can express the nucleus into the anterior chamber. You have a safe coating of viscoat in the anterior chamber, then visco expression. I don't use a sandwich technique because, as KP mentioned, when two instruments go in, it's a tunnel, won't get separated, and OVD will come out, and there is no way you can really ensure nucleus isn't touching the endothelium. So I'll be using a visco expression technique where, again, this time I'll be using orogel, Hilon. So that expresses the nucleus out of the anterior chamber. And I put maybe 2 sutures so that, this is a larger wound, maybe not necessary watertight incisions, but still I'll put 2 sutures and come out. So that central 6 millimeters will be, unsutured with the periphery. But KP also has a good point, but for that you have to be a good phacosurgeon. So I started doing SICS in 1992. And fortunately, I was able to learn phaco-bisection, trisection, phaco-snare, sandwich, Blumenthal technique. Blumenthal I never liked because it required a larger incision. So it is not a technique which has to be taken in a very, what should I say, in a very superficial way. Okay, you should be very careful with for the SICS as you're careful for the phaco. So no questions from the postgraduates?
So,
Shweta, where is Shweta?
good morning, sir. So,
Hi, good morning.
would how dense a cataract is, would the grade of the nucleus be a factor you would consider if we take a patient for topical anesthesia, phacoemulsification?
Yeah. No, that actually is a very valid question. See, first is, how do you classify the nucleus grade? I mean, if you have to see on the slit lamp and grade a nucleus, so what are the criteria that you take into account? What is the classification system that you follow?
So we consider the logs grading system.
Logs grading system, yeah. So why I want to tell you the logs grading system is something I don't follow, because it does not take care of the real red cataract rubra, cataract nigra that we see. Okay, if you see the nucleus sclerosis grade 3-6 there, still yellowish, still amber colored. Okay, in the logs grading. So my classification will be, it's a brunescent, brown 1, 2, 3. Then cataract, next is cataract rubra. Next will be cataract nigra. Okay, so brown 1, 2, 3. Then red cataract, and then is a black cataract. So this is the way I classify my, I haven't read it anywhere, I have not published it, but this is the way I choose my phaco parameters, my surgical technique for these cases. So your question was?
So if the density or the grade of nucleus would be a determinant, like if we take a patient up for topical anesthesia, phacoemulsification?
No, so the thing is, if I feel that a surgery may take a longer period of time, if a patient is uncooperative, so I would use a peribulbar block for subtenuous block or a peribulbar block for those cases, patients. But then, I have had cases where, if a patient is very cooperative, like however hard cataract you are dealing with, whatever be the size of the people, however small it is, if some of the patients have required a passman intraoperative hard eye, I've done a vitrectomy from the passman in that eye without any supplemental anesthesia. So it all depends upon the attitude of the patient and your surgeon's exact assessment of the patient. It is just like, when a cross-up is done during a cricket match, the captain has to assess how the pitch is going to behave, and then he selects batting or bowling. So, so as a surgeon, I would assess that, is this patient going to be, cooperative? He's cooperative, but if it lasts longer, tough case. I have done extremely hard cataract under topical anesthesia. I have done very, very simple cases under peribulbar block, because the patient at the end of the day will remember your surgical experience, but the amount of pain that he gets during intraoperative. So that there I don't want to compromise. So patient has to be absolutely comfortable during the surgery.
Thank you, sir.
Good morning, sir. Sir, if we are operating a case under topical anesthesia and if you land in complication like a PC rent, how would you go ahead with the surgery? Would you continue with topical
Yeah.
or you would
See, again, it depends upon how much leftover work you have got to do. See, if I have taken a patient under topical anesthesia, means patient is a cooperative patient. So patient does not know what is happening. Whether you're doing hydrodissection or whether doing phaco, what stage you've got a PC rent, you're doing vitrectomy. Patient has no idea what is going on. All right. So patient doesn't. So it is not up to the patient. It is up to the surgeon. If the patient is cooperative, I mean, I would just continue to do surgery and in the same manner. Otherwise, there have been very rare cases. I don't have too many of PC rents, but if I have a PC rent and if the patient has been extremely uncooperative, then I will be using maybe a perilimbar block for those. But most of the PC rent patients I have not used in supplemental anesthesia. It is, that you have more work to do, more work less that is left over, but you don't panic. That's it.
Thank you, sir.
Thank you for the wonderful discussion session. We have come to an end of this session. Thank you, sir.
We request Professor and Head of Department of Ophthalmology, Dr. Rekha Mudal ma'am, to present a token of gratitude to Dr. Narsapur sir. I request ma'am to present a token of gratitude to Dr. M.H. Patil sir. Thank you, sir. Thank you, ma'am.
We will now take a short break for the inauguration ceremony before we resume with the further sessions. Thank you. A very good morning to respected dignitaries and delegates. It is our distinct honor to inaugurate this advances in cataract surgery. I would like to extend our deepest respect to all our esteemed dignitaries present here today. Now I request Professor and Head of the Department of Ophthalmology, Dr. Rekha Mudhol ma'am, to escort our Honorable Pro-Chancellor, Dr. Y.M. Jairaj sir, our Honorable Vice-Chancellor, Dr. R.S. Mudhol sir, and our Presiding Honorable Principal, Dr. Arvind Patil sir, to the dais. Thank you, ma'am. Thank you, sir.
I request Professor Dr. Sunil Birada sir to escort our guest speaker, Dr. Arup Chakrabarti sir, to the dais. Thank you, sir.
As we gather here today, let us set the tone with a melody and seek the blessings of the Almighty to mark the beginning of an auspicious event. So, without further ado, let us welcome Dr. Veena and Ms. Bhamini to the stage as they grace us with an invocation song.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुणवे गुणगुरवे गुरुदैत्यकलक्षेत्रे गुरुधर्मसदाराध्याय गुरुपुत्रपरित्रात्रे गुरुपाखण्डखण्डकाय गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गूढकल्पाय गन्धमत्ताय गोजयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि श्रीगणेशाय धीमहि श्रीगणेशाय धीमहि
Thank you, ma'am, and thank you, Bhamini.
I request our esteemed professor and head of Department of Ophthalmology, Dr. Rekha Mudol ma'am, to address the audience with a welcome speech.
Good morning, one and all. On behalf of Department of Ophthalmology, I welcome you all to the CME Advances in Cataract Surgery. Honorable Pro-Chancellor, Dr. Jairaj sir, Honorable Vice Chancellor, Dr. R.S. Mudol, our beloved Principal, Dr. Arvind Patil, distinguished guest faculty, Dr. Arup Chakravarti, a renowned ophthalmologist from Thiruvananthapuram, Dr. Krishna Prasad, Dr. Sanjeev Kulkarni from M.M. Joshi High Hospital, Hubli, Dr. Narsapur, Dr. Malgan, Dr. Biradar, Senior Ophthalmologist of Vijayapura, my colleagues, Dr. Sunil, Dr. Vallabh, Dr. Ijere, other faculty members, Dr. Hanutki sir, our medical superintendent, all the professors from SN Medical College, teachers from our Alamin Medical College, all the faculty members, invitees, and delegates. Cataract surgery is considered one of the most rewarding surgery and successful treatment among all procedures. With continued advancements in technology, cataract surgery has been evolved into a refractive procedure rather than simply a surgical treatment for cataract. Despite the worldwide availability of multiple IOL brands, materials, and models, many lenses are not suitable for every patient. While modern cataract surgery has significantly improved the lives of many people throughout the world, perfection seems to be an illusion. In this new era of cataract surgery, advanced technology ensures precise, minimally invasive procedures with rapid recovery. Innovations like femtosecond lasers and premium intraocular lenses significantly enhance vision and quality of life, which needs to refine our skills. So today, CME is designed to provide a comprehensive overview of the latest techniques and best practices in cataract surgery, including a hands-on wet lab workshop on phacoemulsification for the beginners. So on this special day, I warmly welcome Honorable Pro-Chancellor, Dr. Jairaj sir. I welcome you, sir. I warmly welcome Honorable Vice-Chancellor, Dr. R.S. Mudol. I welcome you, sir. I welcome Dr. Arvind Patil, beloved Principal, Shri B.M. Patil Medical College. I welcome you, sir. I'm honored to welcome Dr. Arup Chakravarti, Senior Consultant and Director of Chakravarti Eye Center, Thiruvananthapuram, an eminent faculty, an expert in complex cataract surgeries, and a good teacher who has come all the way from Thiruvananthapuram as our guest faculty. I welcome you, sir. I welcome Dr. Krishna Prasad, Head of Pediatric Ophthalmology and Glaucoma, MM Joshi Eye Institute, Hubli, a passionate teacher known for his dedication in training postgraduates. I welcome you, sir. I welcome Dr. Sanjeev Kulkarni, Head of Low Vision Aids and Special Contact Lenses. I also welcome all the delegates, invitees, and who have gathered here and to grace our function. I welcome one and all. I hope this one-day event will be fruitful for everyone. Thank you, one and all.
Thank you, ma'am. To symbolize the inauguration of this enlightening event, we will now proceed with the lamp lighting ceremony. I kindly request our dignitaries to come forward and light the lamp, representing the dispelling of darkness and ushering in of knowledge and wisdom.
Thank you, dignitaries. Now I request Professor and Head of the Department, Dr. Rekha Mudhol ma'am, to present a token of gratitude to Honorable Pro-Chancellor, Dr. Y.M. Jairaj sir. Now I request Dr. Vallabha sir to present a token of appreciation to our Honorable Vice Chancellor sir, Dr. R.S. Mudhol.
We request Dr. Sunil Biradar sir to present a token of gratitude to Honorable Principal, Dr. Arvind Patil sir.
Thank you, sir, and thank you, dignitaries. I now request Dr. Arup Chakrabarti, sir, to grace the felicitation chair. I now request our dignitaries to felicitate our guest speaker for this event. Dr. Arup Chakrabarti, sir, a senior consultant at Chakrabarti Eye Care Center. His field of interest is complex cataract surgery, and he has an abiding interest in glaucoma. Dr. Arup sir has edited 3 books: Cataract Surgery in Diseased Eye, Posterior Capsular Rent, Genesis to Management, and Posterior Segment Complications of Cataract Surgery. He has also contributed to more than 30 book chapters. He has more than 76 publications in international, national, and state journals. He has presented 107 free papers, 22 posters, and 111 videos in state, zonal, national, and international conferences. He is a reviewer for prestigious journals, including JCRS, APJO, IJO, BMJ Open Ophthalmology, among many others. Thank you, sir. I now request Dr. Krishna Prasad, sir, to kindly grace the felicitation chair. Dr. Krishna Prasad, sir, one of the directors and the head of pediatric ophthalmology and glaucoma services at Joshi Eye Institute. Dr. Krishna Prasad has undergone a fellowship training in pediatric ophthalmology at Storm Eye Institute Medical University of South Carolina, USA. He has 3 international publications and 12 national publications in peer-reviewed journals. He is the director of PG training and fellowship programs at Joshi Eye Institute and has been a PG teacher for last 30 years. He has been awarded the Best Teacher Award by ANBAI and by Forum of Ophthalmic Teachers of India. Thank you, sir. I now request Dr. Sanjeev Kulkarni, sir, to kindly grace the felicitation chair. Dr. Sanjeev Kulkarni, sir, Head of Special Contact Lenses and Low Vision Aids at Joshi Eye Institute, Dharwad. He has been a medical director at the Dharwad branch since its inception. He is a respected and renowned private practitioner at Dharwad.
Thank you, all the dignitaries. I now request Honorable Pro-Chancellor Dr. Y.M. Jairat, sir, to address the audience.
Respected and Honorable Vice Chancellor of BLDE Deemed to be University, Dr. R.S. Madhur, sir. The illustrious guest, Dr. Chakravarti. The illustrious principal of Shri B.M. Patil Medical College, Hospital and Research Center, Dr. Arvind Patil. Head of the Department of Ophthalmology, Dr. Rekha Madhur, Madam. Dignitaries who have been invited as guest faculty from various parts of India, and the faculty of BLDE and Alamin Medical College and various other invitees, and my dear students. Amongst all the people who are sitting over here, I'm the odd man out. I don't have the specialization to speak anything on ophthalmology for a simple reason. I am basically a medical microbiologist by vocation and a former vice chancellor and pro-chancellor by profession and education administrator. But yet, in order to speak a few words befitting to this particular occasion, I'll take 5 or 6 minutes of yours to share some of my stray thoughts. First of all, hearty congratulations to the Department of Ophthalmology headed by Dr. Rekha Mudol Madam, for having thought it fit enough to have a CME on one of the burning topics of ophthalmology, namely the cataract complications and surgery. A round of applause to her. And also all the faculty. I also congratulate them for having invited illustrious personalities and professionals in this particular field who have made a mark in India and abroad through their committed profession, at the same time academic acumen in the form of publications and illustrious recognitions. I also congratulate the honorable principal of this particular college for having encouraged the faculty members of the departments to give insistence to the continuous learning process, which is the hallmark of 21st century. I keep on telling the 20th century is known as one-time learning and lifelong learning. I repeat, the 20th century is known for an adage called one-time learning and lifelong learning. Not that they were not learning, but there is not much to learn new. The pace at which the knowledge and the skills and the technology and competencies that are developed used to take 30 to 40 years to evolve. So whatever was happening till 1990s was known, and ultimately they used to practice. I still remember about 60 years back when I was 15 years old, I was one of the volunteers to one of the cataract camps in my native place. During that time, there were no medical colleges except 3 to 4 medical colleges in entire Karnataka. And there was one doctor who was known as the poor man's doctor, Dr. M.C. Modi. I don't know whether you have heard of him or not. He was awarded Padma Shri also. So he used to conduct camps at various taluka places. And we as students of high school and middle school, we used to be volunteers in that particular camps. I still remember that picture is vivid in front of me. All the old age people used to line up, and with the help of a torch used to just say yes or no for operation also. And the operation was conducted, I still remember, in our classroom, a makeshift classroom. And the other classrooms were used as the IPDs. And medicine was given to them. And during that time, the knowledge that I gathered about ophthalmology as a student was that ophthalmology is a science for the old people. In Kannada, you'd say, 40ಕ್ಕೆ 40 ಬರ್ತದೆ. 40 ಬರಸ್ or 40. Right? Till 40 years, no need to come to the ophthalmologists for a simple reason that our food habits were good, eye care was very good, the way we used to nourish our eyes with proper resting and other things was very good. But 21st century, we are seeing a paradigm shift. The paradigm shift is by the age of 15 only, myopic disorders are on the increase. And you see any ophthalmology clinics, more than the old people, the youngsters who have got learning disabilities to see the board from a distance and all are brought to the ophthalmologist only to diagnose that they have already got the number. Now, probably this is becoming an epidemic. At DY Patil, about 1.5 years back, we had one international conference on myopia. And in another 20 to 30 years, probably this is going to be still higher. The age for the myopic disorders, which was earlier between 15 to 20 or even 40, is going to decrease. So ophthalmologists have a very, very pivotal role regarding not the diseases of eyes, but the well-being of the eyes. See, Sustainable Development Goals of UNESCO, number 3, health and well-being is the word used, not curation of the disease. So 21st century, we should aim at health and well-being. So probably ophthalmologists have a role, not only in their OPDs and IPDs and operation theaters, but to attend to the complicated aspects of surgery, particularly with the help of the computerized assisted microscopy surgery nowadays. But what is more important is regular screening at the schools to find out the defects at the early age and try to give corrections. That's all. As a layman, as a student of medical science, I can only tell that much. And I wish you all the best in this particular endeavor, that the PG students who are going to have a hands-on experience. As I keep on telling, competencies is the hallmark of 21st century. Many people fail to distinguish between skills and competencies. Skill is that you know how to do. You can also do, but how nicely within the time with the least inaccuracies you do is competency. So competency can come only when you go for more number of hands-on experience. Even the competency-based medical curriculum also insists on more of hands-on experience and competencies. So I request all of you more observation is important rather than listening. Observational skills as to how a senior does, how he holds the apparatus, how he looks at the patient, at what angle he looks at, and how he does it, play a very, very important role. But I have a grouse about youngsters. Youngsters always think that they are more computer natives, and the old people are computer immigrants. They don't know anything about it. And I always think that old people do not know much about the advances in the computer-aided bioinstrumentations and so on. This is one of the grouses I always listen from youngsters. But remember one thing, only when the experience and the expertise and the improvisation and the passion from an youngster join together, success will not be there. So it is a teamwork. Today, solo exhibition is gone. Today is the era of teamwork. So try to learn as a team, try to exhibit your skills as a team, attain competencies as a team, and ultimately ensure that the patient goes with a smile. That's what I wish to say. I would like to conclude my remarks by saying only one anecdote of Helen Keller. I'm sure, how many of you heard of the name Helen Keller? Please raise your hands. I'm happy that many of you know. She today a celebrity, though she was blind. She developed blindness. She thought that the entire world is gone. But ultimately, she became a celebrity by writing good number of books, which have become illustrious books for reference in 21st century. Once she was asked, do you feel sorry that you don't have sight? I repeat, please listen to this question very carefully. Do you feel sorry that you don't have sight? She said, no, I don't feel sorry that I don't have sight, but I feel sorry for those who have sight but no vision. So what is more important today is, if you give me a sight, it is not enough. You should give me the sight first to see things properly, neither myopic nor biopic. A natural, normal view. Second one is insight. A sight without insight is no sight. You can only see, but you can't visualize what is happening. So in 21st century, when things are moving at a very, very fast rate, what I want to appeal to all of you is give sights to others and have insights within you. Only then you can develop the vision. What is that vision? Vision to serve the poor, to serve the needy, and to serve to the best of your ability with least expectations. That is what best service that can do. And eye being one of the important sensory organ of the human body. We know the importance of eye when you see a blind man. Though others without various disabilities can perform better than others, whereas people with no eyes, you can know the difficulty of it. But those people have got an insight within them. All of us have got sight, but it's for us to develop insight and ultimately develop a vision to go for an integrated, holistic, humane society. With these few words, I wish you all the best for this CME, and I welcome the experts coming from various parts of Karnataka and India to the portals of BLDE. For information, sir, BLDE is a 115 years old association, one of the oldest in entire India. Our medical college is around 40 years old. And our motto is, the motto of our leader is to serve the masses, particularly the downtrodden and the rural masses. That is our leadership, Dr. M.B. Patil, sir. So on behalf of the university, on behalf of our chancellor and our leader, Dr. M.B. Patil, on behalf of all the fraternity of BLDE, I welcome you to the portals of BLDE and I wish you all the best for the day to come. Thank you.
Thank you, sir, for your insightful words.
Now I request our Honorable Vice Chancellor, Dr. R.S. Mudhol, sir, to kindly address the gathering.
Very good morning to one and all. Greetings from the BLDE University and Chancellor Shri M.B. Patil. I am very happy that the Department of Ophthalmology has arranged the very common topic and a burning problem of this society, cataract, calling the experts that what is happening in the cataract surgery, what are the newer things happening, and how do you benefit the patients and helping the postgraduate students in particular. This cataract surgery CME is very, very important. I congratulate and compliment the Department of Ophthalmology for having this particular CME. Honorable Pro Chancellor, Dr. Y.M. Jairaj sir, guest faculty, Dr. Anup Chakravarti, Principal Dr. Ravind Patil, Head of Department Dr. Rekha, other guest faculties, Dr. Krishna Prasad, Dr. Sanjeev Kulkarni, Senior Ophthalmologist, Dr. Narsapur, Dr. Malgan, my own the students and friends, Dr. Umesh Harkuni, Anand Puranikmat, and Shilpa, and many others, and dear delegates and students. It gives me immense pleasure to be with you to highlight some of the things of the eye surgery. And the burden today, probably you know better than me, almost 24 million eyes, rather 12 million people are blind, having blindness problems. 80% of them are having cataract problem. And almost 3.8 million every year is the incidence in India. And out of which we are addressing only 1.3 to 1.5 to 1.9 surgeries are being done. There is a huge gap between the need for the cataract surgery and what we have got, infrastructure, surgeons, and what is our capacity building of the India is not. That means what? You have got all ophthalmologists and young friends have got wonderful. Unless government and all the private agencies take that, bring that gap to the whatever is happening, I think it is a long way. At least takes 10 years, and every year cataract is adding. So aptly you have taken, and one or two things about the cataract surgery. Most rewarding, because the moment you do the cataract operation with today with the extracapsular extraction and intraocular lenses, I think you have done the wonderful job, and they are almost 6x6 vision you are going to give. Most rewarding. I am a ENT surgeon. I know that temporoplasty we do, endoscopic sinus surgery. Somewhere we cannot achieve 100%, but the most all surgical branch you take, most rewarding point of the view of the patient, he will be most happy. Ultimately, what is happiness of the patient or satisfaction of the patient is hallmark of the any medical treatment. That's one thing. More than that, highest charity happens in the cataract surgery. All over India, you take any hospital, including Joshi Eye Hospital also, they have got the lot of the charity they are doing, because I have attended one or two programs, and almost when I was in KLE, we used to have camps together in many places like Mudod, Malingpur, Jamkandi and all. So two reasons. One is you are giving perfect vision. Second thing, you are giving the most charitable work, any institute that is. And other way around, if you think the commercial aspect also, I think you are charging highest also with the IOL lens. I am not comparing with the super specialties. I am comparing with the ENT, other surgeries. So we are happy that you are happy, patients are happy, and ultimately institutions are happy. And ophthalmology takers also. Before ENT and before general surgery, ophthalmology takers. I, as a Vice Chancellor, see who are taking ophthalmology first in our institute. So somewhere, ophthalmic fraternity is doing human service to the humanity, and particular training the young friends, postgraduates, fellowships, and many DNB programs. And of course, medical colleges are doing MS programs and fellowships. In that context, this workshop and CME, whatever they are doing, FECO amplification also they are doing, and for the young students. And also the stalwarts, Anup Chakravarti, Krishna Prasad, Sanjeev Kulkarni, and many the staff members, they can interact, and young friends will be very much benefited. For these reasons, I am very happy, the head of the institute, that the Department of Ophthalmology is doing the very good CME, which is burning problem of the society at large. In particular, the institutions are not matching what is the demand of the society. With that note, I wish this CME and workshop a very fruitful outcome. Thank you one and all for inviting me here. Thank you.
Thank you, sir. Thank you, sir. Now I request Dr. Arup Chakraborty, sir, to address the audience.
Respected dignitaries on the dais and off the dais and dear friends. Sometime middle of May, I got a message from a friend that there is a meeting going to be happening. And that time I was actually in the airport traveling to China for the APSCRS meeting. So then soon after that, madam rang me up, but your name was still saved as Belgaum. So I was not able to put together. I saw Belgaum, Dr. Rekha Model ringing up and called about the CMA happening in Vijayapur. So I was not aware of this transition, for her transition from Belgaum to here. Yeah, major transition. Yeah. And then, but I was not really familiar with what Vijayapur was. But what life has taught me that whenever there are some doubts, etc., just time will heal it. Time will tell you the solution in due course of time. So I went to China, came back, and then KP got in touch with me. I asked KP, where is Vijayapur? So it turned out to be Vijayapur, which I'm so familiar with. And so thanks a lot, madam, for thinking about me. And it is always a pleasure to, associate with the youngsters. And, I mean, it is all, everybody knows that it is not possible to teach a syllabus here, but it is just to provide you a spark, just tell you that so many new things are happening in this field. As sir quite correctly mentioned, that in last, particularly this particular century, so much of evolution has happened, new information has come in, new technology has come in, and things are happening. So it is just to provide a spark to you that, you're on the right track, ophthalmology is the right specialty. And until unless you are in sync with what is happening, you'll soon find yourself outdated. Sir also mentioned about, youngsters are very smart. I fully agree with it. When I was learning FECO, I was in my early 30s, I think 31 or 32. And that time, what we have noticed is, the younger surgeons found it easier to learn FECO. KP, isn't it? Those established med teachers, those who taught me, and they have other responsibilities also, but we had nothing. We just could read up, see videos and do. So I realized that our generation is picking up things very, very fast as opposed to our teachers' generation. And I didn't want to, I kept in my mind that when I cross over to that generation, I should not be like, oh God, I have stopped, learning. Very difficult, to learn new informed technology, new tricks. So I have always tried to keep pace with advancing technology, either in my field or in general field, to the extent that it has been possible. I think that is, I mean, I need not emphasize this to the youngsters, but just keep abreast of whatever latest is happening, find out how you fit in, how you can contribute. I think this is what I would like to leave the message that I would like to leave behind. And like, thank you, KP. Also, I asked KP, what is the program? Don't worry, sir, I'll put a program. You made a marvelous program. So thank you, KP, to make the whole program, the plate complete. Thanks a lot.
Thank you, sir, for your insightful words.
It is with great honor and privilege that we welcome Dr. Arvind Patil, sir, to kindly give the presidential remarks.
Honorable Pro-Chancellor Dr. Y.M. Jairaj, sir, esteemed Vice-Chancellor of this university, Dr. R.S. Mudol, sir, esteemed guest faculties from Trivandrum, Dr. Arup Chakravarti, esteemed Assistant Cancer Institute of BLDE, Dr. M.M. Joshi's institution, because he's so fond of BLDE and he has been associated with for a long time, Dr. Krishna Prasad and Dr. Sanjeev Kulkarni, senior ophthalmologist of this part of Vijayapura, Dr. Malgan, Dr. Jayaj Biradar, Dr. Narsapur, my esteemed alumni of this institution, Dr. Santosh and other members of our institution, being an ophthalmologist, and proud postgraduates of various parts of India. It is an honor to have you in our institution. Such a wonderful CME is being created. We all know from the evolution of cataract surgery, from only extraction of the lens today, phacoemulsion, and future what is going to be any invasive procedures will be minimized so that the patient benefit is always going to be the most important thing, as our Pro-Chancellor emphasized. And Dr. Vice Chancellor also emphasized how the evolution and what is the role of each doctor to take care of those things. That's what we look forward. I'm left with a confusion whether, because you are all so lucky youngsters, we all feel anyway about you, because you will be learning the current trends. When we started our journey, our teacher used to tell, make big surgeon, make big incision. Textbooks also used to emphasize, do not compromise on this thing. I'm sure Shilpa also knows those things. That's where we thought of it. Today, it is the era of from minimally invasive. Now, today we are going, big surgeon makes no incision. Big surgeon makes no incision. So what is that big surgeon makes no incision? Now, transgastric procedures are coming. I'm left with confusion. Should I teach the students big surgeon make a big incision? Or should I teach students only transgastric surgeries? Yes, but this is being last 6 months, I'm being discussing with people also and asking people and also introspecting myself and putting myself in student shoes, what they should want to know. But now I understood and evolved a good skill lab which will learn the basics and the complicated surgeries, because any procedure has a complication. So he cannot be saying that I will learn straight away transgastric surgery. A good skill lab I can definitely learn all those things, and a good short learning curve with good procedures, live operations has to be done. This is my view. I don't know what Satyaprasad sir also thinks about these things. So all these things we like to look upon, and the institution is keen to invest and develop such things. We have a wonderful skill lab. We have wonderful, now Madam has arranged such a wonderful wet lab. So all these makes us a pride place for all of you, making use of these things. I'm sure your visit and stay in the institution will be a very rich learning experience, and will always demand, Rekha Mudol madam, please arrange more and more by the time you leave. So this is my view about the learning curve. Only my request to all youngsters is dedication is the key. Dedication is the key. Observe, as Pro-Chancellor was telling, observation and vision. You need to keep yourself. You can't be, we have all these things, but without all this vision and the hard work and dedication, you will not achieve goals. What the teachers have spent years together. We will be learning such a rapid learning curve you possess, and we'll be learning all those things. I wish you all to be the best and look for next 20 years. What are the challenges in the field of ophthalmology? How do I branded already blind patient, how do I help him? So all these things, because since you are blessed with such procedures, with so many technology embraced science, you should be looking forward, how do I treat the non-treated patients in the field of ophthalmology? And I wish and pray for all of you to be the best ophthalmologist in the world. Thank you.
Thank you, sir. I would like to request Dr. R.K. Ijeri, sir, to deliver the vote of thanks.
Good morning, everyone. I would like to thank Dr. Jairaj sir, our Pro Chancellor, for gracing us with for this CME among his busy schedule. Thank you, sir. I'd also like to thank Dr. Mudol sir, who helped us in conducting this CME in every step. Whatever we approached for, he didn't said no. So thank you for all the support, sir. I'd also like to thank Dr. Arun Patil, sir, who is ever inspiring. He is backbone for our department. So whatever you had asked, he has already, he said no to everything. So thank you. Didn't say no to everything. Thank you for your support, sir. So I'd like to thank Dr. Arup sir. Just with a single phone call, he has agreed to come all the way from Thiruvananthapuram to deliver his experience to all the students and faculties of the Vijayapura. Thank you, sir. Krishna Prasad sir is well known to everyone in at our place. Vijayapura is just like a family to him. So thank you, sir, for delivering all the excellent talks for us. Also like to thank Dr. Sanjay Kulkarni for coming here to share his expertise in low vision aids and contact lens. Thank you, sir. I'd like to thank all the delegates, postgraduates who have come from different parts of the outside of Bijapur to just attend this gathering. Yeah, from Maharashtra. Thank you for coming. I'd like to thank Department of IT, who has provided us with all the audiovisual aids, which has helped us to conduct a very beautiful CME. Also, we have YouTube live also is there for the CME, which link we have shared in the group. Anyone can access this link. So I would like to thank Alcon for providing us with wet lab facilities. Pharma companies like Sun Pharma, His Highness, Aura Lab for helping us support in conducting this CME. Lastly, I want to thank department, faculty, postgraduates, optometrists in conducting this CME. Thank you one and all.
Thank you, sir. The inauguration ceremony concluded now. We proceed with the following sessions. are arranged outside. The session will continue in 15 minutes now. hall.
Dignitaries and delegates to gather. Next session will start. Ma'am, we can only speak to you, no, because she's sitting at the wherever the market is happening. Like we have.
You're on the way.
I kept already one.
elbow के पास से photo भेजो। हाँ, correct match मैंने color। उन्हें match हो रहा है क्या नहीं? हाँ, तो continue करो। ಇಲ್ಲ ನಡೆಸೋಣ ಇಲ್ಲಿ ಬಾಟಲ್ ಇಡಕ್ಕೆ ಹೇಳಿ ಅವರು ಟಾಕ್ ಮಾಡ್ತಾರಲ್ಲ ಅವರು थैंक यू सो मच ऐसे करो इसके बाजू में पाइप के सामने बॉक्स आता हाँ बॉक्स आता और बॉक्स के बाजू में लेफ्ट या राइट में ये आता हाँ रोटर पर अभी एक काम करो तुम केबल बसता है ना तो काम करो तुम सिर्फ कैमरा के लिए आप ये बिठाओ बॉक्स बिठाओ वाईफाई के लिए नको और केबल देखो केबल जो बसता है ना पाइप में वापस रिवर्स डाल के रखो हाँ तो ऐसे करो उधर सिर्फ ना एक ड्रिफ्ट करे जैसे 1-2 फुट रखो बस ओके और ट्रे के साइड
significant public health issue with a prevalence rate ranging from 1.0% to 2.7%. On this note, we begin with our second session. I request Dr. Anand Puranik Mat sir, consultant at Kodikni's Eye Center, Belgaum, and Dr. Minashi Sonad ma'am, consultant at District Hospital Vijayapura, to come to the dais for chairing this session.
Good morning, everyone. So after a very informative session on cataract surgery, let's move on to the next session, that is low vision aids. I request Dr. Sanjeev Kulkarni sir to start his presentation.
Good afternoon, everyone. This topic is a little away from the main topic, that is the recent advances in cataract surgery or phaco surgery. So the topic given to me is low vision aids in clinical practice. Yes. Yes. Okay. Today's topic I'm going to talk is about the low vision aids in clinical practice. What is low vision? It is the best corrected visual acuity of less than 618 to light perception plus, and a visual field of less than 10 degrees from the point of fixation. In 2020, the prevalence world over visually impaired were around 220 million, and low vision was around, out of that, 175 millions. Totally blind were 45 million. So for each and blind person, an average of 3.8 people have low vision. As you can see, this is the age prevalence. As the age advances, the prevalence of low vision is more and more. What are the usual symptoms? What the patient complains when he comes to the OPD? He complains that difficulty in reading, driving, walking, and inability to recognize the familiar faces in spite of the best visual correction. After being the best surgery done or the refractive correction corrected by means of glasses or medication, whatever it is, the expected vision is not there to the requirement or need of the patient, then he complains all these things. What is the purpose of low vision? Rehabilitation. It is to minimize the functional impact of the visual impairment on patients' lives in promoting and maintaining independence, productivity, and life satisfaction. So this low vision rehabilitation is mainly visual rehabilitation, motor rehabilitation, occupational rehabilitation, and social rehabilitation. So today I'm going to talk out of 4 only about the visual rehabilitation in low vision. What type of low vision the patient may have? So one could be the loss of contrast. You have a slide change or laser beam. Okay, it could be loss of contrast like this, or this is a loss of peripheral vision, or this can be loss of central vision as this picture shows. So the reasons may be variant. It could be macular degeneration, age related, or chororetinal scarring, or diabetic retinopathy with macular edema or myopic chorioretinal atrophy, or it could be optic atrophy due to many reasons, or glaucoma, glaucomatous atrophy, or retinitis pigmentosa, or it could be injury or surgery, whatever, if the eye was involved earlier. When the vision cannot be corrected to the expectation of the patient, we call it as a low vision. How to evaluate the patient with a low vision? We have to have a structured questionnaire like date of onset and progression of visual loss, details of diagnosis, investigations and treatment taken, age, educational status and professional requirement, whether the loss is near or distance or both, it's more in more light or bright light or less light, and visual activities including the ability to move independently indoors and outdoors of the patient, medical, social and psychological buildup of the patient. But most important is the exact requirement and expectations of the patient. We should have all this before we start the low vision aids trial. How we measure the distant visual acuity? Normally, there are so many charts, Bailey, Low, Logmar, Bosch and Lomb, Sloan, Staub, Ferrell's, Bailey and other things, but we use Snellen's chart in general, most of us in our clinical practice. Usually we test it for 6 meter distance or 20 feet, but for low vision patients, it can be 3 meters or 2 meters, sometimes even 1 meter also. Near vision, there are Sloan's M charts, Killer charts, and modified DRS charts, or what we usually is Jiger's chart. How do you, and one more important testing is the visual field testing. For central vision, we use the Amsler's grid at 33 centimeters, useful to recognize the metamorphopsia and small central scotomas. In low vision aids, obviously, most of the patients, we cannot do the field analyzer testing because the vision is so less, they may not be able to fixate on the target also. Any of these patterns we can find when we test with Amsler's grid, depending on what how much macula is involved. For example, this is a 8 years old boy. Right eye has got central corneal opacity. Optical iridectomy has been done pretty long time back in the right eye, and that eye has eccentric weaving. And left eye is anophthalmos. The best corrected visual acuity in this patient is finger counting at 4 to 5 feet in right eye with N8 at 1 inch distance. So this is the vision he has in the right eye, left eye is totally blind. So how do you test this patient? Usually we don't go, we try Snellen chart, then start at 3 meters. But this is how you test the field of vision. Left eye I'm not covering because it is anophthalmic. It's you should have the patients to test the field of vision in these people, because fixation is abnormal and eccentric viewing is there. You'll have to keep on repeating the test. And this is one more patient where the vision has to be tested. It depends on the IQ of the patient. Then central and near vision field of testing has to be done. What are low vision aids? It's a device that improves or enhances the residual vision by magnifying the image of the object at the retinal level, and anything that helps in enhancing the visual performance of the person. They can be of 3 types: non-optical aids, optical aids, and electronic aids. What are non-optical aids? There are some retinal conditions where just by increasing the contrast, the vision can be improved. Like this is a concentrated light which is focused onto the point of fixation or the print. And this is a writing or reading chart where a slit is kept on the reading print so that he can follow the line without skipping. So when sometimes you can add all these three: increased illumination and proper working distance and the reading slit. This is a writing slit where the patient knows how to write and in a proper manner. And normally we write with a pencil or a ball pen or this thing, but for low vision patients, you can give for a student heavy thick felt tip or sketch pen so that he can read what he had written earlier. There are talking clocks and laws. These are all for the past. Now the things have changed. What are the optical aids? Obviously, for reading, you need to magnify the image. So these magnifying glasses can come in different shapes and different power. Handheld magnifiers. Sometimes it can be combined with LED light source so that you can have increased contrast also. Then high powered reading glasses. Usually what we give ad is a maximum 3.25 not for a normal person. But here you can go up to 5, 6, 7, and you should try it on the patient first. Obviously, when you give higher power, the working distance becomes less. And these are to be combined with appropriate prism so that the asthenopia is avoided. And this is a reading dome magnifier. One thing about these low vision aids is each and every device has its own limitation. Either it is portable or non-portable, and what is the strength? It can increase the size of the point of interest, print to by 2x, 3x or 4x. So with this reading dome, you can have up to 2 to 3x magnification. And this depending on the high powered lenses, if you use plus 10, it can increase by 4x, 4 times the magnification. You can have a flip-on glasses over the present prescription glasses for this purpose. Sometimes the patient may have hand tremors and all that, they cannot use a hand magnifier. So these are called the stand magnifiers. It has a fixed lens of 10 diopters or plus 10 or 15 or 20. Depending on that, the working distance becomes less, and some people, they feel it is happy, but here the illumination is not controlled. This is a Fresnel prism. This gives a magnification of 2 to 2.5x only. It's okay to some extent, but it comes with a LED inbuilt source, so contrast also can be increased. But most of the patients in my clinical practice, they don't go for all this. Most of the acceptance is for this reading dome magnifier or the high powered reading glasses or these electronic devices, like we call it as digital video magnifiers. It comes in different sizes, like a 3.5 inches this screen or 5-inch. Like an old patient who cannot read the glucometer reading also, or he can't read the prescription on the medicine tablets also. For them it is very handy and they can follow it. Or a old person goes to a shopping mall, he doesn't know the label and the price also. It has so many different uses. Okay. For near vision, first you assess the existing vision, then field of vision by Amsler's grid or the finger counting field, peripheral field. Then for this person, he needs, his working distance. As you ask him to read, he has a tendency to bring it nearer and nearer. Say if he holds it at about 10 centimeters, as you know, plus 10 has a working distance of 10 centimeters. So you can increase the near vision glasses up to plus 10. It gives a magnification of plus 4. But here you are compromising on the working distance, but somehow you have to make him read. The next one is a reading dome magnifier. With the present glasses, this boy can read the print on the newspaper. This is a digital video magnifier, which is 5.5 inches. It's like a camera only, which can be, here the magnification can be increased, the contrast can be changed, and the background can be changed to green, blue or black or total contrast. So it is very, very useful device. For example, one more person with a boy of about 14 years with Stargardt disease, how to calculate to begin with? He has best corrected visual acuity 636 and N24. For distant vision, see, your target vision is 6/9. So if he has got 636 existing, you divide the denominator of the existing vision with the expected or the target visual vision you are aiming at. Denominators of these two numbers are used, divide these and you get 4x. So the minimum distant vision correction that the person needs to read 6/9 is around 4x. So 4x telescope you can give, monocular telescope or binocular. How to calculate for near vision? He has got N24, you are targeting at N8. So 24 divided by 8, it comes to 3x. This is the minimum. But for comfort, you again multiply it by 2, 6x. So as we know, for E 2.5 diopter plus, it gives a magnification of 1. To achieve a magnification of 6x into 2.5, that is 15 diopters. When you give 15 diopters prismatic glasses, 100 divided by 15, that comes to about 7 centimeters. That is the working distance. Then 6x loop can be given. Like earlier we used to use in the cams, 6x operating loop you can give. Otherwise, digital video magnifiers, nowadays they are easily available. So these are the telescopes, different size. This is called CTV. It has a fixed distance of not exactly fixed, but it can be focused up to 20 feet for watching TV and other things. But this has a magnification of around 2.5. These are again two 1 plus and 1 minus lenses. These are the glass, the frame fitted telescopes. This is what we call as Ocutec VES plus, where this has when the person wears and focuses at something, automatically it gets focused and it zooms in and zooms out. This is also very useful. These are the instruments for LVS for distant vision. So distant vision, you demonstrate it to the person, the patient, what best you can do with his present condition. Then the patient can choose. This is one device, as I told you, as CTV vision. See, this is the first time this boy is reading the Snellen chart in spite of all the spectacle correction that was given to him. And it's quite a hearty scene to see them smiling and being able to read. The same thing is applicable to reading in the classroom also. Even he is made to sit in the front row, he can't make out what the teacher has written. This one more person, he's 15 years old boy. He has polydactyly short stature and he has heart wall problem. He's extremely intelligent. So he fits somewhere into LLBB syndrome. Best corrected visual acuity is 6/60 and N24. For him, this is a frame fitted, this is a prismatic telescope and he can come up to 6/9 also. One more person with age 30 years, software engineer by profession. His high myopia, bilateral -20 is wearing. He can manage somehow computer work by increasing the font size but he has difficulty while attending the meetings and seminars. So you give him the choices, show him whatever device you have, and then make his life more tolerable. It's a Stargardt disease. He's a clerk and he is about to be thrown out of the job because he can't do his office work. Show him whatever. This is for distant vision and near vision. This is a +20 glass, aspheric glass, which can be fitted into small frame. But as you say, when you give +20, working distance becomes only 5 centimeters. So it has its own handicap, but somehow he can use it. Now, then the most popular is the digital video magnifiers. They come in different sizes. This is a 3.5-inch screen, and this is 5 inch, this is 8 inches. So these are cameras which can be portable and long lasting and quite useful for the patients. There's one more this thing. This device is called Acrobat Reader, where it has like a closed circuit TV with a focal length of less than 2 feet distance. So whatever print you give, that is transmitted and you can see it on the monitor. So magnification, there is no limit. You can increase it to 30x or 100x also. So depending on the requirement, you prescribe it to the patient, and this can be used. This is a reading mouse, like there's a camera fitted into the mouse. They can put just move it on the print, and that will be transmitted and seen on the any TV. So these are useful devices even for students also. So the neonatal cerebral hypoxia, all these years, they have visited many doctors and everyone has said this is best what we can do. We cannot do anything more. But if you have these commonly used devices, you can do something more for the patient and make his life more tolerable and livable. This is the operating loop, what we used to use, and some DCR and external terrorism, we can still go ahead with this. AMD, RMD, age-related macular degeneration. These people, they have enjoyed life and good vision till they are 60, 70, and suddenly there is some ARMD and central vision is gone. There is RP with macular involvement. The same procedure, distant vision, near vision, calculate, and depending on their existing vision, you start with the low vision aids you have. So we have a separate department for this in Joshi Eye Institute, Dharwad unit, and Hubli also they have started. So this is Mr. Bhatt. The same. He has got a dry ARMD, not progressive, and he wants to read somehow. It's albino with macular hypoplasia. He is 14 years old boy, 636 and N12 at 6 inches. Got nystagmus also because macular hypoplasia. He wears -5. So just he removes his glasses for reading. So automatically there is a magnification of 2x. But he can't face the sunlight. You can give a filtered glasses which are available in different wavelengths. So sight is next to life. You please protect it, save it, and restore it to the best maximum potential you have. Thank you very much.
Thank you, sir. Thanks for that very informative talk. The session is open for discussion. I request the audience to ask.
The BCVA has to be calculated, best corrected visual acuity for living at a low visual age or not. So who is the youngest children are? Because so many cases come with amblyopia and exanopsia in one eye. So how to assess them at the younger age?
What age? What age?
Vision, visual age.
No, what age?
What age you have to assess? Because they will be losing the vision. The earlier you assess, that's the better.
Yeah. At the earliest possible. That is why school screening is important. Even the undergraduates, unless if there is a unilateral visual defect, then the person or the baby or the boy may not be able to appreciate it. So individual eye has to be tested at the earliest stage. We started joining the school at the age of 6 years at first standard. Now the usually schooling starts at 2.5, 3 years only. They go to crush and ABCD. By the time they reach first standard, they would have studied 3 years. So detection is much easier now because that particular boy cannot perform equal to other boys. The teacher notices, and definitely parents are quite sensitive about it, and they are brought to the ophthalmologist.
Procedures for the younger children.
Like any other, if Snellen chart is there, at least they should be able to make out the finger counting or 1 or 2 or toys or something like that. No. Oh. Thank you very much for your patient hearing.
We request Professor Dr. Vallabh sir to present a token of gratitude to Dr. Anand Puranik Mat sir. We request Professor Dr. Vallabh sir to present a token of gratitude to Dr. Minakshi Sonad ma'am. With the strive for excellence in cataract surgery, the choice of intraocular lenses is a crucial in determining patient outcomes. With this, we begin with the third session. I request Dr. Umesh Harakuni, sir, consultant at Shri Eye Clinic and Harakuni Eye Center. And I request Dr. Malini Prabhugoda, ma'am, consultant at Anugraha Eye Hospital, Vijayapura, to come to the dais for chairing this session.
Hello. Hello, good afternoon. Before going to the session, just I want to tell something which we have experienced. When I was PG, so when the patient used to come, first we used to ask whether he wants IOL or a plain surgery. That was the days when we have faced it, when we are PGs. But slowly it has gone out. The IOL has become the mandatory. So once IOL has become mandatory, there are different types. AC IOL, PC IOL, like that. So the AC IOL they used to put, because of the so many complications, they have left the AC IOL. Now we have settled to the PC IOL. In PC IOL, again, there is a different conditions, like whether to put in the bag, in the sulcus, or the scleral fixated, like that. They have got their own advantages, but in the bag has become the best one now. So in that, again, there are many IOLs are there, like monofocal, multifocal, trifocal, EDOF lenses. So to clear which is better one, I invite Dr. Krishna Prasad, sir, to start the session.
No, before actually embarking on this, the prospects and pitfalls of these newer IOLs, I think I just told I'll just show a 5 minutes video on phacotrabeculectomy. I'll not cover it as a topic in later. So this is basically, I want all of you, including the postgraduates, to get acquainted with a combined surgery. See, we do get chances to do a combined surgery, like where you need to surgically manage the glaucoma also. It may be a patient of lens-induced glaucoma, like a phapomorphic glaucoma that you can see in this video. Or it can be a patient who is on multiple medications, may be controlled, may not be controlled with medications, and needing a cataract surgery. So if you are a good cataract surgeon, your threshold to do combined surgery will be very less. You will actually try to manage both the things together. At the same time, the standard narrative, like normally the postgraduate should tell, if the IOP is well controlled with medication, do cataract surgery alone, may not really hold water, because anyway you are going in and doing an intraocular procedure. You can always add the element of trabeculectomy. If the point is maybe it may not work, that's fine. But anyway, ಅದಕ್ಕೆ ತಗೊಳ್ಳ ಬರ್ಲಿಕ್ಕೆಲ್ಲ ಟೈಮ್ ಹಾಕೊಂಡು ಅಂದ್ರೆ ಅಲ್ಲಿ ಇದು ಮುಗಿಸ್ಬಿಡ್ಲ. So they want a full talk on that, so I'll do it that way. So I'll now go to the so this is actually as Dr. Arup said, we are only trying to give you some kind of a spark. It's not really the for the postgraduates, because there are a lot of confusions about IOL, and every cataract surgery actually we need to be very clear about what IOL that we need to choose, because patient will not choose, we will choose the IOL. So let's start with so definitely you need to use cataract surgery as a platform to add value. Okay, I just told you about astigmatism correction. Okay, so try to correct a problem which is already pre-existing. The patient may have a very high spherical aberration. So if you can correct spherical aberration during cataract surgery, use an aspheric IOL. The patient, obviously, after you knock off the lens and put a monofocal, patient will need glasses. If you have focused him for distance, you will require it for near and vice versa. And please do not underestimate the problems of spectacle dependence. Time and again, when we were kind of some 30 years ago, patients were very happy to see clearly with glasses. But now, okay, it is not like that. The patients actually expect little more. If somebody, see, it is not that they come asking for it. Unlike a metro, maybe Hubli, Vijayapura, patient won't come and demand, I want to see without glasses. It's not like that. But if you can make them spectacle independent, you can make them see near and distance both without glasses, they'll be definitely be happy. So maybe that we are under promising and over delivering if we can probably take care of this. So spectacle dependence is going to be the issue. And most of the old people with the bifocals moving around, taking stairs can get into trouble. They have motor disabilities, they have less motor skills, they have frail and fragile. So don't really make them fall and break bones because of your bifocal glasses. So all these probably is this is the kind of a time where we take off to understand. So obviously, I'm against the word premium IOL because that's a very commercial term coined by to kind of create a kind of a disparity. Like, are you not doing premium IOLs? Premium IOLs, no big deal. It's just a pricey IOL. Maybe its cost is little more, but if the patient needs it, it is the basic necessity for the patient. So don't really worry about this term premium. Your surgery has to be premium. So aspheric IOLs is, please understand, is a presumptive treatment of spherical aberration. Most postgraduates do not understand spherical aberration. Okay, our eye, okay, has different amounts of spherical aberration. It is at the time when they come for cataract surgery, it is around plus 0.2 microns. That is the value. It is always in microns. It is on the positive side. Okay, so because cornea is positively spherical aberrated, lens is negatively, with age it also becomes positive. So we have end up with some kind of a plus 0.2 micron for an average eye. But this is a presumption. Okay, so we have IOLs which have a negative spherical aberration. So most of the IOLs that have a Q value, what we call as around anywhere between 0.2 to 0.3 microns spherical aberration. So we assume that this patient has a positive spherical aberration and we implant a negative. It is not necessarily true. Unless I have done an aberrometry, I have really quantitated his spherical aberration. Doing this actually is not the right thing. So the future is a customized surgery. You have to do an aberrometry as a preoperative investigation. Only if the patient has a sizable positive spherical aberration, you use an appropriate IOL of a particular negative spherical aberration. If the patient has almost no spherical aberration, then putting a negative spherical aberration, you are actually overcorrecting it on the other side, right? And some amount of spherical aberration is not bad at all. You please understand, some amount of spherical aberration gives them pseudo accommodation. So some spherical aberration increases the depth of focus. Even though it distorts the quality of vision to some extent, it also increases the depth of focus. So that could be one way of looking at it. So you don't have to really correct all spherical aberrations that you want to. And please understand, we don't have a Pellier-Robson chart. Sneller's chart is a 130-year-old vision chart, completely black and white, 100% contrast chart. But our patients don't see things in real life in 100% contrast. So that's why the patient after my cataract surgery, in my clinic, will read 6.6, but he always complains, I can't see well. When he goes out, he can't see because he has a thin PCO, or he has a fold on the posterior capsule, he has a deposit on the eyeball, or he has a mild nebular corneal opacity. His vision is in real life, in the normal contrast, is very less because we don't use Pellier-Robson chart in our clinic. The day we use Pellier-Robson as a standard way to measure the visual, performance, then we will really come to understand the patient's problem much better. So toric IOLs is a great tool for astigmatism, and all incisional procedures, with no disrespect to anyone, they are bad. When you cut the cornea, you induce aberrations. You induce some amount of irregular astigmatism. You weaken the cornea. And the amount of incision that you need to make on limbus or mid-peripheral cornea is so much so that you are actually disturbing. Cornea should be pristine. The more you damage the cornea, anyway, you have to make entries, that is immaterial, that is minimum that you need to do. But any other incision that you do will actually weaken, and please understand they don't last long. There is a regression, the cornea heals, all that keratometry changes you have immediate post-op will come back. But the patient is not happy because you have added more aberrations. His quality of vision will be actually poor, even though astigmatism may be less. So cornea-based astigmatism control is not the way to go. It has to be lens-based. It is not the market pressure or the companies forcing us to use our toric IOLs. It is the physiology that makes us. And obviously we have very good polymers which sticks to the capsule. You don't move. There's hardly any misalignment. And we have a lot of digital marking systems to get a better thing. And obviously it should be the standard of care. And what is the cutoff? How much astigmatism should be left uncorrected? It's your call. At least more than 0.75 diopters of cylinder. If you don't correct, there's a definite decrease in even though it causes some pseudo accommodation in the myopic side, but still there's a definite degradation of vision. And if you are using any trifocal or a multifocal, this has to be corrected 100%. Otherwise, you will never get the actual benefit of it. Right? So, especially if you have a very large astigmatism, corneal scars and corneal pathologies. So no amount of good cataract surgery will save the patient's vision to the satisfied levels. And huge market potential, low penetration. And I told you how you tell the patient. You basically explain that the keratometry problem or the astigmatism is the patient's problem. And if he wants to get it corrected, there is an opportunity and you can monetize this opportunity. So now earlier when we were young, PC IOL was posterior chamber IOL. Dr. Umesh said there was AC IOL, PC IOL. Now if you say PC IOL, it only means presbyopia correcting IOL. That means to make patient good for near. So whether it is a trifocal, a multifocal or a head-off. So it's always a confusion among the postgraduates. What is a multifocal? What is a trifocal? Okay. So there's a lot of confusion. I mean, most of them you may know, but still for the people who do not know, there's no difference. Only thing is the intermediate distance. See, the multifocal that we had earlier, like we have array, we had all this Technis multifocal. Basically, they had fairly good near vision, good distant vision, but the intermediate, the distance was focusing at around 80 centimeters. Okay, 60 to 80 was a little far off. That's so the normal intermediate distance of around, let's say, 50 to 60 centimeters, they were not able to see well because optically they were focusing a little far. So they made some modifications in the optic so that the intermediate focusing point was brought to around 50 to 60 centimeters. Okay, so it is a multifocal which focuses around 60 centimeters for intermediate. They had to call it by a different name to say that it's a different IOL. So they called it as trifocal. Zeiss came with a new technology which had a better intermediate vision. They called it as Zeiss trifocal, just to differentiate it from multifocal. So now all companies have followed suit. So you have trifocal, like you have Panoptics from Alcon. Okay, you have the Optiflex Trio from Biotech. They are all trifocal lenses. So trifocal lenses mean the intermediate is better than the previous generation lenses. That's all. Okay. So today we don't use multifocals, we use trifocals. So they asked head-off versus, so people will come and ask, sir, which one my father should get, head-off lens or a monovision or a, so they want a simple answer. Okay. If I say, who is a better batsman, whom do you like? Whom do you like? Each have their own. Who's a better singer? So first you understand multifocal, I mean trifocal. What are the problems of a multifocal? First is it's pricey. It is not to be taken too seriously because patient is spending once in a lifetime. Okay. Number two, there is a decreased contrast because all the light is not going to one place. In a monofocal, all the 100% of light get focused in one place. Here, because of whether it is a apodization or some different optics, there is a breakup of light at different distances. So there is a sharing of light. So obviously decreased contrast comes as a baggage. You can't do away with it. Some waxy vision people will have, halos and glare. See, don't try to attach too much. Any lens with a rings will have halos and glare at different pupil sizes, especially in the pupil dilates, especially in the night, scotopic vision, you always have halos and glare. One thing, please understand. Let's say we ask a patient, do you drive at, do you drive at night? He'll say, yes, I drive at night once in a while. Tell me how many of our cataract patients drive at night compulsively every day from Vijayapura to Bagalkot or to Hubli? If he can afford a trifocal like Panoptics, he will keep a driver, right? So for his, ability to see near without glasses, having an excellent vision throughout the day without glasses, that's a small price to pay and he will make that necessary lifestyle adjustment. So don't take those things too seriously. At the same time, when the patient, you tell them there's halos and glare, when they Google that there's halos and glare, it always comes. Most of my patients are unaware of halos and glare, they never have it. They may probably reluctantly say, sir, I see some rings. I say, when the patient says, I'm seeing rings, okay, you know what I'll say? I'll say, very good. I show very excitedly, I say, I'm very happy. Oh, you're seeing rings? Very good. Then that means the multifocality is working. Then you must be having a very good near vision, right? They say, yes. See? That will go away. So, which is true, right? The reason they have rings, they are seeing for near without glasses, and that's the same reason they are seeing halos. So, these things may not matter to most patients. At the same time, there are some patients who are, little crackpots. So what are the basic criteria? See, if you want to have a happy trifocal presbyopic correcting IOL patient, this is most important. If you follow this, you will never be unhappy. Patient may be happy or unhappy. You will not be unhappy. So one is look at the cornea very carefully. Very carefully. Just don't have a cursory look. Look at the cornea, the transparency, sheen, surface. Very important. Ocular surface is extremely important. Tear film extremely. There may be fine nebula, which may not do a sclerotic scatter and see. A fine nebula in the center can completely mar the whole, effect of a trifocal, which is not actually, you're not seeing it at all. So look at the cornea, it should be pristine. If the cornea is not good, if the cornea has a lot of aberration, which you'll never know unless you do aberrometry. If you have an astigmatism more than 0.75, you need to use the toric component of the trifocal. So this front cornea is extremely important. This is the reason for most of the dissatisfaction. Regular astigmatism, it should not be irregular. It should not have any scars, minimum aberrations. Okay. Angle alpha. See, for the youngsters, if you're not having all kinds of that tight trays and things like that to imaging devices for alpha, just put a torch, ask the patient to look at the light. You can actually see where is the center of cornea. Like cornea is there at a close, do you know where is, you can just approximately know where is the center of cornea in that patient and where is the Hirschberg reflex. Are they coinciding or not? Right? If they're coinciding, your alpha is very less. The gap between the center of cornea and the Hirschberg reflex is alpha. The optical axis and the visual axis. So you may not need any instrument. Like I know that I have seen, we have picked up alpha with a torchlight in many patients. With 0.8 point, you will come to know the Hirschberg reflex grossly decentered from the center. It is not at least focusing right on that. So you can do that basic thing. Just put a torch, ask the patient to look at the light. Where is the center? You just make a thing and try to find out where it is. It's more than 0.5, then it's a no-no for the thing. Because your lens will center to the anatomical centration. It will center to the center of the bag. But your Hirschberg reflex is the visual axis, which is going by the side. Your Hirschberg reflex or your visual axis should go to the center of IOL so that you get the actual optical benefit. Because you put a lens, however you put, you can't put a lens in the intentionally decentered way. You can't center it to visual axis. You can only center it to anatomical axis. The difference is the angle alpha. So just look for it. Most times, and healthy tear film, very important. If you have bad shirmas, you have TBT, very significant, these patients will be having a terrible time. Then, very important, it is not that your lens is stable at the end of the surgery, like our OPL videos. Kal kya hoga kya jane. You just try to put it there, it's fittings, okay, end of the surgery, khatam baat, video is over. No, it should be stable for the lifetime. Because if a monofocal lens tilts, it only induces astigmatism. It causes a negative cylinder perpendicular to the tilt of the axis of the tilt. That's all. Only it produces a regular astigmatism, any tilt of monofocal. But any so-called premium eyeballs, be it aspheric, be it toric, be it a trifocal, if it tilts, it induces aberrations from the internal aberrations, which cannot be corrected with glasses. Patient will have a terrible time. Lot of ghost images, halos, and a subnormal vision, and a decreased contrast because of the tilt. So you cannot afford a tilt of the IOL post-op. If you find a hypermature cataract, if you find a severe PXF, if you find some kind of a PC rent where you try to manage, okay, we have seen people trying to put trifocals in a dangling IOLs in a bad capsule zone. You'll know. I think Sir has a talk on that. We'll come to that. So stable capsule zonule for a lifetime. And CCC. So this is where a femtosecond laser cataract comes in. CCC, I was asking yesterday one person for postgraduates to SICS, what is important? The size of the CCC or the shape of the CCC? She was thinking, I gave her an example. See, if you are making a chapati to feed somebody, what is important? Shape of the chapati or size of the chapati? The size of the chapati. Shape can be anything. So when your rex is, here both are important. It should be centered to the visual axis or to the IOL. It should be around 5 millimeters. So you have at least 0.5 overlap. If you do more than 6, you go one beyond. So that can create an asymmetrical thickening of the margin of the CCC and can cause a tilt. Why? Because there is always a fibrosis at the margin of the CCC. And if it is uniform 360 degrees, it pushes the lens in the uniform way. If the the rexis goes outside of one of the margins, then there is an asymmetrical, okay, or an imbalance in the that pressure that is exerted by the fibrosed CCC margin. So that is very important. And back, macula, it should be immaculate. No DME, no CME, no CSME, no ERM, now or in future. Like you have a very bad diabetic, okay, he's extremely bad diabetic, very young diabetic, very likely he's going to have, a plethora of his diabetic maculopathy going on and on. The retina surgeon will be injecting 30 times anti-VEGFs. So this patient will have a tough time. But there's a small twist to that. If the patient really needs spectacle independence, they can still manage the macula. But don't count the number of injections. Okay, that is not your problem. But at the same time, if you really are going to have a bad macula for the rest of your lifetime, no. And most important is this. Patient is too fussy, asking too many questions, equating money versus the vision outcome and all that. So what we need is, who will not ask you any question, will pay you any amount what you want. If you have a such patient, please send it to me. But postgraduates, we are talking about all this, but I get patients. I would have planned a monovision. Okay, one eye 6.6, one eye plano, other eye I made -1. But for some reason, biometric error, I don't know what, the other eye is also a metro. Both are 6.6 for distance. Autorefractometry is plano. This patient is going to have a tough time, right? I have knocked off the IOL, lens. So this patient is metro for distance. His near vision will be very bad, right? But surprisingly, this old man comes and reads Samyukta Karnataka very easily. He will read N8 comfortably. He's 6.6, both eyes bilateral. Near vision is N8. How did it happen without correction? So that we call it as pseudo accommodation. Believe me, most of our old people who come to us during the cataract age group have a great amount of pseudo accommodation. Don't underestimate this. So all the spectacle independence with IOLs is out of the window now. This man is reading N8 without any such pricey IOL. How? That is because they have very small pupils, meiotic pupils of senility. That small pupil is like a pinhole effect. It increases the depth of focus. Have you checked? A presbyope wants to see near vision. He has lost his glasses. With a pinhole, he can see near vision. You know this? So it increases the depth of focus. So basically, a small pupil, actually a small pupil is useless for multifocal because all the rings will not be exposed only. If somebody has a senile meiosis of 1 millimeter pupil normally, so don't try to put actually a multifocal because the rings have to be, you have to put the patient on homotropic to keep it away. Otherwise, all the rings are not exposed in the normal, photopic vision, right? Number two, a small minimal myopic. I told you astigmatism need not be corrected fully. A small 0.5 to 0.75 of myopic astigmatism is a great tool to see near vision. It won't affect the distance much. He'll be still 6'9", but he can be at least N10. Okay. And this is spherical aberration. I told you spherical aberration is a friend at times. Spherical aberration is like myopia. Okay. You know, night myopia. Night myopia is because of spherical aberration. So a small amount of uncorrected spherical aberration is not bad at all. Okay. So it gives you pseudo accommodation. So this is something that you should keep in mind. Okay. When you are planning all this. Now the EDOF lenses. This is a new, kid on the block. EDOF lenses is somewhere in between. I try to oversimplify, I'll not go into the technicality because they're postgraduates here. Trifocal is on one side, monofocal on the other side. EDOF is somewhere in between. Here there is basically an HLED design where they basically try to increase the depth of focus by working on the spherical aberration. EDOF lenses create spherical aberration. Do you understand? I just in the previous slide I told your pseudo accommodations because of spherical aberration. So can we create it in a controlled fashion so that it is useful without disturbing the distant vision? So they create a controlled spherical aberration so that that depth of focus is actually extended. So that's why we call it as EDOF lenses. They tread the middle path. And normally they won't give you N6, N5 vision. There are around N8, N10 vision, which is good for mobile work with a slightly higher font. Okay. Teach the old people how to increase the font size in the mobile. They will be happy, right? And all the selection I told you, pristine cornea, capsule zonule, macula, you can definitely do a small, exemption for EDOF lenses. If a patient is, let's say, night driving, as you said, compulsive driver, macula is not all that great, capsule zonule is slightly A, cornea is not that great. So patient still wants, it's better than monofocal, you can put an EDOF, but don't expect too much from an EDOF lens. It is somewhere in between, okay? What we call as a chinicum, no? Like it's neither a sugarless tea or nor with a lot of sugar, somewhere in between, okay? Which is neither this way or that way, okay? But still works. And it only on, see, all trifocal lenses should be assessed on a binocular implant. Uniocularly, that is not. It's 1 + 1 is equal to 3. So it's always on a binocular implant, you should assess the patient. If the patient is not happy with one eye surgery, what will you tell? Get the other eye done. So there's no comparison, right? So pitfalls, light scattering. Problem is, each one will claim their IOL to be the best. I've been using a XYZ IOL. I'll put it in the group. Hey, my patients are very happy. Because there is no way, because as a surgeon, I can't really visualize what the patient is seeing. I told you in the morning, the patient's subjective happiness is an outcome of his personality or his mindset, not your visual performance. Patient may be happy with 660 also, maybe unhappy with 6.5 also. Right? Patient may be happy with halos and glare. So basically, if you're a happy person anyway, you will be happy anyway, right? So this is very important. What the patient wants from the surgery is very important. Okay, that's the problem of our pricey packages. Our surgeries are very pricey, very costly. Then you have this problem. Patients are unhappy because they don't get the deal right. Okay. So finally, if a patient is not great for these trifocal or EDOF lenses, then we can go to good old, understand monovision. Monovision also is a good option. Okay. monovision is a good option. We have two things. Normally, we used to make earlier -2.5, but that will cause too much of difference. So we normally make it micro or nano monovision, where you make the eye slightly myopic. Because nowadays, nobody's reading this very small print. They're all reading their Facebook, Instagram posts on the mobile, which has a higher contrast. They can increase the size. They can always do this. Okay. So when you can do this, monovision is also fine. Right? So for you, you should know how to check an ocular dominance. There are a lot of surgeons who don't really follow this. The eye which is emmetrope should be the dominant eye. The eye which is non-dominant should be the myopic eye. But this is your option. Okay. But finally, I am a strabismus surgeon. Let me tell you something from the side wing, what people don't talk, what cataract surgeons don't talk. Monovision, I said, is okay. But there are a lot of problems of monovision too. I really dread anisometropia. Okay. If you create asymmetrical refraction, one is myope, one is emmetrope, one is -1.5. Please understand our binocular vision can be greatly disturbed by this anisometropia in some select patients. You may create a new ocular imbalance instead of when you're trying to give a spectacle independence. And stereopsis. How many patients we actually check stereopsis in a post-op in a bilateral implant? We hardly check stereopsis in adults, right? Start checking stereopsis, you will understand. So we say that 2020 is our goal. 2020 vision. For strabismologists, we had another 20. 20 is our goal. Patient should be 2020, should be having 20 seconds of an arc of stereopsis. That is our aim. So don't try to create a problem or a hurdle to stereopsis by making this anisometropia too much. And you have to use glasses also, even if you're having monovision. But the people always have a problem. Initially, I can see with this, they compare and create problems. So contraindication for monovision, anitropia. See, it doesn't make any sense. If the patient has a manifest squint, okay, it doesn't make sense. Because patient is using always only one eye. So that you basically see, idea of monovision is not to create just one for near, one for distant. No, we have to create an eye which is cooperating for binocularly. Still have an anisometropia, manageable anisometropia, able to give him a better near vision. This is important. If you make one eye 0 and other eye -3, it doesn't make sense. So you need to create only that much myopia, and both should work. In a tropia, that means a manifest strabismus, they are not working together. So the monovision falls flat. Okay. Any previous squint surgery obviously means that they don't have stereopsis. Any phoria, you're going to break this phoria into tropia or enhance this problem. And any prism usage, all this. So worth 4 dot test, and wherever possible in a pre-op patient. This is something important, if you plan a monovision. And 4 prism diopter base. So there are a lot of microtropias lurking around there. If you have not done this, and all of you can work on each other, take a 4 prism diopter, put it base out and try to see what is the normal response. Do it on the patient. Great day to find out microtropia. At least Bagolin stated classes will tell you he has a binocular vision. Ask one question. Because when the patient will come with advanced cataract, they will have poor vision. Please tell him in childhood, did both eyes have equal vision or one was weaker than the other? This will tell you should be going for monovision or not. Okay. So monofixation syndromes are quite common. And if you have a long-standing unilateral traumatic cataract, obviously the binocular, thread is broken. If I have the amblyopia in one eye, don't use this. And Parkinson's. See, Parkinson's patients have a lot of problem reading. We think we'll start looking in the eye. It is not inside the eye. Parkinson problem also have a problem in a steady fixation. Okay, not tremor. So they have basically a problem in trying to, even the Graves' disease, they have a problem in the ocular motor problem. It's not actually a vision problem. So in such situations, monovision can create more problems. Okay, so what should we do? Premium eyeballs is the way to go, if you can call that way. Please correct astigmatism, spherical aberration, and spectacle dependence. They're all dispensable, and you should always look forward to, because patient gets only one chance. You get another patient to operate, but the patient will not get another chance in that same eye. So always take your time, make a proper decision, an informed decision, and a decision made out of scientific facts, not out of your, whims and fancies. preoperative fusional deflection should be always checked. Always check the octave balance before cataract surgery. 20-20-20. That's your goal. And if you are in doubt, take an EDOF route. And it's a we are underutilizing presbyopia. I'm a big, champion of or a supporter of presbyopia correcting IOL, not for any kind of commercial reasons, but for the experience that I've got. In fact, there are a big chunk of patients who are presbyopes and hyperopes above 40 years, having trouble with the thing. So there is a small percentage of patients where you can actually prepone their cataract surgery and give them a total spectacle independence for life. Okay, thank you very much. Any questions? So I will.
We are sorry to interrupt, but due to the delay in session timings, we won't questions for discussion right now. All questions.
Okay, sure. Thank you. But please ask question in the end.
We'll start our session. Intraoperative floppy iris complication while during surgery. How to tackle with the floppy iris syndrome. Please, I'll call upon Dr. Arup Chakravarti to elaborate this floppy iris.
So a very good day once again. I'll start off with a video demonstration, a video film which brings out aspects of small pupil phacoemulsification in all its gory details. This was, I think, about 20 years old now video. Both the talks, huh? Okay. So this is actually a very old video, and I'm sure, the senior phaco surgeons would have encountered this kind of scenario before knowing what exactly it was. We had the people coming down floppy, iris chafing, and some people I've seen in OPL videos, that whole iridal dialysis has occurred. So then later on, I got to know what this condition exactly is when David Chang and his associate published their work in JCRS way back in April 2005. So this was a landmark presentation, publication, and I really request all of you to go through this publication. So this was the first time it was shown that there is a strong association between IFIS and systemic use of one of the alpha A subtype specific blockers, that is tamsulosin for BPH. So basically what was happening was patients who were being treated for a BPH were landing up in this kind of complications more often than patients who were off BPH. So then it was found out that basically all these patients who had this IFIS syndrome were on alpha 1A subtype blocker, and that was responsible for the intraoperative problems. So it is important for us to know that we need to do a preoperative work for all patients, for cataract patients, that whether the patient has got BPH or not. So since that time, we have classified small pupil into two types: the non-IFIS type small pupil, which is the traditional concepts of small pupil, and then the IFIS category small pupil. There can be an overlap and crossover in between both these groups. So basically, what the 2005 paper brought to light was there is a category of drugs which patients are on, which can result in IFIS-like syndrome, and these are basically the alpha agonists. So what was happening earlier was these BPH patients were receiving non-selective alpha blockers. You know, they were terazosin, doxazosin, and these systemic blockers had a very high absorption profile from the GIT. So these were also blocking the smooth muscles of the blood vessels, and there's postural hypertension. So they were looking for something which is uroselective, something which is which is specific for the selective the receptors in the prostate and bladder and all that particular trigone and that area. So they came across, they started tamsulosin, and then it was not known that time that same receptors are also present in the iris dilator muscles, in the smooth muscle. So it was basically a coincidence, and then we found out, the surgeons found out that the dilator muscle was getting blocked, and ultimately, IFIS-like syndrome developed. So it has been found out, the IFIS has been noticed in other kind of scenario. Other patients who are using benzodiazepines, QT-pin, antipsychotic medications, finasteride, and all that. So now we have prepared a list of all the medications that are capable of giving rise to IFIS, and it is put up in the counseling room. And this is just to catch all these patients who are IFIS, potential IFIS candidates. Sometimes, many patients go through this net, and still we find out on the theater that when IFIS is happening, and then you call somebody, and the patient's bystander, yes, he has been receiving, but he has stopped, and we thought it was irrelevant for us to tell you all this information. So, but it is a better approach, to be fully aware of what has to be done. Now, this is I do a lot of patients, small people cases like many of you here. So I always look forward to what are the new updates that are coming, because there are certain things which come up in peer review literature, and you're not really sure what you hear in the peer groups, whether they're correct or not. So once you see it in the literature, then they can be taken seriously. So 2 peer review literatures came up, 2011. I learned a great deal from that. Then last one was 2012. So basically, the summary for this, the learnings from this particular meta-analysis was, and a few old findings to confirm that it is seen in the males more. It is also seen in females, mind you, but it is seen in males more. Hypertensive patients with decreased dilated pupil diameter. So I'll be coming to it a little while from now, more in greater detail. What exactly? This is a new concept. So what exactly is meant by decreased dilated pupil diameter? Okay, then any patients on alpha-1 adrenoreceptor antagonist, tamsulosin, we have already discussed with benzodiazepines, finasteride, antipsychotics. Okay, so now another thing that was revealed by this particular study was that surgeons had taken certain precautions intraoperatively to reduce the incidence of IFIS, and there's no justification for that. There's no evidence supporting these acts. For example, discontinued tamsulosin, it did not help the cause in any way. Use of topical atropine, it was of no use. Intracameral epinephrine did not help the cause, and preoperative topical NSAIDs also didn't prevent IFIS from happening. So this is a very important concept. And now I basically, most of my IFIS management is based on this particular concept. So in the literature, it has been mentioned that, maximum dilated pupillary diameter is very important. So IFIS can be seen if the pupil doesn't dilate beyond 7 millimeter, according to one study, beyond 6.5 millimeter in another study, and beyond 8 millimeters in another study. Okay. So I used to meticulously, measure the pupillary using from the ASPs and using the formula proportions, till I came across this paper, which was published in 2018, which said that intuitive pupil to limbal diameter is enough. That means you don't really have to measure. You just under the microscope you see, and you measure the pupil to limbal diameter. So this is what it meant. This is the limbal diameter. Okay, from here to here. And the blue cord that you see is the pupillary diameter. So this ratio should be more than 60% for you to proceed without any further modification to your surgical approach. If it is less than 60%, then you have to modify your approach. So this is something that I follow meticulously. So even if the patient is not IFIS candidate, classical IFIS candidate, but still if I find that pupil hasn't dilated beyond this, so now I know it is going to be an IFIS candidate, and I'm going to have to take precautions. So, okay, so precaution means I'd be using Phenocan Plus or T Ultra for these patients. Morning I had referred to this when I talked about intracameral anesthesia. So this is basically a combination of tropicamide, phenylephrine hydrochloride, and lidocaine hydrochloride for injection. And in cases where the pupil is really small and there are a lot of comorbidities, intermittent cataract, poor cornea, very hard cataract, very shallow anterior chamber, bad experience in the previous eye. So I would straight away go with a pupillary device. I've used all these devices, but my go-to device is always an IRIS-6. I'll be using 4 or 5 IRIS-6 to start with when I start cataract surgery phaco for these IFIS candidates. Now, this is a video I've shown, but I have subsequently got many more videos which I have to edit and show. Now, this is basically a candidate whose AS anti-segment picture was shown earlier. So this is under topical anesthesia, temporal clear corneal approach. So latest patient is very cooperative. So let us see how the surgery goes. So I made the inferior incision, paracentesis, and the superior paracentesis is small. So you have to ensure that there has to be a tight fit between your instruments that go into the eye and the incisions. So the superior one is little small because I'm going to be using the Sinskey hook for this. Then I injected I think Xylocard, but that time I still had not started using the Phenocan Plus or T Ultra Plus, etc. So I just injected Xylocan with the patient's eye to make the eye harder. Morning I told you that you need a hard eye for you to make a good and a sharp blade for you to make a good incision. So I applied counter pressure on the nasal side and then temporarily 2.4 millimeter incision. Incisions have to be absolutely properly constructed here. Now, if you see carefully here, I've done trypan blue staining. As I wash out the excess trypan blue, the pupil has started coming down. And so I know that, I have to be on my guard and, be very alert and manage the complications or difficulties as and when they arise. So fortunately for me, I didn't have to use IRIS-6 now because viscometriasis gave me sufficient pupillary size for me to do a safe capsular excis. And once after the excis is over, next thing is, you have to ensure that you, when you perform hydrodissection, you have to burp out OVD from the anterior chamber. You do not want a very inflated eye. So I had done all that. And then when I started doing hydrodissection, you see the stenting of the subincision and iris tissue here. People will be coming down further. So this is definitely going for going to take a very complex path, surgical path, and I have to be really prepared. Patient has been very cooperative. Patient doesn't know what all is happening. So here, for example, the iris had come up, the AC has become shallow superiorly. So I decided to go ahead with phaco. Now I am grabbing the corneal incision, and so that there is no pressure gradient created between the anterior chamber, and the external eye, the congenital fornix. Otherwise, if I stabilize the paracentesis on the superior side and go into just pushing the phaco handpiece, there will be pressure gradient, egress of OVD from the eye. And whenever there is such a pressure gradient, iris will follow. All main incision and sometimes the other incisions when you're working through the side ports. Okay, so I would ensure that I do not go in and out of the eye too many times. Just normally, like after about a minute is over and still have not made much progress, lot more work to be done on the nucleus, I would inject OVD into the eye, but I'm not doing anything like that because I want to minimize my entry and exit into the eye. Same reason for that. I don't want to be creating a pressure gradient. Now, please watch. So this is, can you see the reading of 30 here? So the 500 cc pouch it contains only 30 cc of fluid. And normally my dictum in my theater is whenever I start a complex case, we take a fresh pouch for the Centurion machine. So some of that was violated. And at one point, I realized that my fluid is over. So I had to come out of the eye. By that time, they were setting up the machine once again. And I was just waiting. So whenever iris prolapses from the main incision or from the side port, don't try to reposit from the same approach, from the same route. You go 90 degrees or 180 degrees away. And as you will see here, me doing it and then trying to reposit it. So like, for example, the temporal iris, which is caught up in the section, is deposited through the superior paracentesis using a Sinskey hook. So that is done. So by this time now the pouch is full. So now I'm going inside the eye. And another thing that you have to be careful about here is there will be small chunks, pieces of nucleus. Now the pupil has come down. There is arca sinalis. There will be stromal hydration in the area of the paracentesis. And there may be collection of the chunks of nucleus in the posterior chamber. So they will resurface only in the postoperative period. So my entry was smooth. Some amount of iris chafing has occurred, but that could not have been avoided. So phacoemulsification is going on. So now at this stage, if the surgeon feels that the view is not adequate, the surgeon is not very comfortable, one can always use an iris hook or any pupillary ring device to enlarge the pupil. So that iris hook can be used at any stage in cataract surgery. So the last chunk is removed very carefully. Make sure that there is no surge that is happening by altering the parameters. So the nucleus has been sort of taken out. I think there's one small chunk hiding under the paracentesis here and the incision here. So be very meticulous and take them out. Now, if you're planning to use an iris hook or a pupillary device at this stage, there's a danger. See, iris hook, when you try to engage the hook around the pupillary margin, if the rhexis margin is also close by, you will also hook the rhexis margin. Okay, so if you're not aware of that, then you will end up with a rhexis tear, because rhexis circumference can stretch only to a certain extent. If you pull it from all four directions, more than that, the rhexis margin can snap. And so you have to create a friendly space by injecting OVD under the iris. So pushing the capsular bag little behind, the anterior little behind, to a more posterior plane, and then engage the pupillary device. So that is it. So now the pupil has really come down, and this is not a very good idea. I'm trying to, depress the main incision, get this chunk of nucleus out, and if I do that again, iris prolapse will happen. So it was basically perseverance that which saw me through, took out all the cortex from the capsular bag, and then I had planned to use a hydrophilic acrylic lens for this particular patient. Okay, so now as I started injecting this lens, the lens gets flipped. It becomes ulta, it becomes upside down. So here, for example, now pupil had become small, the haptics were dragging the iris tissue, AC was a little shallow. So I did not want to flip it back for good reason, because this is a lens which I know extremely well. So as KP was mentioning, whichever lens you use, you should know everything about that particular lens. And otherwise, you should not be using that lens, in big large numbers. So that is what my policy is. So this particular lens, I did not flip it back because it is a planar lens. It does not have any angulation. Okay. And then it is equiconvex lens. The power is equally distributed in the anterior surface and the posterior surface. So even if it is flipped, the power is not going to change. And since it has no angulation, so if it had angulation, it was flipped, then there's always a possibility of pupillary block glaucoma in the postoperative period. So that is not likely to happen. It is a non-aspheric lens. If it is an aspheric lens, and let's say sphericity is in the anterior side and the lens is flipped, then patient will lose all the sphericity in the postoperative period. So for all these reasons, I just decided to do minimal manipulations, hydrate the stroma, and finish the surgery. So this is how I started off the surgery. This lot of stromal hydration was there. In certain situations, it may be a good idea to just suture, place a suture, either the clear corneal incision or the paracentesis, instead of doing so much of stromal hydration. So this is the end of the surgery. So some iris chafing has happened, and this is on day one. Now morning I showed you a picture where I would expect to see my cornea is absolutely crystal clear, sparkling clarity, transparency. This didn't happen like that, so it always gives a nagging feeling in the mouth, but in your mind. But all said and done, I mean, that this SK is going to disappear, and in a week's time, patient had a vision of 6.6 with minus 0.5 diopter sphere. So basically, in IFIS cases, cataract surgeons should be aware of all the factors which are predisposing to IFIS and take appropriate measures. You must properly assess and evaluate these patients and stratify the surgical risk. Use all the necessary pre-op and intraoperative measures in high-risk patients to achieve an adequately dilated pupil intraoperatively. And so if you fail to do so, a routine case will become a nightmare. Thank you very much for your attention.
Any questions from the audience? Even for Dr. Krishna Prasad also, the previous session.
How many days you have to wait for topic of solution and then doing the cataract surgery?
For topic of?
The person has taken.
Yeah. No, we don't stop, sir. See, so earlier on, when people really did not know what exactly is the role of tamsulosin, all these aspects, so people were stopping it. But then stopping is not good because patient symptoms will come back, patient will become more uncooperative during surgery. And it has been shown that even if the patient has taken tamsulosin just for a few days and stopped it, still patient is a candidate for IVs. So we don't stop it. We don't stop it. There's no need to stop it because ultimately, you know, the IVs is happening. See, a patient has, let's say, taken the tamsulosin for a few days and then stopped it. Long time back, 5 or 10 years back. There are permanent changes that happen in the mid-segment of the iris. So dilated muscle atrophy that is happening. So it is unlikely that after stopping tamsulosin, when, you know, these are basically competitive inhibition for the receptor. So those molecules are gone. So what is blocked now? So there has been some anatomic changes in the dilated muscle area. People now hypothesize that there is some immunological mechanisms that also come into the picture. Details I have not really pursued, but there are changes, that permanent changes that happen. So there's no point in stopping tamsulosin in these patients.
It could decrease the intraocular pressure by giving mannitol or diamox or a PBI.
No, it is not a problem associated with the intraocular pressure. So I don't think I'll be altering it in any. It is just that you have to make your incisions parpaka so that it should not be leaky, it should not be borderline incisions. And your all your manipulation should take place within the capsular bag. All these fluidics, you know, they should be at a more posterior plane, not at the pupillary plane where they can go behind the iris and stimulate the sphincter muscles and bring and cause more, you know, inflammatory mediated release and pupillary constriction.
There is fish mouthing at the wound, then would you like to suture?
Then maybe I'll suture that incision and make a new better incision. Yes. Because if incision is not well made, then I mean, how iris is going to prolapse out. So how are you going to? Another thing you could do is, and I have done, actually I didn't show the video, is you can push and put an iris hook just behind the incision. Okay, and then you just engage the pupillary margin and retract it. So iris tissue has been pulled away from the subincisional area. So now you can go in very smoothly. So I think that will be a better option to do. I'm talking about in certain situations where not IFIs, but in a very badly constructed incision because, you know, the sudden entry of the instrument that happened and, you know, very ragged. So that I'll close the incision and take some other site and go ahead with phaco. But in these sort of situations, it is an iris hook that will solve your problem.
Hello, this is question for KVs. Sir, you have done a lot of monofocal lens. Can you, if patient is asking for EDOF lens or multifocal, can you go for EDOF lens?
I think patient asking for a particular lens is a little difficult to imagine because patient wants spectral independence.
For near vision, they are asking for
Okay, near vision. So if one eye is already emmetrope, the other eye, an informed consent, you can actually say this eye is for distance. So I'll try to reduce some for the distance and give it for near. So you can probably go for a micro monovision of 1.5, which is actually, see, EDOF lens is a kind of a in-between thing. See, you can see EDOF lenses are like monovision lenses only. They just have a small. See, if you are putting only EDOF in one eye, actually it is not, you're not going to make a justice. I would rather make it eye 1.5 diopter myope, put a monofocal. Okay. EDOF, all these trifocals and EDOFs work best on a bilateral implant. So I would rather put a trifocal in the second eye rather than an EDOF.
Yeah.
Which is a better bet because EDOF is somewhere in between. I told you Chini come. It doesn't work that way or this way.
Is it a good movie? Movie or something? It must be.
Very good.
So maybe
you should see, sir.
I have told you to send me a list. You have not sent me. See, this was a very. This has a lot of background to it. You know, see, the general feeling is multifocal technology has to be bilateral. Otherwise, there is, you know, the two images they got synchro. Yeah. Now then, I had patients in my practice. I'm talking about 10, 12 years earlier, where patients were pseudophakic, perfect. Then fellow eye wanted multifocality. So I was not really sure. Then I listened to a paper from Brazil. They have done more than 1,500 cases, ACLS paper, free paper. It was published also, no issues. Then I came back and any patient without one eye pseudophakic, other phakic, I don't hesitate in using a multifocal lens. Usually I might go to lens, the panoptics lens, if there is no contraindications in that eye. So that can be easily done.
And also about the floppy iris, that's for the postgraduates. See, we are just talking about the phaco part. In SICS also floppy is a problem, and that's for you, that's more pertinent. 2-3 things that you should keep in mind if you're suspecting a floppy iris. It's very difficult. As you said, the initial dilatation is important. If you have iris atrophy, if you have a small anterior segment, if you have a case of chronic ACG, these are all the patients. And if you're given too much of block, I mean, the orbit is very tight. So expect iris to prolapse. See, very important is whenever you touch the iris, you produce prostaglandins, and your post-op will be, he'll take a hit. So minimum iris manipulation should be the game. So in a floppy iris, that should not be taken as an excuse for iris manipulation and trauma. Your initial incision should go deep into the cornea. It should have a longer intrastromal track. Because if you make a short stab with a small intrastromal track, there are more chances of iris going there. Even your corneal entry in a scleral tunnel also. At the same time, the thing is, whenever, see, when I've seen my postgraduates operating, there's an iris prolapse always coming in one of the side ports. They just want to reposit it for aesthetic reasons. There's no reason. You are not using that side port. It is a non-dominant. On that side, there's a side port where iris is, they are doing somewhere here, something else. But they want the surgery to look nice. They want to repose it. Don't touch the iris unless you want to use that opening. You want to do an IA. You want to enter that out. There is an iris there. Then you try to repose it from inside out. You never push the thing from outside in. And thirdly, why the iris is coming, there is a disparity of pressure. The anterior chamber has higher pressure, so that's why it is taking the floppy iris to the orifice that is nearby. So you always work with, because they keep on, I've seen iris to basically put the iris in, first they inflate the AC and they want to push it in. It will never happen if you pressurize the anterior chamber. Deflate the anterior chamber before you repose it. And it is always from a sweeping from inside, okay, not pushing it from outside, because you end up doing more iris damage by repositing. The prolapse is not causing trauma to the iris. Your reposition is actually causing.
Don't use too much of OVD. In those cases, you'd like to fill up the AC with OVD and then perform manipulations. One of the causes is, very high amount of OVD into the anterior chamber. So that should not be done. So inject a little bit of OVD. And sometimes, if you're using coaxial irrigation aspiration, if the iris is prolapsed, it gives you better access to the cortex, residual cortex. Yeah. So, so you should, like a magnet, you should not, you should take advantage of adverse situations. So inject a little bit of OVD, and if you feel that, iris has to be deposited, go from the side port and take it out. And it can, as KP mentioned, it should not be the first priority. Iris has come out, push it back, otherwise all hell will break loose and nothing of that sort happens. Anybody can tell me what is the volume of the anterior chamber? So KP, I need some help, some input from them. Volume of anterior chamber, volume of posterior chamber, volume of the capsular bag. Can anybody tell me? Huh? See, because I had a question from Bangladesh just now about 11 o'clock. Sir, a silly question. Am I still online?
Yes,
Okay, then nice. I think we can terminate the discussion, isn't it? Yeah. Huh? No, this one I don't want to discuss. Can you just? Okay, thanks a lot for your kind attention.
Sir,
Thank you.
so coming back to the question which Marley has asked, you want to say monofocal one eye, multifocal in other eye, rather than going for EDOF, because all these days we used to think that EDOF should be put along with monofocal in one eye.
No advantage. See, trifocal is basically you need to get a good near vision. That's when the patient will be happy with an unaided N6. That is your aim. Okay. EDOF is somewhere in between. You will never get N6.
In a bilateral implant also, you will never get N6. So it is for those patients who are not actually, the candidates for trifocals, but slightly better than monofocal. So that is what it is. So just it increases the depth of focus. So there is no point using it as a second eye. If you have got one eye monofocal, either try with explanation, make the other eye myopic with monovision, or you put a trifocal. Because see, as he said, the large group, see, it's very difficult to understand what the patient will be happy with. If the patient wants spectacle independence, whatever that problem you create by this disparity of monofocal versus trifocal in the other eye will be taken, the patient will actually take it in its grace, no problem. But a bilateral, well done trifocal, in a good case, the patient will be happiest. That is the ultimate thing.
So other questions. Multifocal in one eye. You would like to go for multifocal or idiom? The patient is not happy. Multifocal.
In one eye.
One eye, patient is
I'll
not
do
happy.
multifocal in the other eye. See, that's why I said no. If the patient is unhappy, see, it is for a technical, there is a different issue. If the patient has a very high, see, you have to investigate why. I think I'll quote this. There was a patient from Vijayapura only. One Muslim lady came with 20 years ago. Two sisters, both were not married. Okay, she came with a PSC. I did those times. It was a multifocal. Maybe I don't know what array or what, or maybe restore. I don't know. We had put. She was extremely unhappy. This was 20 years ago. Extremely unhappy. And because the patient was that psyche of the patient, no, we had her background more than the patient. Her sister was prompting her. She was making her more unhappy. She was actually reminding her of all the problems. Okay, so both of them acted as a couple, and they were trying to really make me miserable. Then I said, "Arey, I thought this patient is a functional patient. She'll not be happy with anything." But after 2-3 visits also, she was not happy. So actually I did that. She actually had an angle alpha of 0.8 millimeters, which I had missed. So she had a very large angle alpha, which I had missed. And I had to actually do an IOL exchange. And she was happy with a monofocal later. So basically, never take that also always take it seriously. At the same time, if you have made a mistake from your side, patient not being happy. See, most patients who are not happy initially, give them some time, they get over it. Because they are looking at the negatives only. They are not looking at the positives. They are able to see well. They are not actually coming and telling you that. They are only trying to say what they are not able to do. Both positive and negative dysphotopsias will be their main concern. If given some time, if everything else is fine, they will normally get over it. And there are some patients, even if you give a bad, the refraction and a bad spectacle, ill-fitting spectacle, they're happy after some time. The brain will get used to it. So we give the time is the best healer, give them some time. But if they are repeatedly coming, and if you can find an obvious cause, I think then that is our wrong selection. So I have, explanted many trifocals in the beginning, multifocals in the beginning, but now we are very, very clear about it. Okay. So which patient we have understood, which patient probably will do well, and what is the actual selection criteria. We didn't know earlier. Any patient who would opt for a higher package, we would put it. It's not like that anymore.
Thank you, sir. I think we'll close this session.
Sir. Now we request Dr. Sunil Biradar sir to present a token of gratitude to Dr. Umesh Harakuni sir. I request Professor Dr. Sunil Biradar sir to present a token of gratitude to Dr. Malini Prabhugoda ma'am.
We have a small announcement to make. We will take a short break of half an hour for lunch. We'll resume the... We'll take a break of half an hour for lunch, and we'll resume the further session at 2:15 p.m. Thank you. come to the dais for chairing this session.
This recent advances in IOL Sir, full continuous.
Good afternoon, everyone. I call upon Dr. Arup Chakravarti, sir, for the talk on a recent IOL power calculation.
There are a couple of factors which have to be taken care of when you want to hit the target refraction in cataract surgery. Of course, it goes without saying that your cataract surgery has to be a very safely performed surgery without any complications. If there's any pre-existing astigmatism, that has to be addressed. And there are various options. Toric is quite popular these days. Use a premium intraocular lens, because if you use a monofocal lens, the patient will have only a pseudophakic presbyopia. So use a premium intraocular lens. And finally, you have to increase your refractive accuracy, because no matter you perform a very safe surgery, take care of the astigmatism using a toric lens or use a premium intraocular lens, your results will not be satisfactory if we have not calculated the intraocular lens power in a accurate and precise manner. So this is what I'm going to talk to you about. See, I think the CME was themed as recent advances in cataract surgery. So I think this will be very, very much in sync with the theme of the CME. And I feel that, whatever is happening in IOL power calculation, unlike surgical advances or advances in diagnostics equipment or surgical equipment, a postgraduate resident should be familiar with it, because that is definitely within his realm. He does not require any additional technology to be, on the cutting edge of IOL power calculation strategies. And this is a topic which has been my favorite for right from the time I started doing cataract surgery as a fellow and subsequently as a consultant. And this is a very, very happening field. I wanted to edit a book on IOL power calculation because last good book was edited long time back. When I got in touch with most of these gurus in IOL power, those who have done the pioneering work, those who have created the formulas. So I got an impression that, by the time the book comes out, the IOL power topic would have moved on. A lot of either a new theoretical formula, new formula would have come up, or there would have been some changes in the existing formulas, some new diagnostic equipment would have come up. And so by the time the book sees the light of the day, the concepts will be all very outdated and obsolete. So I shelved the idea of doing a book on IOL power calculation. If you see the literature, the peer review literature, every thing on every journal on cataract surgery will have some significant contribution, significant public contents on IOL power calculation. This is for example, sorry. So JCRS in the month of May, there are two very relevant articles, and this month in the American Journal, there are four very relevant articles. So I just make it a point to go through all the relevant articles, which I feel is going to make a difference in my practice. And or something which, if it's a new technology that has come up, which has not yet reached India, not reached my practice, be just familiar with what the technology can do. So it is important to be aware of what is happening. So now it is a cliche to say that cataract surgery is today a refractive surgery, but it was not always so. Sir Harold Ridley, when he first did cataract IOL surgery, first audited cycle 2 patients, and both the patients had highly myopic outcomes. One was -21, another was -15 diopter spherical equivalent. And then subsequent audit cycle had a mean post-op refractive error of median post-op refractive error of -2.25. So these results today are just not acceptable. Okay. So we want to set up the target refraction, whether it is 6/6 plano or whether it is slightly myopic or whatever it is, and hit it all the time in all the patients that you operate. So that is basically the holy grail. Now, where do we stand today? If we analyze our surgical, the visual outcomes, so we need to know where exactly we're standing. So then we can evaluate ourselves and improve if we are not at that level. So this was a very useful article published in JCLS by one of my good friend Giacomo Savini from Italy. So he concluded that most of the newer IOL power calculation formulas, like Barrett formulas, Barrett to RBF, their prediction error was within 0.5 diopter in more than almost 90% of the cases. So in 90, if you're measuring your biometric measurements using a SWIP source OCT based device, if you're using the modern formulas, it is routine eyes, I'm not talking about extremes of the eyes, 90% of your patient should fall within a prediction error of 0.5 diopter. So when you go back and analyze your results and you find that you have not reached there, that means you have some way to go. And if we are already hovering at that range, so what is the future? What should we do? So many people feel that we have perhaps reached the limit. Subsequent improvements in IOL power calculations, precision, accuracy will be very, very slowly incremental, and because of some of these factors mentioned here. See, today we are able to measure the axial length very accurately using the SWIP source OCT-based biometers. There is some keratometry still has some way to go because we still do not have an equipment which calculates the keratometry with precision in all patients. So this is still an area where work has to be going on, and there are certain uncertainties. For example, the intraocular lens today come with discrete IOL power steps. You have, let's say, 19.5, 20, 20.5 in steps of 0.5. And in the extreme ranges, you have these lenses coming in the power of, in the steps of 1 diopter. So whatever be the emmetropic power you have calculated, you cannot implant that power because that is not manufactured by the manufacturer. Obvious reason, because it requires a lot of inventory. So you are usually selecting in IOL which is closest to the target refraction that you have chosen. So that is one limiting factor. Second factor would be, okay, before that, sorry. Yeah. So this is one factor. Second factor is the labeling tolerances. Now, when the IOLs started getting manufactured, the ISO and other related standardization agencies, they allowed the IOL companies to have a tolerance. For routine powers, it was a power 0.3 diopter. That means if you have a 20 diopter printed on the box of the lens power could be 19.7 or 20.3. So, and for higher powers, for example, lenses which are more than 30 diopters, this labeling tolerance was 1 diopter. So that means a lens which is labeled as 30 could be 29 or it could be 31. So when you are not hitting the target refraction, so you are not sure whether it is because there is some mistake in the IOL power labeling, that they have labeled it wrongly, and still it is acceptable because it is within the labeling intolerance. Effective lens position is another bugbear. Most of the theoretical formulas, they calculate the effective where the lens is going to sit, the effective lens position, and then it calculates the intraocular lens power. It is a two-step work. So effective lens position and the absolute lens position, if they are the same, well and good, but many a time they are not the same, because once the lens that is kept in the bag and the bag undergoes scarring post-operatively, so whether the lens continues to sit in that position or if it is pushed forward or if it is tilted, nobody can say. Like certain patients with severe exfoliation, retinitis pigmentosa, where capsular contracture happens very rapidly and it is quite severe. So ultimately, the final lens position, the actual lens position may be quite different from what you had expected. So this is area that is still not sorted out. Then morning, we were referring to angle kappa and ocular biomechanics. So now it is increasingly believed that angle kappa plays an important role in IL power calculations. So likewise, ocular biometrics. So if you're dealing with eye which is softer eye, post-operatively the effective lens position may be different from if you're dealing with an eye which has a higher biometric index. Angle kappa also makes it quite inaccurate. So these are some of the regions, some of the areas where which rather do not allow us to reach precision, and we may perhaps not reach that prediction error going up to 100% of patients landing within a prediction of 0.5. So that may not be possible in the near future. So these are some of the stalwarts, the IL power gurus from the PG perspective. Warren Hill, we have all heard about him. Ken Hoffer, Jack Holland, Wolfgang Heigis. He was a mathematician. He's not a he's no more. He's not an ophthalmologist. Graham Barrett, Adi Abulafia, and Thomas Olsen. So they're doing tremendous work in IL power calculation. They've already done, and what we are enjoying today is the benefit of their hard work. So please remember that IL power calculation is just not one-off event, like when you work up a patient for cataract surgery, what is done preoperatively. No, it is something which transcends the preoperative period, intraoperative period, as well as the postoperative period, the input that you get from the information in the postoperative period. So we have known for quite some time that patients with an ocular surface disease can definitely impact the IL power calculation, not only for the toric lenses where you may not be able to get the accurate axis or accurate IL power, but also you may not be able to get the accurate keratometry, which is going to affect your monofocal or multifocal IL power. So please look for ocular surface disease before you work up a patient for cataract surgery for biometry. So that is very important. And if it is diagnosed, then this has to be appropriately treated, and so that two consecutive values are sort of repeatable, so that that the ocular surface has been optimized, and now the measurements are making more sense, and they're more reliable. Also adopt the needle touch technique of biometry, where make it a point to do all the measurements on the virgin cornea. So before you have applied anesthetic drops, or if you have dilated the pupil, or if you perform the contact procedures. Sometimes it may not be possible because when a patient comes, all the workup would have been done, you see cataract, then you advise surgery. So in those cases, I ask these patients to come back on another day for biometric evaluation, so that way I can get the measurements on the virgin cornea. So it is important for us to make sure that the biometric parameters that we are measuring are all accurate. So now this is something which I had been doing for a long time. So, but when I was doing A scan, and now even optical biometry, if the pupil was small, I realized that if you dilate the pupil, sometimes you get better values. All right. In many cases, sometimes you're not getting any values, particularly for ultrasonic biometry. But after dilatation, it started giving you some good readings, which were repeatable, and I was using that. So recently there was a publication again in JCRS November, where similar thing was reported in a study which used a SWAP source OCT based biometer. So there, 8.52% of the candidates did not give a proper scan because the cataract was advanced. Okay, so those cases, the pupils were dilated and the values were, and the readings were repeated, and it was found out that the values definitely got more reliable, and it definitely helped the cause. So perhaps it makes some sense to dilate the eyes in situations where you're not getting a proper biometric, even using the optical biometer. But there is an issue here. Now, if you dilate the pupil's eye, biometric parameters change. They have an effect on the biometric parameters, and this is going to have an impact on multivariable formulas like all these Heigis, Barrett Universal 2, Olsen, Hill, RBF, etc. So this study clearly showed that the central corneal thickness, anterior chamber depth, lens thickness, they change after the eyes. The arrow mark is not coming up, the bullet. Okay, so there is definitely a change in these values. So if you incorporate these altered values in these multivariate formulas, and including the Barrett Universal to Olsen Hill RBF, you are going to end up with an IOL which is half to 1 diopter overpowered, which means you're going to end up with a myopic result. So all those patients where I do the biometry after pupillary dilatation, I tell them that, one fourth of the cases, I'm not sure whether you belong to that group where you'll be ending up with little myopic result, but there's nothing we can help it. So let us accept it. So it has not been a big issue generally by and large. So many of these dry eye patients, I normally use little bit of lubricating agent, wait for 4 or 5 minutes and repeat the biometry. That has given me good results. So this is what I basically, so once you have prepared the eye for biometry, so now these are the devices that I use. I still use ILMaster 500. I do topography for all patients, eye trace. And then you can also use, the manual keratometer, auto refractometer, immersion scan. I'm not ruling out immersion scan because, in our country, it is still a developing country, and there are many centers where you need to still, cannot afford to go in for an optical biometer. So that also can be used. And before you perform, but with certain criteria, I'll come to it later on. But if a patient is on using a contact lens, make sure the contact lens is removed for at least 2 weeks if it is a hard contact lens before you make the measurements. Now, as I mentioned earlier, that in our scenario, we still use ultrasonic biometry. But I would recommend that you use only immersion scan. Do not use a contact applanation, because studies have shown that contact applanation is less accurate, and there's a mean average shortening of the axial length to the tune of 0.25 to 0.33 millimeters. So always use an immersion A scan. It really is not going to cost you extra money. A study, again, a meta-analysis by Hygis, where the outcomes were compared, where biometry was done using the optical biometer and immersion A scan. Optical biometers performed better than the ultrasonic biometry. So what I try to give you the take-home message, that is always better to use a optical biometer because it is easy to use, and it is not much user dependent. But just because you have an optical biometer in your office does not mean that your results is going to be magic, that you're invariably going to end up with good result, with accurate values. So all these machines have validation guidelines. So every recording that you get, every measurement that you make, you have to see whether they fulfill these validation guidelines. If not, if there is a red flag, then you have to delete that reading and then take a fresh reading. So that is something that we have to routinely do. ILMaster 500 versus ILMaster 700. Say 2015, there was a paper which compared that both these machines were pretty accurate. They gave almost the same results, so there's not much difference as far as the refractive outcome is concerned. But ILMaster 700 has certain additional features. For example, now you can see the foveal area, so you know exactly where you are measuring. Then it penetrates harder cataracts, and it has other features inbuilt which enables you to measure the posterior cornea, the total cornea, and all that. So I'm not going into that, but what I'm telling you is, the non-swept source OCT-based biometers also generally give good results, but they do not give you any output if the lens happens to be a hard lens, white cataract or thick posterior subcapsular cataract or a posterior polar cataract. So now we have decided that we have to how to get the readings accurate, what are the devices and tools to get the biometric parameters, and they have to be substituted in the formulas. Now, these are the formulas which we have been talking about for a long time. All these formulas belong to the previous century. This classification system, generation classification system, is a very chaotic. It doesn't make any sense. So, some couple of years back, Warren Hill and his team wrote guest editorials in JCRS and classified the IL power in this format: historical, regression-based, vergence, artificial intelligence, and ray tracing. And then till about few years back, 3-4 years back, these are all the formulas which we had access to. They're free. Most of the formulas here are free. Some of them are not. And we had basically, focusing on Barrett Universal to heal RBF, gain EVO formula. Then subsequently in February of this year, JCRS had another editorial by Giacomo Savini where there's the IEL formulas were reclassified to accommodate all the new formulas that were being proposed. So you have a lot of articles coming up, newer formula writers, new ophthalmologists writing newer formulas, claiming more accuracy for those formulas. So it is impossible for us to to test each and every formula. So, but this is something that we need to know that so much work is happening. So now, which formula should we use? I always use the online calculator. See, most of these formulas I had projected here, they are available free of cost online, so that your access is free. On the other hand, there are certain formulas like they are all licensed to vendors, the OCT manufacturers. So if you want to access those formulas, you have to use those machines, and it becomes a very costly proposition. And likewise, whenever some changes are brought about in the formulas, the changes are incorporated in the website, online formulas, almost immediately. On the other hand, the formulas which are there in the machines, so they do not get upgraded in time, and sometimes it just does not get done. So you can do multiple results. So you have a particular data set of a patient, you can use multiple formulas, and it will give you the picture. The different formulas gives you what are the IEL power recommended by the different formulas. So it is easily available. You just need an internet and a laptop, and that is there even in your in your smartphone. And these updates, as I just mentioned, they're updated by the formula writers as and when there is an update. So these are basically the IEL calculators and other tools online. And these are for the toric formulas, post-refractive calculators. So basically, the go-to formula is the Barrett Universal 2 still. It is available free on this website. This is a go-to formula because it is a suite of formulas. It takes care of all your IEL requirements, all your IEL calculations for routine eyes, for calculation for toric eyes, post-refractive surgery eyes, for piggyback lenses, for secondary IELs, so on and so forth. So this is something which I always go to. And there was, people think that whether if you have done an ultrasonic biometry, can Barrett Universal 2 formula be used? Yes, it can be used. Only thing is you have to use the contact A scan, the value which is written on the box. But sometimes we really do not know the contact A scan value which is written on the box, how it was calculated. Company has no justification. You ask them, any company, they do not know. So sometimes it becomes a little unreliable. So Barrett Universal 2 formula. Then ascaras.org, it has also a host of formulas for, I'm not reading out everything. You can go to this homepage and find out for yourself. RBF formula is available. Now the version 3 is available. Gain formula is another new kid on the block. In fact, it has been around for a couple of years now, 4-5 years. It has done wonderfully well. So whenever I have patients in the extremes of axial length, very short eye or very long eye, keratometric eye, so the keratoconic eye. So I always use the Kane formula in addition to the Barrett Universal 2. And in certain situations, I use multiple formulas. Now, this was for, I'll give you an example. See, this is a highly myopic patient. ICL was done. Patient developed cataract. So I did a cataract surgery. So, here I use the traditional formulas of SRKT, Holiday 1, Hygis, and Hoffer Q with Bangkok adjustment of the axial length. So basically, when you measure axial length for these highly myopic eyes, even with the OCT-based biometers, it is always an overestimation. So you have to use a adjustment factor. So adjustment to recalculate the axial length and calculate the IEL power. So the traditional formulas gave me a lens of 3 diopters, whereas the Barrett formula is giving me a lens of 2 diopters. So I ended up using the 2 diopter lens, and it was bang on. Patient had done extremely well. So intraoperatively, how does it impact our IEL power exercises? KP was just mentioning about this thing about the routine size, shape, and things like that. So here, the assumption is made by the formula writers that you are using a lens which is 6 millimeter optic, and the axis is 5 millimeter diameter, and it has a uniform about 0.5 overlap on the anterior surface of the intraocular lens. So subsequently, with the capsular contracture, etc., occurs, theoretically it should occur symmetrically, and then your effective lens power assumption would perhaps continue to be accurate. So this is in terms of your Rexis intraoperatively what we could do. Now here just a little digression here. Sometimes when you have a PC lens and you cannot keep a lens in the bag, you have to keep a lens in the sulcus, and so in that case we adjust the IOL power. Here patient had a PC lens, so big lens, so I had to keep 3-piece lens in the sulcus. So here you need to adjust the IOL power. By the rough rule of thumb is 5%. You use a factor of 5%. And this chart is available in Warren Hill's website, so you can easily calculate. I have put it up in the theater. So it is basically to calculate the IOL power for a lens which is going to be kept in the sulcus instead of in the bag. So it is not the bag IOL power; it is the same lens IOL power in the bag, which is adjusted and which is kept in the sulcus of the appropriate power. So now finally, another thing that is gaining ground and a lot of people are talking about it is the gender effect on the IOL formulas. So for example, Barrett Universal 2 is supposed to be more, more accurate, more precise for the males. Remaining formulas are more precise for the females. And these gender differences become more pronounced at the extremes of antechamber, that is antechamber depth or axial length. So friends, as regards IOL power calculation, you are in charge. If there is any deviation from your target refraction, major surprise, nobody else should be blamed other than you, because until unless you know how to do the things, how to do the measurements properly, the guidelines I've already mentioned, an optometrist cannot be aware of what is happening. So you have to train the optometrist or whoever is doing the test for you, even if you are doing it yourself. So you have to get accurate results. Preoperative workup has to be done properly. Use appropriate measurement devices, use validated measurements, use the newer formulas, work with properly optimized lens constants. I didn't talk much about lens constants because now most of these online formulas and the A constants are already there in the drop-down menu. Or if you put in what lens you're going to use, the A constant automatically gets filled up in the boxes. So adapt to new technologies as they present. So anything new that is coming in the market may not be the best. It will make some noise, create a wave for some time. It'll just vanish after some time. So just try to assess it and find out whether it is really appropriate and whether it is whether it will stay on. And strive to use all available resources to their best advantage. So that is it. So thank you very much for your attention. Any questions on this, the audience? Yeah. Which is the best optical biometer? Okay. So I see, basically I was one of the first in South to go for the Almaster 500 when it came in. Okay, so it is still serving me well. So then other companies started coming in, and then the questions came that which is the best to purchase and all that. So I did a literature search, all the articles that had come around that time, and all of them revealed that there is no difference in terms of precision and accuracy, in terms of axial and overall. No, IOL power calculation, the target refraction, prediction error, and all that. So my answer to this question would be any company which gives you good service, after sales services, and gives you at a more, what would I say, financially viable scheme is a good biometer. Then when the SWAP source OCT-based biometer started coming in the market, then I again wanted to compare that. Do I have to really invest? And what are the differences? Then I saw a couple of articles. I just showed one article. There are a few other articles. In terms of measurement of axial length, there's not really any difference. The only thing is it gives you additional features. It gives you additional features for measuring, to go through a more advanced cataract, to make sure that it is measuring up to the fovea, and then the various posterior curvature and things like that. And then any new machine that has come up after the SWAP source OCT biometers, they cannot be compared. So if you are getting your parameters from one machine, they cannot be substituted and you've done the calculation, it cannot be substituted from another machine. They usually do not, many of these parameters, for example, anterior, whatever feature values you get from the anterior may not be the same that you get from the, yeah. And then in the IOL star, what is the other biometric new thing that hack straight? Hack straight, the new thing that's come up? Star. Lens, not lens star, the next one. Yeah. So same thing, and I mean there are articles which are the literature is replete with articles which says that these machines may not may not measure their measurements may not be tallying with each other. So basically, I use IOLmaster 500, and for hard cataracts I use an immersion A scan, and then the people who do the measurements for me, my staff, it has been validated several times, so over a period of time, and I'm getting pretty good results.
To use this online.
And somebody asked me recently that I'm shortlisted 2 machines now. One is Argos, another one was IOLmaster 700. So I asked him what is the cost difference, 10 lakhs. Then so that is it. When Argos came into the market, it was not belonging to any company, any multinational. So it was quite affordable that time. Then once the big company purchased it, then they hiked up the cost. It became very, very expensive. So then I told him that in that case, why don't you go for a immersion, continue with the immersion scan?
To use these online formulas, the readings should be taken from optical biometer only, or you can take it from...
That's what I told you. Say, for example, when Barrett formula became popular. So this is a question that first confronted me. That when I talk, people ask. So they say that if you have immersion A scan, value can be used. But if you're using the apprenticeship A scan value, then you have to use the ultrasonic A constant that is on the box. But then the question is, who has calculated that? There's no literature. I don't think a company X coming up with a new lens calculates the A constant for ultrasonic biometry in the apprenticeship mode. No, I'm not aware. I've spoken to some engineers, they don't do it. I don't know how they put those values. So there's a big question mark there. No, it is not a published formula. So it is nobody knows, what exactly the formula is. Yeah, no, it is we're talking about, say, for example, Hoffer formula. Hoffer Q is what exactly is the formula. Hoffer Q is gone now. Now it is basically Hoffer, the newer version that has come up. So there it is an open. You can see the whole formula. For example, yeah. So, but Barrett, you don't know what the formula is, but you just see the outcome. No. Barrett suite, you don't have to pay for it. See, if you go, that is the beauty. That is the beauty of online calculation. You go to the online calculator, which is an APS here website. You access Barrett. It takes care of all your IOL power requirements. Barrett Universal 2 is the one which calculates for the your monofocal lenses or multifocal lenses. Then the toric formula, it calculates for the toric monofocal or multifocal lenses. Then post-refractive surgery. Again, that is taken care of. Then there's an RX formula. So that is again, you want to do an IOL exchange. If morning we're talking about, patient's not happy, so you have done exchange. So supposing patient goes elsewhere, how will you know the power? So that has the formula for that. That is the Barrett suite, absolutely free on the website. On the other hand, the Barrett license version, which is available in the Zeiss, that is not available in the Barrett Universal 2, in the Barrett website. Recently I was in China for the APS series. So basically, he says that for his formula on the website, if you're using it, you're doing well. KP had something to say?
The same thing, sir. Basically,
Barrett suite is free. Everything that is absolutely free.
Combination of multiple formula, as you said, it's a part of the IOLmaster 700. So if you want to really go there and do it, you can do your own job. Like otherwise, it's in the part of the thing. And for the postgraduate,
No, it is not the part of the thing. Again, another thing that I think I missed out on emphasizing. See, basically, Barrett keeps on changing this, and the A constants will be changing, or some formulas, some new features will be bringing in. So those features will not come into the one that has been licensed with Zeiss. So that will be coming only in the online
That will
formulas.
come on the website. It will not come into the machine
Yeah.
because they have to come and update it. So they keep updating it anyway, but
Yeah. I have not used anti-rinse, so I'm not in a position to tell you.
okay, something like maybe Barrett suite, we don't know. We have to ask. Yeah. Okay, for the people who are still have only acoustic biometry, that is a scan, the least that you can do is do a keratometry properly. When you are doing keratometry, that should be the first investigation you have to do before you put any drops, including pediatrics. And see that your head is, for a tall or a short patient, the head is not tilted. Because if the person is tall and you're doing a keratometry like that in an auto keratometer, you will get around 10-20 degrees off. So you can't do any toric thing, right? So axis should be maintained properly and cornea should be pristine. Okay. Don't damage the tear film. Number two, do a immersion A scan. It's very important. Contact A scan is out. Immersion A scan. When you're doing that, please also note down lens thickness and ACD. For your routine A scan, you don't do that. But there you have to basically anterior chamber depth as well as length, because you need to factor in these two in the online formula. So go to any of the website, go to Barrett, put these two and choose the thing and you will get it. At least this is the least that you can do if you don't have an optical biometer.
Sir, manual K or auto ref K, which one?
Anything is fine.
Both are accurate. Manual K, auto ref K, both are accurate. So before I got the eye trace, I used to do my, I used to compare my iron master K value with the auto ref K and the manual K. Now that I found out that all three are the same, I don't do all those.
Yes, that's what.
No, yeah, we do topography because if the patient is for a toric, I'll taken up for toric. I need to know what kind of astigmatism patient has. So you need not do it, but see, I feel that for any toric, if the patient is planned for a toric surgery, topography is it is a must. Even for multifocal patients also.
Since many of us will not have this IOL master cell, we are doing
Immersion scan is absolutely fine. That's what I try to convey. Yeah. Yeah. And then see, many of these online formulas will have multi-variable formula. It is not necessary that you have to fill up all the variables. No. So it is said that if you have filled up all the variables, the results output will be perhaps more accurate. But the machine will, the formula will still accept a basic minimum number of variables. So if you don't have
mandatory field that you need to fill.
Yeah,
Otherwise,
if you measure these things, you can fill it up.
the lens thickness ACD is mandatory.
Thank you, sir, for highlighting about the accuracy of the IO and the calculation, power calculation. Next, we'll have Dr. Krishna Prasad, sir, on PC rent video presentation, PC rents.
So I'll just show you three, small videos that will probably have some point to discuss. So as I started off in the morning, see, you will get a chance to do a combined surgery once in a while, and those are not actually so-called the traditional glaucoma surgeons. Anybody can actually try. Especially, we do get a patient where there's a lens-induced glaucoma, and you need to combine that filtration procedure along with. So the conventional teaching is, if a patient is well controlled on AGM, you do only cataract surgery. That may not work. Okay, in fact, it can work both ways. In the case of an ACG, your lens removal can facilitate outflow facility and can slightly reduce the IOP. Okay, but your surgical trauma sometimes can even decompensate the cataract, the glaucoma, and make it worse also. So both are possible. So if the patient is already going under the table, going on the table and getting under the knife, so you can give him an advantage of a glaucoma surgery also. So in the next 5 minutes, I'll just show you one of my videos of my phaco trap, which is a case of a lens-induced glaucoma. You can see that intumescent cataract there. So normally for most of my phaco traps, not such an acute inflamed eye, I normally don't give peribulbar block. I do a subconjunctival xylocaine only. But this patient actually was a very symptomatic and inflamed eye, a very high pressure and an extremely intumescent total cataract. So despite the thing, I raise the conjunctiva on the superotemporal side. I'm injecting mitomycin underneath. So this is the new thing. See, normally you heard of mitomycin application with merosal sponges, but now I don't no more do that. 0.1 ml of mitomycin is injected subconjunctivally and we don't wash it. So this actually works very well. Because the kind of Indian brand of mitomycin that we have, they don't really work with merosal sponges. You need to keep a long contact time, and this will actually save time. But for doing that, I normally raise the conjunctiva so that you don't damage the conjunctiva because you bellow up the tenons. You do a good dissection posteriorly at least for 8 millimeters because that is where the filtration happens. There has to be a posterior filtration. And you need to do a good cautery. Unlike cataract surgery, cautery is very important in trabeculectomy. You don't want blood and blood products to basically seal the fistula. In a cataract, it is optional. Ideally, you should not be doing cautery in a cataract surgery because you want the wound to heal. Here, you don't want it to heal. So you just make a rectangular flap. That is my choice. You can even do a triangular flap also. But only thing is, look at that. These are not really going, this flaps are not really going up to the clear cornea. They are just short of it so that the filtration is more posteriorly directed. Normally, if you cut it till the clear cornea, normally you have more of a filtration sidewards and you have more anterior overhanging blebs. Okay. So now we turn to, I was sitting superior temporal to do this. Now I have moved temporally. It's a right eye. I've moved temporally. Now I'm going to do my phacoemulsification. So you can go underneath the same flap or you can do another temporal entry. So this is a white cataract, so I'm going to stain it. I don't do it as a routine. So this is a temporal entry for an intumescent cataract. So this is the viscode I'm putting. There are many techniques of getting a rhexis in an intumescent cataract, double rhexis, spiral rhexis, and all that. So basically push it down with a good viscoelastic like a viscoat or a Helon, and you open it up so that it won't really go to the periphery. Now you can see I'm just going to aspirate all the swollen anterior cortex, which is the reason for the intralenticular pressure rise. So once you deflate it, and you can again further, push the thing down with viscoelastic and complete. Normally, it is wise to use a rhexis forceps rather than a needle at this stage. Maybe the initial opening can be with a needle. And you can even use a side port for if you don't want the anterior chamber to collapse. So this is not a very hard cataract, but I'm using a sharp chopper to kind of get a break. So most of these intumescent cataracts may sometimes be quite a brittle small cataract, which is very easy to actually break. So I'm continuing my phacoemulsification. So the important thing is after you implant the IOL, you're going to constrict the pupil, okay, using pilocarpine. See, normally when we operate, it doesn't constrict. When our PGs are operating, even cataract, it constricts. I don't know why. So even with pilocarpine, it won't constrict sometimes. Because if you constrict the pupil, you can do a better PI. So now we make that whole area again avascular, do a bit of cautery for your thing. And I normally do a freehand cut. I just do parallel cuts and join them. You can use a Kelly's punch that you need to standardize how much it is. I normally make a rectangular, a small trabeculectomy and do a PI accordingly. So now this is an adjustable suture. I don't complete the suture. I just make it a slip knot, multiple slip knots, because up to around 2 weeks, if we can rub vigorously on the conjunctiva over this knot, sometimes it gets loosened up, not always. So I have found it to be better than releasable sutures. Somehow releasable sutures have never worked for me. So basically you can put multiple sutures and you don't, so at the same time, you also calibrate the filtration. So, and then close the conjunctiva. This is very important. It's not like a pterygium closure. You need to bring the conjunctiva back onto the limbus, onto the clear cornea. You want a proper closure. You don't want the conjunctiva to retract. And basically, you have to pass a suture to the episcleral tissue so that you fixate the conjunctival edges. You don't do conjunctiva to conjunctiva. The bite is to the episclera so that it's come forward. And the free conjunctival edge has to be anchored to the clear cornea. This is the most important step. Otherwise,
it will leak through the free edge. If there is a leak from the conjunctiva, your blood will never form, the conjunctiva will stick to the sclera and the blood will fail. Okay, and also it will cause overfiltration, hypotony, and all the consequent problems. So this is this anchor suture. Obviously, you need to remove it. Now you can see the blood forms nicely, and the surgery is done. Normally, in such inflamed eyes, I do give 0.1 ml of intracameral dexamethasone for the thing, and you can also give subconjunctival. So this is a short video to show how you can actually do a phacotrabeculectomy. You can also do an SICS trab. But somehow I feel that wherever you can do a phacoemulsification through a clear cornea is an ideal technique for a glaucoma patient because you save the limbus. In this case, I have just only around 40-degree, peritomy I have done. So I still have a lot of limbus left untouched for future trabs if required. Because if you do an SICS, so that's why I always say for all postgraduates, whenever doing SICS in a normal case, okay, never detach the conjunctiva more than 50 degrees of the arc. You can give radial cuts, open the conjunctiva like a box. Don't try, just because you want to reach posteriorly for your tunnel, don't detach the conjunctiva. Don't do a peritomy. See, to get a posterior thing, you just give a radial cut so that your conjunctiva nasally and temporally or supranasally or supratemporally are intact. Just always think when you're doing an SICS, where will I do my trab next time? Because every cataract patient is a potential, okay, maybe he may require a trab, who knows, okay, for whatever, maybe because of your surgery or otherwise. So you have to always conserve the conjunctiva. So whenever we have people who have done a SICS, 150-degree peritomy, okay, they have just detached the peritomy. Now this limbus will be very, very hostile for a good bleb to form. For a good, we can still do a trab, it's not like that, but maybe it's better always to make sure that you actually have some amount of conjunctiva limbus for the future thing. So now I'll all postgraduates hate vitreous. Okay, so why do I love it? Okay, do you love vitreous? See, vitreous is an uninvited guest in our surgeries. It makes the whole OT floor slippery. Okay, we have fallen many times in the OT, broken bones. So vitreous is a friend or a foe. Let us now see. Okay, I'll just show you. So this is a patient. This was a surgery that was done on a routine case. I was doing it on Ingenuity 3D visualization system. Okay, this was new to me. Okay, I was little, not very adept at it. Just keep watching the surgery. Okay, because it's a 3D system. It's like, did you look at that? I'll replay it for you. Okay, so when you're doing a trenching, there's a common mistake a PG does. So I didn't notice that because I was busy trying to adjust to this thing because we are not going through we are wearing a Polaroid glasses. My surgery is continuing. Okay, but something is not happening as per my expectations. That there is no followability, pieces are not coming. That is, but I'm continue to do, but things are not falling in place because that rhythm of your surgery is not happening. Okay, something is going the other way. So now the surgeon start getting that doubt, what is happening actually? Because nothing is same, everything in the PC, what I can see is perfectly intact. Now I just move the thing down. Can you see at the edge of this? Can you see? We see a small chink here. That is after moving the eyeball down at the most peripheral part of the posterior capsule, we have chomped off because the trench that was going. So normally the PC, see our cataract is like an idli, right? The PC is coming on either side up. Only the central PC is far away. So when you're doing a trench linearly, okay, normally in order to make a deeper trench, when you go, you always try to reach the posterior capsule on the other side. And with a burst of energy, you may actually take it up. So this is where, and this was the extreme periphery, the central PC was intact. So we did not see it in our normal viewing area, right? So after suspicion, when we moved on, still nothing has happened. Nothing wrong has happened. Don't worry. We just noticed that. Now, that is the area where you have, see, now you can't see in the normal iris thing. So what I'm now putting is viscoat, putting into the area of the chink where the peripheral thing to buttress or to create a platform so that there is no dropping of anything into the vitreous cavity. So I keep pushing viscoat into that gap in the most peripheral part. So it's like a concrete on which we continue the surgery. Again, I put it, push the vitreous down, lift the things up, create a barrier for things to, now I'm doing a vitrectomy and that area that has actually opened up. So I'm doing a sulcus fixation and an optic capture. Okay. So we remove all the cortex and capture the optic in the thing. Okay. So we did this. Okay. Like now I have a case which has undergone a vitrectomy and the patient has come back to us in 2 months with an early posterior subcapsular cataract. So now whenever such a thing happens, we are very, very suspicious. Okay. Our retina colleagues are not so generous to give away cataracts like that. But why do they send it to us? And why this patient on what on earth made the cataract to develop in 2 months post vitrectomy? So that means there's a possibility that during the surgery they have damaged the posterior capsule. And if you look at the eye, you also see the cataract is more posterior subcapsular, not a uniform opacification. So that means I already have a PC rent before my surgery. Okay, I know the post-op outcome already. Normally you have intraoperative PC rents. I have a preoperative PC rent. Okay, and now I need to get this right. No big deal. We have done so many posterior polar cataracts, right? So this is something like a posterior polar cataract. So this is the patient. You can see, even though it's opaque, the posterior part is more opaque. So now I'm doing my surgery. This is under topical. Okay, so I know that there's a problem, but we can manage. It's a softer cataract. I'm quite confident. So I start doing that because we have done a lot of posterior polar cataracts and we have managed even with the pre-existing dehiscence of the posterior capsule. So I don't do hydro dissection. I reduce the IOP. You can see 30, like a bottle height reduction. I don't want the things to be pushed in, so I reduce it. I've not done a hydro dissection. Okay, I mean, with very skid gloves, I now cut, I don't rotate the nucleus. I'm cutting a piece and trying to take it out. Just keep what is happening. Sometimes whole thing is trying to slightly go at a lower level. Okay, so now this, this PC has opened up. Whatever that small pie I had actually separated without rotating the nucleus has dropped down. Okay, now I have a PC rent. We just saw the previous video. If there's a PC rent there, we keep on putting visco and buttress it up, lift it up, and eat up the whole thing. So let's start doing that. See, I'm putting it, it's going nowhere. It's a huge vitrectomized space and there is nothing to hold this vitreous, and whatever I'm putting is actually not filling the whole thing. Nothing is lifting up. I'm still continuing to put visco there, trying to lift it up and trying to bring up the whole thing. And it's not happening. Okay, there is no support from below. The whole thing is going down. So I'm trying to lift the whole thing up, put viscoat underneath, trying to do a anterior chamber phaco to remove that. So the big piece I'm trying to remove. So now I convert to subtenous anesthesia. Till now it was under topical. So as Dr. Arup was alluding to in the morning, this is the time that we need to. You can see the large PC rent there. Okay, I see the rexis, the whole big rent is there. Now, because I gave subtenance, because it is transferred to the VRs, the next table, in the next OT. So they go in with a PPM in three-port vitrectomy. After vitrectomy, they remove all the pieces. They do in the same setting. Now I implant a 3-piece lens and try to put it into the sulcus. It's very difficult because the whole eye is vitrectomized despite the infusion. It's very soft, so I need to really place it. So the whole idea is, by considering these two, why the second surgery was so difficult, why everything dropped down, where I could not really get the things up, because
in a normal situation, we have vitreous. Vitreous usually is a gel. It is actually a platform on which we do the surgery. PC is there, but you forget the vitreous which is supporting the PC. Okay, right? So that is what it is. Only we see the earth. We don't know what is the underneath. We don't know the Kurmavatara underneath holding the whole earth. Okay, so vitreous is the one which supports the PC, and if there's a rent, the vitreous still continues to support, does not let the things go in. If you take care, the drops, it doesn't, you can avoid the droppings into the vitreous and still put a good quality viscoelastic, create a barrier for things to drop, and you can continue to do the surgery. But if you have no vitreous, the surgery that you saw, so it's going to be a tough case because any PC rent will have immediately, there's nothing to hold the pieces from going down. Even though I managed to remove most of it from the anterior root, a lot of it had to be taken from the back. Okay, so respect vitreous, love your vitreous, so that it won't come in the time that you don't want, right? So since there are a lot of postgraduates here, so I just have another video which I really want to share. Okay, so this is a case. Normally, the how we do the training is, so this is the trainer. You can for a change you can take it's me. There's a trainee who's waiting. Normally, we do is we do the basic steps. We break the nucleus into multiple pieces. I call it as a shabari technique. No, shabari used to eat a fruit and keep the rest for Ram. So then the trainee comes in. So this is the surgery that is we are doing a rexis and hydrodissection and also hydrodelineation. I don't do hydrodelineation myself, but for the people for the trainees, I do it. So I crack it. I don't eat it up. I only crack the nucleus to multiple pieces so that my trainee can go in and eat up these pieces to get a hold of, to get a hang of how to do this nucleus emulsification. Okay, this is according to me the most non-critical step because the centurion does the rest. You just have to go there and press the pedal. Right. So now the trainee starts. Now look at the difference. Okay. See, she's so tentative in entering only. She has not started the irrigation. Okay. And then she starts, she's very tentative. She doesn't know how to press. See, this is something, since you have a wet lab, I want to see, phaco machine is like driving a car. So how much of accelerator, what is the play, how much to press, how to press the brake. So it's basically a muscle memory. Expert drivers know it even without looking at there. They can drive because they have hand-eye foot coordination that happens. It has gone into their spinal level. Phaco is also like that. Okay, how much to press? Okay, is basically a muscle memory you get. So unless you do multiple sessions of wet lab, it is very dangerous to try it on a human eye. So look at this. She's very tentative, even though she can complete the surgery in a jiffy. So she doesn't know what to do, how much to press. She's not pressing at times. She's pressing too much. Okay, but nevertheless, the machine is doing its job. Okay, whoever is pressing the foot switch. So she's removing the things. Basically, she used to go eat, bring it to the center and press, that's all. See, and she crosses the line, catches the iris, and suddenly, that's what, whenever a PG steps in, the iris knows. It start coming down. You know why? Okay. So when we operate with excitement, the pupil dilates. Keep looking at this. Keep looking at this. So she's almost finished last epinucleus. Keep watching. Did you see that? So she just had an epinucleus. She changed to epinucleus mode, I think. But see how much you press. See, that's why I said it's basically you need to control the pressing of the foot switch. If you suddenly press it, whatever, even if I kept a 350 or 300 vacuum, will come till 100%. And what she did was she just, went through the epinucleus and caught the PC. At that time, there is nothing to support the PC. I'll just, So now I told her to come out of it. I told her to put visco, but she already withdrawn the thing. So all the mistakes a trainee does, okay. So this was not scripted, it just happened, okay. So now I came in, I am sealing the rent. Some remembering the old video, there is a PC rent already there. I don't want things to drop. That is my most important thing. So I put viscode, seal that rent so that no further dropping happens into the vitreous cavity. Okay. So that is my first thing. So I put it so that nothing goes in. Now this is, I am dilating the pupil because this is very important. Unless you dilate the pupil, you can't do the surgery further on. You don't know what is underneath the iris. You just see just an adrenaline into the anterior chamber will open up the whole thing. Okay, now you have some hard nuclear material, epinucleus. Again, I push that part that's got a PC rent, I push it down. And since this was not planned for a foldable lens, this was in a community case. So we had planned anyway a rigid lens. So I had no qualms in opening this up to get this out. Otherwise, I would have probably removed this with the phaco probe itself with a lesser parameters. Since I had to open the wound, I slightly enlarged it, got the whole thing out. Okay. So now we need to, the vitreous has been disturbed, anterior hyaloid phase. So you do an anterior vitrectomy, remove the vitreous from the PC rent area and from the anterior chamber. Don't go too much into the vitreous cavity, remove the vitreous unnecessarily. Okay. So you can do a infusion and remove the vitreous, whatever is. So now IA. Can we do IA in this case? Now the PC is bare open. There is a PC rent, anterior hyaloid phase is open. Can we do IA? Yes. See, you cannot remove this thing with a single cannula aspiration because it's all stuck there to the capsule of fornix. If you can, you have done a good anterior vitrectomy, and if you can push the vitreous with a good viscoelastic, okay, and you enter with IA with lesser parameters, don't direct the infusion into the PC rent. And also quickly do a job, come back, again put visco, again go in. You can't be there because all the vitreous will again go away. You will try to, now the vitreous, see, very important is, you should never pull the vitreous. In an attempt to complete the surgery in that panic-stricken area time, you normally tend to, cross the line. That is the most important character of a surgeon. Because if you pull the vitreous, patient will have a, long-standing, retinal complications. So all these patients will end up with a peripheral break and retinal detachment later. Okay. So never touch the vitreous. Once you have done a good anterior vitrectomy, put viscode, push the PC rent down. I enter with lesser parameters, quickly remove a part, come out again, put visco again, enter on the other side. So this is a very, I am doing with a lot of caution. And if there's a vitreous trying to come in, I stop. Okay, I go to the other side and I always occlude the cortex. Okay, the port with the cortex. I don't go and just aspirate in the midair. Okay, and only this can, see, remove all the cortex. That is the most essential thing. If you got a PC rent, it is not okay to leave even a small speck of cortex. It will change. See, you can go deep into the cortex, away from the PC rent, and try to remove even the smallest amount of thing. Then only you will have a good result. Why I'm showing this is, if you have done a PC rent, still you don't have to have a suboptimal outcome. Okay, getting this cortex out, getting a capsule cleaned up is something very important. So now you put visco. Now you do eyeball implantation. You have an intact rexis. The piece is completely opened up. So anyway, I would have put a 3-piece foldable lens and done the capture like the previous case. Since it was a community case, I'm putting now we don't get 3-piece rigid lenses also. I had to put a single piece lens. So that's why I'm not capturing this. So now you see, I'm going with a vitrectomy probe underneath the IOL and trying to remove the visco. This is important. When you have pushed visco to form the AC, some visco will go into the vitreous cavity. They will all stay there. You don't go and remove it in the fear of getting the vitreous out. So you need to remove as much visco from the vitreous cavity because it will cause a raised IOP post-op. Okay, so you have to go in, try to remove as much visco from there as possible. You can't go and flush it up. You only can do vitrectomy, that's all. Constrict the pupil, and I've sutured it up.
And very importantly, on the table, I will always give a moxifloxacin intracameral. I was telling you in the morning or the endophthalmitis session, the one of the ways, I'm not saying the only way, one of the ways to prevent endophthalmitis is to introduce antibiotic into the anterior chamber. Because every cataract surgery, however clean it is, we always introduce bacteria into the eye. It can never be a sterile thing. Some bacteria, a small quantity, maybe saprophytic bacteria, maybe a virulent, or less virulent bacteria goes in. Our immunity and the hostile anterior chamber will take care of it. It will never proliferate to set up an infection. But if you introduce Bacillus cereus, if you put Pseudomonas, or the patient is immunocompromised, okay, you can still have an infection. If you have done a PCR like this, now imagine even so-called less virulent bacteria, even a smaller inoculum of the bacteria, now has a highway open to get into the vitreous cavity. So immediately it'll go to the vitreous cavity. There it's a safe haven for to set up an infection. So now the stakes are high. So you have to take every care. The only thing that you can do now, so no amount of systemic oral antibiotics will help. Nothing will enter the vitreous cavity in the MIC required to kill the bacteria. You have to give intraocular, that is intracameral. So intracameral moxifloxacin is very important on the table. Post-op, the patients will have corneal edema, maybe because of the excessive surgical time. Number two, patient will have a high IOP because you are not able to remove all the viscoelastic from all corners and nooks, especially what has gone into the vitreous cavity. So look for high IOP. And later, the inflammation will be high because the iris handling, tissue time handling is more. So maybe you need to put them on longer period of steroids. You have damaged the PC, the chances of all the inflammatory medias going downwards, back towards the macula to set up a CME post-op, not after 3-4 weeks, is a possibility. So always put the patient on nepafenac drops for a longer period, maybe for 2 months. Even steroids can be continued a little longer, but nepafenac at least twice a day is a must for at least 8 to 12 weeks so that you don't develop a CME. And in predisposed patients, slightly axial lens more than 25, always after a month get a posterior segment examination for peripheral breaks. Okay, so this is a very important thing. It is not important just to manage a post-op on the table, a PC rent on the table. What follows is probably more important so that you can make up for the mistake that happened, right? So all of us will have PC rents, but the way we manage will make a big difference. Okay, any questions you want to ask before I?
The identification of incident on intraoperative.
See, it depends on the stage. Okay, PC rent can happen right from hydro, procedure. So the moment you do a hydro procedure, okay, that's a very classical thing. No, when you push lot of fluid in a small eye, okay, or you do a small capsular axis, okay, you just push too much of fluid, or if the PC is already inherently, weak, you can tear the posterior capsule and the fluid will enter the anterior vitreous. So it will hydrate the anterior vitreous. In a jiffy, the whole lens will come forward. There will be a sudden shallowing of anterior chamber. Eye will be hard because you have introduced fluid into the vitreous cavity. It's like giving an intravitreal injection. So eye is hard, okay, soon after hydro procedure is a sure shot thing to say that you have damaged the PC. You have pupillary snaps and so many other things. But this is something very, very important. So only way is prevention. Do a small aliquots of fluid, very volitionally, very in a controlled manner, have a thinner cannula, give multiple sites, don't push too much force, and be very careful in the small rexes. Because in a small rexes, the fluid doesn't come out very easy because whatever you have put has to come out into the anterior chamber to decompress it. Okay, so that is also very important. So if that is the, because many a times what happens, eye is hard, is coming up, you push the lens, it will go back. Then eye will become okay. But you already torn the PC. For an unsuspecting surgeon, things will continue. But make sure here, if you see the lens is slightly at a lower level than before. That means since the PC is open, lens has slightly descended down. The moment you start doing a phaco or whatever, you will have the lens going down, right? So it's better rather to, even with the slightest suspicion, okay, you can open up and try to do a scleral tunnel and try to salvage the nucleus in a different way rather than to again pressurize the anterior chamber and push it down. So that is your initial thing. The most important part is when you are actually doing in a phacoemulsification, whether you are handling a nuclear pieces or during the IA. In fact, traditionally, historically, we always used to say IA has more PC rents compared to nucleus management. Various reasons, surgeon is relaxed, surgeon is not mindful and all that, and PC is bare open and all that. It's not necessary. Even we have done PC rents at all levels. So there's no difference, right? But only thing is, when you make a PC rent, what happens? This is for a postgraduate. The AC becomes deep because you open the PC, the things in the anterior chamber can start going slightly downward. So AC becomes deep. AC becomes irregularly deep because the vitreous makes a foray into the thing. So that vitreous is like a viscoelastic. It's a very ziddy viscoelastic. It can't be sucked. Okay, it is like a viscoelastic. Sometimes when you use a very highly viscous viscoelastic, we are confused whether it's vitreous or visco. They behave like that because they will cause pupillary distortion and things like that. So take it as vitreous, don't take it as visco otherwise. So AC becomes irregularly deep, and your aspiration stops because the vitreous comes and blocks your port, either a IA or whatever it does. The followability will stop. And sometimes you start seeing the light at the end of the tunnel. There is a posterior capsule and whatever, the epinucleus and the nuclear sheets. Normally, there is no retro glow right now. If you have made a chink and gone through it and reached the PC, along that, you actually start seeing the retro glow. So if you see light suddenly coming up in the middle of surgery, be careful. Okay. So the light at the end of the tunnel can be an oncoming train, right? So that is the next thing. You see a glow suddenly. So these are the things, or you can start seeing the actual PC rent with things going down also. IA, see, that's what, when you're doing IA, you should be very mindful, especially when you're, most of the IA problems happen not because of you're not being mindful. You don't set your parameters right. Okay. So usually there is even the trainee I showed, maybe you should not switch from the chop mode to the epinucleus mode. This can happen. The machine is only worth its parameters. Okay. So even if you take the best car and put it in first gear, it won't race. Similarly, whatever you have kept on the machine, it works that way. So if you have kept a 600 vacuum, you are trying to remove the epinucleus, it is actually full hurdy. So use that parameters very carefully. And IA, basically your parameters, the amount of fluid coming in, and sometimes there is a upthrust, lot of, maybe a block given into the eye, or patient is squeezing, or patient is doing a Valsalva maneuver, PC is coming forward. That's a very dangerous thing, that not enough fluid is going in, or there's a lot of leak. Your side ports are leaking, your main port is leaking. So then you have to probably increase the bottle height. Okay. That is very important. In other cases, you can increase the IOP in Centurion so that more fluid can come in, so that you have it deeper. So never do an IA unless the PC is concave. Never do it when it is convex. So that is and you actually start seeing the PC rent. So PC rent is like, Bhagwan. See, you don't normally see Bhagwan, but there's a problem, you start, Bhagwan comes into the field. You start remembering Bhagwan. So you see only PC when there's a rent. Otherwise, PC is not seen. It's translucent and transparent, right? So be watchful. And not all the time we can blame the postgraduate, because they may not be doing the best of, like this was operated on a Luxor Rivalia, one of the best microscope with the best retroillumination. Okay, so you may not be having the best microscope at that point of time. So your visibility, what you see, also matters, and what instrument you are using and your level of experience. So PC rents will happen, but by going through the discussions, going through the videos, and trying to understand, like trying to discuss your complications with your mentors, you can definitely make that incident to go down. So that is important. Anything else? See, patient wants vision. Patient wants vision. Okay, how you give it is your problem. See, most of the PC rents, I think you'll understand, most surgeons, we will be able to put an IOL. Unless I've planned for a multifocal toric or whatever, and I'm not able to put because of the PC rent. Very rarely, because we always have a three-piece alternative to put in the sulcus to optic capture with a slight modification of IOL power, we will be able to mostly do well. Okay. And second thing, PC, the thickness of PC is 4 microns, less than an RBC. Okay, which, bloody super specialist will work with a tissue of 4 microns, tell me, and still can do a good job? Tell me. We are working with the thinnest thing that is possible on earth in a surgical field, and you don't want it to tear. So PC rent is nothing to do with your, don't take it on your ego. It's very thin, right? So, and please understand, I always keep referring to, this is for a postgraduate to understand, cataract surgery is one of the most difficult surgeries. This is not a disparaging or a discouraging statement. You should understand the profoundness of this statement. It's a very difficult surgery across all surgical subspecialties. But you see Dr. Arup operating so well. Why? Because it in the numbers. If you were to do one cataract surgery in a year, which can happen in some medical colleges, okay, it is the most difficult. You'll never be able to do it well. Okay. See, why glaucoma surgery is so difficult? Why trab is so difficult? Because we don't do it that common. If I were to do 20 trabs a day, okay, I would have been a master at it. Right? But I do 20 cataracts a day. So even though it is technically challenging and it's the most unforgiving surgery, you cut the aorta, you can suture it. You cut the intestine, you can suture it. See, they can undo all those surgical problems in other specialties. Okay, they can always undo it. Once you tear the PC, can you stitch it up? No. So life will never be the same for the patient and the surgeon both. So it's a very unforgiving with a very less margin for error. Margin of error is so low. So it's a foolish to think that you can do a safe surgery at all times. The only thing, since we do this surgery multiple times, we have so many chances to go through this. Now we have mastered this so difficult surgery. You get this point? So don't trivialize cataract surgery. It is a specialty by itself, and it is the most rewarding surgery across all surgical subspecialties, the most commonly done surgery, and you should become an expert in that. And all these advances, all these talks, all these workshops, okay, are only, aiming at trying to scale your cataract surgery quality to the next level. So do put your heart and soul into understanding this cataract surgery to master all these difficult techniques. And making a PC rent, I don't have to tell the patient. Okay.
This PC rent, even it can occur like after removing cataract, when we are injecting visco.
Yes.
That
No,
time also.
no, even after putting IOL, it can split.
Especially when hydrophobic IOL.
See, it happens when the PC actually, the AC shallows. Okay, when there is a PC dehiscence or a PC weakness, if the PC comes forward like this, then it can tear. So always in such cases, keep the PC posterior by making it, always forming the AC. And it can happen. Anyway, if you have already put the IOL, you can still do it. You don't have to worry much about it.
Thank you, sir.
Thank you, sir.
Huh? Yeah.
Thank you, sir.
We request Dr. R.K. Ejiri, sir, to present a token of gratitude to Dr. Shri ma'am. We request Dr. R.K. Ejiri, sir, to present token of gratitude to Dr. Rohini ma'am. We have a small announcement to make. Please give us your valuable feedback for today's CME and wet lab workshop. The link for the same has been sent to you. Kindly take a screenshot of the Google form response We request you to show the response screenshot at the time of collecting certificates. I repeat, please give your valuable feedback for today's CME and wet lab workshop. The link for the same has been sent. The QR code has been displayed on the screen in front of you. Kindly take a screenshot of the Google form response and show the screenshot at the time of collecting certificates. The QR code has been displayed. Kindly fill the feedback response.
Glaucoma, the silent thief of sight, has a prevalence of approximately 1.2 to 3.1% among adults aged 40 years and above. With this, let's begin with our fifth session. I request Dr. Anupama Shadgar ma'am, Professor SN Medical College, Bagalkot, and Dr. Kaveri Patil ma'am, consultant at Anugraha Eye Hospital, Vijayapura, to come to the dais for chairing this session. I request Kaveri Patil ma'am to come to the dais for chairing this session.
This is only for the postgraduates. Okay, others can relax. How many postgraduates here? Okay, good. See, whenever we say glaucoma, okay, you should always ask a question, what glaucoma? Always ask the prefix. I keep telling in a lighter vein. So, when a baby is born, in the labor room, what is the first question the relatives ask? Boy or girl? It's a very elementary question which will change a lot of things in their life. Right? When they say baby is born, will they ask after 5 minutes, so what is it? They will immediately ask, boy or a girl, because that is very important. Similarly, when you say glaucoma, it is so elementary to make a diagnosis. Is it an open angle or an angle closure? Do you understand this? So when they deliver the baby, they will look at an appropriate place to know it's a boy or a girl. Right? The appropriate organ they see and they say. Similarly, in an eye, you see at the appropriate place the angle to look at. So gonioscopy is the way you distinguish between the two. Never assume looking at the anterior chamber depth, it's an open angle. Always, always, all postgraduates, make it a habit from today to diagnose glaucoma either as open angle or angle closure. It is elementary. Okay. You shake your heads, but it doesn't happen. I'm seeing for generations. So please start doing gonioscopy. If you don't have it, it just costs 3,000-4,000 rupees. Do a gonioscope, share it. Always try to do at least some within you finish your PG, at least do 250 gonioscopies. And don't do gonioscopy only in an AC shallow case. Do it in all cases. I have seen PGs have done whenever there's a AC shallow Van Herrick sort of what's also, they'll put a gonioscope to look for an angle. They would have never seen an open angle in their life. Please do gonioscopy in pseudophakic patients. Do gonioscopy in high myopes. You will see all that zebra crossing that you see, no? All Schwellbest line, trabecular meshwork, scleral spur, okay, including the peripheral role of iris. So you need to identify this. Go to gonioscopy.org. There's a YouTube lecture by Dr. Deepak Megura on gonioscopy. So please master gonioscopy so that you can answer this question, boy or girl. No, open angle or angle closure. Why? Because the treatment is so different. The treatment is so different. The life is different. All ACG, what is the one sentence, answer? How do you manage an ACG? One sentence answer, how you manage an ACG is do a PI. Treat the residual disease as OAG. For example, a patient comes uploadable angle. Is a PACS, primary angle closure suspect. You do a PI. Who knows? The whole glaucoma may get cured. then there's no residual disease, you don't have to do anything. A patient comes with a variable amount of synovial closure, pressures are high, maybe PAC or PACG, you do a PI. Even if the angle is closed, PI works. It opens up the spaces between the synechia. Your medication requirements will come down. Further pupillary blocks will stop. Many a times the whole glaucoma goes to a lesser degree. It becomes less severe. Okay. Then you look at the IOP. There is the still residual disease is there. The IOP has not come back to normal. That you treat like OAG. Maybe drops, maybe surgery or whatever. Right. So this PI is so in the center of our action. Okay. This PI is so important. If it's an OAG, we wouldn't do PI. If it's an ACG, PI may be the only thing that may be required. And if you think that you confuse an ACG for a OAG and don't do a PI, you are going to worsen the whole situation, make the patient, worse. Okay. You can put, if not a full stop, a comma for glaucoma in an ACG with a PI. So in that case, unless you diagnose it as ACG or OAG, you are making a mistake. Okay. Then the question comes about the suspects. Okay. See, normally, let us take both into one and try to look at the suspect. See, how do you suspect glaucoma in your OPD, in a busy OPD? Okay. You don't have to really do much. See, one is an IOP suspect. You do an NCT routinely. NCT is, let's say, 30-30 or 34-26, whatever. So there is an indication that the IOP is on the higher side. So what do you do? Okay. First, repeat the IOP. Do another NCT. You can do an applanation tonometry. First, establish accurately the IOP. And wherever possible, try to look for corneal thickness and correct it for corneal thickness. But believe me, only in the borderline group of patients, only in the borderline range of IOP, CCT is important. If the patient comes with 50 intraocular pressure, your CCT has no value. You understand? Even the thickest cornea cannot give a 50 as a false reading. How much thick it can be? It can be probably around 60 microns on this side, So hardly 3 or 4 millimeters of mercury can be the difference in a routine case, except in abnormal cases. So obviously, if the IOP is far away, let's say 40, 50, and IOP is digitally high, okay, your CCT is not the investigation of choice at that point of time. You may do it for completion, but that is not necessary. So establish the IOP is high, okay. Then you do a proper examination, okay. They do a comprehensive examination, including gonioscopy. Look at the angle, open or occludable. Look at the disc. So disc evaluation is everything. You should know that is, see, whatever is the IOP, IOP is the cause maybe. But what is the effect? It is the disc. IOP can be falsely high. Okay. Or patient may be having glaucoma when he comes to IOP may be low. That can vary. But the disc cannot cheat you. If you can see the disc and decide whether he has glaucoma or not, that is the effect. Right? So you should be well versed in trying to read the disc rather than break your head on IOP. Nowadays, what is happening is anybody can treat a glaucoma by prescribing a medication. You don't need a license. You do an NCT, pressure is 30, you can always start timolol or latanoprost or whatever without looking into anything. See, that is not it is. Please understand, glaucoma is a very slow disease. It runs for months and years before something can happen. It's a very slow disease. So you don't have to treat the patient unless you're very, very sure it is a progressive glaucoma. For example, you all learn about NTG. NTG is a primary open angle glaucoma subset where the pressures are always within the statistical normal range. Okay, but a progressive glaucomatous optic neuropathy. That is the definition. Okay, so you see pressures are 16, 12, 14, and there's a disc damage. You do a perimetry, there's a biarcade scotoma. That is not NTG. That is a snapshot. What is the definition of NTG? It's a progressive glaucomatous optic neuropathy. Where have you documented progression? Maybe for next 10 years, 20 years, 30 years, this may be the same fields. With the same IOP, the same fields can continue. There's no progression. So you can't diagnose NTG in one visit. It is probably a burnt out glaucoma patient, used steroids, there was high IOP, he had a damage, his top steroid pressure came back to normal. Maybe a pigmentary glaucoma burnt out. Maybe a post-op surgery, there was high pressure burnt out. So it may be a burnt out glaucoma, may not be a progressive glaucoma, right? So that's why exercise caution in not starting treatment. Never start treatment. In doubt, always postpone. I would rather start treatment in the next visit than this visit, even though the IOP is high, if I'm not convinced. Okay. But when you have an high IOP, just look at the disc. If the disc is seemingly normal, then you have won the game. If disc is normal, nothing to worry. Let there be any high IOP, don't bother. Because the effect has not happened. Right? So that is what is important. If the disc is normal, you can keep it normal with your efforts. If the disc is already showing glaucomatous damage, the damage is already done. So look at the disc, evaluate the disc, and always a good dilated, a three-dimensional examination of the biomicroscopy of the disc is extremely important. Learn the most important. CD ratio is least important in estimating the disc damage. CD ratio depends on the size of the L-shaped canal. See, all the fibers from the ganglionic cells, axons, have to leave the eye. So they come all over the retina, converge at one point. There is a gap in the sclera. They all take a 90-degree bend and become the optic nerve. That gap in the sclera is called L-shaped canal. That is your optic disc. If I have a big gap in the sclera, my L-shaped canal is big, my disc is big, all that fibers, 1.2 million axons, will be at the periphery. There will be a large gap in the center with a large cup. I will have a CD ratio of 0.8 or 0.9 with normal number of axons. So I may be a perfectly normal patient with 0.9 cup because my disc size is big. So don't take CD ratio alone. If you want to take CD ratio, always have a correlation to the disc size. Try to estimate the disc size. See, on a slit lamp, you have 1, 2, 3 circular rings. Very simple. So put the 2 millimeter circular ring next to the disc and compare the size. Is it less than 2, more than 2? If it is more than 2, definitely it's a big disc. So then your CD ratio becoming higher doesn't really matter. And do a perimetry. Don't do a 24-2. Try to do a 30-2. If possible, do a fill threshold, not a CETA standard. Don't take the first value, first printout as the normal, unless the patient is extremely cooperative and intelligent. Take the second reading or the second printout. Okay. So then establish a baseline perimetry. Okay. The baseline perimetry is normal. This seems seemingly normal. IOP is consistently high, CCT corrected by applanation on various visits. Different times of the same day, different days of the month. Okay. You can establish that IOP for next 2-3 months, only call him and check IOP at different times, different days. Don't treat him because distant fields are normal. If it is consistently high, then we call him as ocular hypertensive. Ocular hypertensives need not be treated. Ocular hypertension treatment study showed for 5 years, not treating the patient, okay, hardly less than 10% of people progress to POAG. Progression means first black dot on the perimetry, not blindness. That means even after not treating for 5 years, 90% were keeping fine, status quo. So you don't have to treat a ocular hypertensive unless he is a one-eyed patient, lost the other eye due to glaucoma, has some kind of a ethnic predisposition like black race, or at least he has some kind of a pigment dispersion or a PXF or some kind of a ocular predisposition, or a thin cornea, or a larger CD ratio, vertical CD ratio, or he has some hemodynamic crisis like hypertension, diabetes, and hyperlipidemia, and all such things. Okay, so you don't have to treat ocular hypertensives. Okay, so IOP suspects, you can sit over them. Disc suspects is the next thing. IOP is normal, disc is large, CD ratio is high. Here comes your examination technique. Please examine the disc, look for the neuroretinal rim. Is there an excavation? Is there a narrowing? Is there a shallow, is there a polar notching? Look at the peripapillary atrophies, look at those signs, which shows it's a glucomatous disc. A lot of high myopic discs can be, or tilted disc can look like a glucomatous disc. Okay. Don't do OCT as a method of trying to find it out. In a disc, in a glucomatous, in a tilted disc, your OCT RNFL will be going really, it will be abnormal, even in a normal cases. Okay. Do a perimetry to establish a correlation between the disc size or the disc damage and the perimetry. If you have an inferior polar notch, you also have an inferior arcade scotoma, they don't match. Okay, you should have a superior arcade. So it should be matching corresponding field effects. So when you have a disc damage, if IOP is normal, many things can be there. Maybe the patient's corneal thickness is low, maybe you're not checking it right, maybe patient is on beta blocker systemic, or maybe it's a burnt out glaucoma, or maybe it may be a normal tension glaucoma if you show progression over a period of time. Okay, so it suffices to say that in case of glaucoma, exercise caution, no need to treat immediately. Always the disc is more important than anything else, disc examination. IOP needs to be qualified. Don't treat the IOP in the first place, because if you start treatment, what is happening nowadays is, I'll start treatment. The IOP is normal, otherwise, but I've started treatment. You'll go to a doctor, IOP is checked, he says continue same treatment. Another doctor, IOP is normal. So somebody has to stop the medication and check, no? The washout period is hardly 3 to 4 weeks. Somebody has to do that to say your IOP is normal, even otherwise. Okay, so that is the problem of starting treatment. And don't brand people as, but there is a lot of glaucoma in the community. Don't take it otherwise. But at the same time, on the other extreme, we have a lot of patients who are treated on spurious grounds, just on, with insufficient data. The same patient may require a glaucoma treatment after 1 month, 1 year. That's a different issue. But right now, he may not require treatment. Make sure that you explain the disease. Patient complaints, follow-ups are very important. And in case the patient is not coming down or patient is not, then we do sometimes cross the line. For example, a PI in an ACG suspect or a PACS, the patient is not able to come back to us. We may do a PI out of turn just to make sure that he doesn't, get the disadvantage of a non-follow. Okay, so thank you so much.
Thank you, sir, for the wonderful session.
Questions from PGs only. Okay, ask one question. No, since she asked any question, that was the question she asked. Any question? Question mark. So that should be answered. No, she asked a question. Any questions was the question.
How many days it may take for the higher IOP to produce a disc change?
So it depends on what is the level of the disc, what is the level of the IOP. Sometimes the IOP goes so high, okay, if there's a sudden elevation of IOP, it causes two things. It causes symptoms. See, have you seen a lens-induced glaucoma will come with severe pain, autonomic symptoms, vomiting, pain, headache, with pressures only 45. But you get next time you get another patient, pressure is 60, he's having absolute glaucoma for last 10 years, pressure is 60, patient is very comfortable. Only acute elevation is symptomatic. Okay. So just because the patient is having 60 IOP, you don't have to give him a mannitol. Right? Patient symptoms, there's not an acute elevation. So when you elevate the IOP acutely, disc cupping will not happen. It will cause more of a disc pallor. Okay. Disc cupping is a kind of a vascular and mechanical combined theory where there's a bend of these axons, the intraocular pressure presses the axons, and that causes an axoplasmic stasis. There's a retrograde degeneration of retinal ganglionic cells, and one ganglionic cell dies, it produces certain inflammatory mediators which will damage the surrounding retinal ganglia. This happens for so long, there is a concentric enlargement of the disc damage. It will take several months for a sustained IOP rise. Okay, it is not immediate. If you have cupping, then it is a sustained IOP rise. If you have disc pallor, for example, there's a patient who has a very high IOP for next 1 week and you treat the problem, you don't have disc cupping then. This cupping takes some time to happen, but it depends on duration as well as the IOP elevation. Sudden peak and coming down will not cause disc cupping, because the mechanism is totally different. See, IOP rise following a cataract surgery and you're expecting a pigment dispersion. See, sometimes the IOL is in touching the moving parts of the eye, or in a kind of a plateau iris where the posterior bowing of the pigment epithelium of the iris keeps on rubbing on the IOL surface or the haptic even. That's why we don't put a single piece lens in the sulcus. Okay, the haptic junction will rub the mid-peripheral iris. They keep producing the thing. And it's a long process. It will not happen in 2-3 days or a week. It will take several weeks of, IOL, the pigment, every time the iris moves, there's a pigment dispersion which goes and blocks the trabecular meshwork. So you will have signs of pigment dispersion, pigmented trabecular meshwork, and all those things, Sampolisis line and all that, and IOP gradually elevating. So in such patients, clinically also you can see it on the slit lamp sometimes. And ASOCT, UBM is the best thing to know the thing. UBM, you can pick up the posterior peripheral iris touching the haptic optic junction.
We request Dr. Narsapur sir to present a token of gratitude to Dr. Anupama Shadkar ma'am. We request Dr. Narsapur sir to present a token of gratitude to Dr. Kaveri Patil ma'am.
Thank you, everyone. All the sessions for today are now concluded. We would appreciate it if anyone among the delegates would like to say a few words.
Good afternoon, everyone. So I am Dr. Vinayak. I'm a fellow in Joshi Eye Hospital in Hubli right now. So what I want to say about this CME is that, first of all, I'm very thankful to the entire team of BLD University, and I would like to congratulate them for conducting this event in a very well organized manner. And as a fellow, I understand that what all postgraduates feel about operating a cataract surgery and what challenges they face. So I'm pretty sure that this CME would have cleared a lot of doubts for them, would have made a stronger foundation for them, and would have helped them learn better and understand the principles, how it works, and what better they can do next time when they go to operate a case. And also, when we get to learn from faculties like Arup sir, KP sir, and Sanjeev sir, they not only teach us academics, they not only teach us what we read in the books, but they talk from their experience, which is way more than even my age. Like sir said, he started doing SICS in 1992. I was not even born by that time. So this huge vast experience, when they talk and when we learn from this, so it gives us a very good opportunity to learn. And so I'm very thankful for this CME that it happened and we could get a chance to attend it. And I'm pretty sure I'm speaking behalf of all the postgraduates who must have felt the same way. And so that's what I wanted to say. Thanks a lot.
Would anyone else like to share their thoughts? Any feedback for the wet lab workshop which was conducted today? Still going on.
So we have come to the end of the CME. How the day passed, we could not feel only. I like to thank our guest faculty mainly. Dr. Arup Chakravarti has come all the way, spending whole day in traveling, and he has given us a very good deliberations where all of us are the tips and with evidence he has given. Every talk, every slide, there was an article. You must have noticed that he has quoted the article and he's given his experience and the statistics. So I think it will be very helpful for all the consultants and the postgraduates. I thank you, sir, for making this event very successful. I also thank our Dr. Krishna Prasad. He is our almost like our host only. We did not feel that he's from this college only. We were feeling, and he's among our faculty only. I was feeling it, and also making Dr. Arup more comfortable to come to this remote area of Vijayapura and also charting out all the deliberations and the talks which is done by the Krishna Prasad sir only. What is needed for the young ophthalmologists and also to the practicing consultants. Thank you, sir. I thank Dr. Sanjay. He's for the talk of the low visual aids, which we don't treat, and our postgraduate has to write a 20 marks long question for that, and on the table viva, they have to answer on that. For every case of posterior segment, we will be asking about the low vision aids. Thank you for coming and giving a lecture. And the best part of the success of this CME is the number of delegates who have enrolled. It is crossed 110. So 50 postgraduates and 62 consultants from all over. They have come from Sangli and Sholapur. Madam has come from Sholapur and nearby Medical College, Bagalkot, Anugrah Institute, and all the places they have come, and Shilpa from practicing at Bagalkot, private practitioners have come, and even from Belgaum, Dr. Harkoni and Anand. So that made it a very successful because of this good number who have taken advantage of this CME. And next, I want to thank our most important is my IT department. From 1 week, we were struggling for this hall to do that YouTube and all this arrangement. Nobody had done a CME like this. I think our other faculties, we were doing to the telecasting to the other hall and the hands-on that also be projected, and this talk has to be projected and the YouTube. Thank you, Dr. Anand and Mr. Anand and his team. And next, I want to thank my colleagues. They have also worked hard, each one of us, up to the SAS, everybody like registration, they are sorting out the registrations, in sending the informations and everything. And my PGs headed by Arka, I can say, because everywhere where I go, I was taking him for every small point of the work. And also my departmental staff, the clerk, and everybody has helped for this success of this CME. I once again thank everyone for gracing this CME for whole day. And I hope the faculty, Dr. Arup, Dr. Krishna Prasad and Sanjay will be, once again, they'll be coming to us and giving the deliberations. Thank you, and all.
This is purely non-academic stuff. See, I mean, I was just mentioning that in the course of the day, I got an SMS, and this happens. This sort of messages come to me very frequently. It said, "Sir, it is a very silly question, but my fellows want to know what is the maximum amount of OVD that can be injected into the eye before an iris prolapse occurs." So he is from Bangladesh. There's a hospital called. We are offline, right? Yeah, yeah. So he was from Islamia Isfahani.
Sir, you want? We can talk, sir.